Hello, hello, check, hello, hello, check, hello, hello.
This is the tomorrow this session, second day of Indapur 2 conference. We are going to start now. The agreed person for this session, Joshi sir. Good morning everyone. Second day of Indapur 2 conference. The huge success of yesterday, the first day, including the banquet, we started second day a little bit late. It's okay. So first lecture for today's Indacon 2 CME conference is by Dr. Mahesh R. He is consultant nephrologist and transplant physician. He's done his MBBS from BJ Medical College, Pune, DNB nephrology from Gujarat, then fellowship in International Society of Peritoneal Dialysis. He has a special interest in acute kidney injury, dialysis and renal transplant, working with Vishwara's Hospital as a consultant since last 7 years. So please welcome Dr. Mahesh Rokde. His topic will be renal transplant.
Good morning, everybody. On behalf of Indian Medical Association, I welcome all delegates for day 2 session. Thank you.
So, chairpersons for the first session, may I invite Dr. Magar sir to please chair the session, and our president, Dr. Anil Punde sir, Sukla, please come on the dais and chair the session. The topic for first topic for today's session is by Dr. Umesh Nagre. He is MBBS MS MR. He is hello. It's, Dr. Umesh Nagre. He is MBBS MS MRCS FRCS UK and FRCS TR and Ortho. Dr. Umesh Nagre graduated from BJ Medical College in 1998 and postgraduate from the same institute in 2002. He subsequently went to UK for FRCS in Queen's Medical Centre, Nottingham. He received Queen's Award and later joined South West Thames Orthopedic Specialist Registrar in St. Thomas Hospital, London. He completed his MRCS in General Surgery from Royal College of Surgeons, England, London. He then completed FRCS Orthopedics. He has delivered many lectures on computer navigation, total knee replacement, severe varus and valgus deformities. Dr. Nagre currently performs joint replacement surgery at Dinanath Mangeshkar and Sri Saraswati Hospital and Vishwaraj Hospital. So may I please welcome Dr. Umesh Nagre to deliver his lecture on robotic TKR. Please welcome Dr. Umesh Nagre.
Good morning, everyone. I'm Dr. Umesh Nagre. I'm working as a head of the department and joint replacement in Vishwaraj Hospital and Saraswati Hospital, which is the new one which is coming in Kothurud. And I want to talk about the joint replacement, robotics in arthroplasty. So it's better to be the interactive. So if you have any doubts, please ask. You can stop me anywhere, okay? So there is no problem. So first thing I want to thank INDACON for inviting me and giving me opportunity to share my experience about the robotics. So I have seen the era where I got trained into the conventional joint replacement, going towards the navigation, going towards the GPS, then robotic, which is the recent one, and how the whole specialty has evolved. So we will just go through that. So over the following decades, you know about the Da Vinci. Da Vinci is this robotic platform where I can sit remotely and I can do the surgery without being at the place. Suppose there is a patient in the Indapur, I can sit in Pune and do the surgery. So that platform they have created. And this enabled the variety of the surgical procedures to be performed remotely using the robotic control arms. So initially they started with the cholecystectomy, then even renal transplant, hepatic transplant, then prostatectomy, bypass grafting. So how it came to the joint replacement side. So total joint replacement which is happening in India right now is more than 90,000 per year. The number is from the IJR, Indian Joint Registry, but most of the numbers are not entered. Most of the people, not everybody enters the number, so number is bigger than this. So implant survivorship assess with the revision as a primary endpoint, which is greater than 90% 10-year follow-up. So if any person coming for revision surgery, we take failure as after 10 years as an endpoint. But if you see the satisfaction of the patients, so for knee replacement, hip replacement patient satisfaction is better than the knee replacement over the period. So 20% of the patients of the cohort of a knee replacement, they are still satisfied. So if you do the well performed, this is I told you, like old style where we got trained, and the joint replacement, the aim is like to do the replacement where your mechanical axis, which is a hip center, knee center and ankle center, should come in one line. That's the way you take the cuts, that's the way you use the implants. So well performed TK give a good function, implant stability and long-term implant survivorship, which is the most important thing. Any patient comes to you, they will ask you how long it is going to last. So if you do all these things properly, it will last long. Then the surgeon control variables are like accurate implant positioning, balance, flexion extension gap and proper ligament tensioning. So this is in our hand. So if I do the job properly, then patient is going to get the results. So it's not only the implant factor. I always tell people, like patient, if any implant is failing, there are three factors are there. First is a surgeon factor, second is implant factor and third is patient factor. So starting from the third, some of the patient they don't do the proper exercise. Second is, if the surgeon is not doing his job very well, any best implant in the world is going to fail, because if you don't match this axis, it's going to fail. So what we train, we call this as a conventional jigs. So we use a pre-operative radiographs. I will take the radiographs, I will check the angles, I will plan my surgery before I start the surgery, and I take the cuts accordingly by using the manual knee replacement, which is happening for last how many years now? Like because robotics started in 2019, but conventional patients which have been done in the all over world, they are still lasting long, and all the patients are doing very well. So we cannot avoid conventional and just jump to the robotic. That's why I want to mention here. So reproducibility of the alignment guide positioning is different between the patients, between the surgeons. Then there is a limited intraoperative data. This is the biggest advantage of the robotic. So whatever cuts I am planning, so I can give that data to the patient. See, pre-operatively, this was your graph. I have done the replacement, I have corrected the deformity, and this is the post-operative graft. So patient can get those results by doing the robotics. So if you don't do the job properly, whether it's a robotic or whether it's a conventional surgery, your surgery is going to fail. Implant is going to fail, surgery is going to fail, and patient will land up into the deformed X-ray. This is completely deformed X-ray. There will be increased instability and obviously the reduced implant survivorship. So as I mentioned, the robotic came in 1980. So it was designed and it was planned on a veterinary, on the animals first. And in the first robo was a RoboDoc, which came in 1986. So after 1986, the first replacement which was done with the robotic was 1992 in California. So how it works? Robotic arthroplasty uses the computer software to convert the anatomical information into the virtual patient-specific 3D reconstruction of the joint. So I take the CT scan of the patient. So after taking the CT scan, I get the complete information, 3D picture of the knee or hip. So that guides me what will be the size of my implant, what will be size, suppose I am doing the hip replacement, what will be size of my cup, acetabular cup, or the stem which I am going to use for the hip replacement. It guides me. So anatomical information is generated through the CT, and surgeon uses this virtual model to plan the bone resection and implant positioning, bone coverage, and limb alignment. As I mentioned, we can do, and I can do the changes intraoperatively. If I find that, see, conventional, what happened? If I decided to take the 5-degree cut during the surgery, I will take the 5-degree. But intraoperatively, if I am using the robo, what it guides me, it will tell me that no, this cut is, you can take 4 degrees, or you can even take 7 degrees also. That manipulation I can still do while planning during the surgery before I take the cuts. So eventually it gives the improved implant position and alignment, soft tissue balancing, avoidance of the bone and soft tissue injury, and it gives the better function results. Obviously, outcomes are given in the literature. The most important thing is how you take the literature. You know that whether it's ophthalmology or joint replacement or any branch, you always look for the good results to promote your studies. So there are the failures also, you have to go through the failures, and it's too early to say that the robotic is the way ahead. Is it going to stay in the market? Yes, it's going to stay in the market, because in general surgery, in gynec, everywhere the robotics is coming now. AI is there now, because we are giving the lectures on the ortho AI now. So other studies, there are lots of studies which I have compared. Even in Dinanath, I work in Dinanath also. So we have done the study non-robotic, like conventional patient done, and the patient done with the robotic. So we didn't find any improvement or any change in the functional results after 6 months. So earlier complications, as I mentioned, there is a superficial infections, chances are there, patellar tendon rupture, dislocation, supracondylar fractures can happen, because I have to use the pins to fix my guides, and there is the chances of the peroneal nerve injury also. So there are lots of new data are coming. Obviously, as I mentioned, robotic, I get the data and I can preserve my data, I can recollect the data and do the studies. what difference is making in my practice, or if I am designing any implant, it helps me to design the implant also. So there are 3 types of robots are there: image based, imageless, or imageless, then passive, semi-active or active system, and open or closed resources. So when you classify this, there is passive, active, interactive, or teleoperated. Teleoperated is, as I mentioned, Da Vinci, where you can sit remotely and do the surgery. So passive system, it consists of the articulated arm which hold the instrument moved manually by the surgeon, and with the instrument positioning being recognized by the navigation system. So the best example for this is the Omnio. In active system, we have the RoboDoc or the QVs, where we uses a preoperative and intraoperative planning data to perform the multiple cuts. In interactive system, there is a surgeon between there is interaction between the surgeon and robo, and patient is like an interface. So I am interacting using the patient data to have an interface between me and the robo, and then plan my cuts. So which is known as the haptic model, where the robot is generating the forces, where the amplitude of the and the end frequency reproduce the true sensations. So this is teleoperated, which I mentioned, Da Vinci, that somebody is sitting remotely and doing the surgery. So the first one was RoboDoc in 1986. First robotic knee replacement done. Then it's based on the CT scan, and this is an open platform. Open platform means I can use this RoboDoc and I can use any implant, irrespective of the company. It doesn't matter whether I'm using Zimmer or any Indian company or any foreign company. So then there was a change to the Omni Life Sciences. They started with the IB log in 2010. So this is also CT based, so you have to take the CT scan first, but it doesn't provide the gap balancing. So what happened? Obviously it's a market driven practices. So the companies, all these implant producing company in US, they have decided to produce they have seen the market and they have decided to go ahead with the robo. So every company, in bracket the company name is there and what their robo name is there. So Mako belongs to Stryker, Navio belongs to Smith & Nephew, Rosa belongs to Zimmer. So if I choose any of this system, I have to use that particular implant only. I cannot use any implant. So my hands are tied. So I cannot use any of the implants. So I will show you the pictures. This is the Mako system which we use in Dinanath Mangeshkar, which is a closed platform. You need CT and it's a saw-based system. So I had to use a cutting saw to use to cut the bone. So Navio is a semi-active system. It gives we have to use a burr. So there is no saw involved. It's a burr is there and with burr cuts the bone. So I do the planning first. I provide the information to the robo. Robo will assess the cuts. I have to authorize those cuts. See, main thing I want to mention here, everybody is giving the lecture on robo or joint replacement, but main thing is you cannot avoid the information provided by us. So if I make an error, it's going to take the wrong cuts. So the human interfaces hasn't gone out of the practice yet, and it will not go because I have to provide the information. Accordingly, the robo will take the cuts. So next one is Rosa, which is a Zimmer and Biomet. It's an interactive, it's an imageless, and it's closed platform. Means I have to use Zimmer implant. This is QEs by the Merrill. So this is also CT based, and it's a burr system. And in Vishwaraj we have this Velis, which is a where you saw. It's an interactive between the robo and the surgeon, and it's imageless system and table mounted. It's always close to the patient. So if you see the comparison here, Mako, Navio, Rosa, so most of the system are CT based, but the Velis, this one, what we have in Vishwaraj now, it doesn't require the CT scan. Patient comes, I don't need to do any specific investigation for the patient. Patient come on a table, I will put my jigs and I will provide the information. I will take the, I will do the pointing on the patient's knee. It will get calculated by the robo, and then I will authorize that those readings, and then I start taking the cuts. So this is the one which we have right now, which is the 4th generation latest technology robo, Velis. And the implant which will be used with this is a Attune implant, which has the US FDA since so many years now, since 2013. So obviously, what are the good things about it is surgeon control, which is the most important thing. See, there are some robots are there in the market which doesn't have any control. So I provide the information, CT scans are there, they will calculate the whole 3D model and it will start cutting the bones. What is the problem with that? I don't have any control on those robots. If he's taking the wrong cuts, it will just go ahead and take the wrong cut because it's a machine. Machine doesn't understand there is no human interface. So that's the reason as a surgeon I would like to have the control on my saw. So take the cuts, have a saw in my hand, and then I know that if I'm going wrong, I will just step back and I will go back and do my analysis again. So the second thing is it's not a CT based. Third thing is the compact and is attached to the patient's table. The recovery is very fast with the patient. So it's a saw based system, highly adaptive camera is there which provides the information. Third one is my planning window, which is the easy and better planning. So there I can decide about the cuts, there I decide about the rotations, there I decide about the what implant size I am going to use and what is the compatibility of that implant also. The last is well balanced knee, that there is a tensor is there. See, joint replacement is not only the bone cutting surgery. So my ligaments are there, everybody knows that there are ligaments around the knee. So when there is a deformity is there, suppose there is a varus deformity where the leg is completely deformed. So your ligament on the outer side of the knee are stretched out and on inner side are contracted. So I have to make sure that those ligaments are balanced before I plan my femoral cut. So I have taken the tibial cut, I put the tensor inside, which is on the last slide here, and that shows that the tensor will tense the ligament and then I will take my cuts. So obviously why we decided to go ahead with this, I can do the 4 to 6 cases per day using a robo. Normally I do 6 just conventional methods. No preparation required before the surgery. If the patient decide last minute, doctor I want to go with the robotic, I don't want conventional, I can change, or other way also, ready for robotic and then don't want to conventional. So any surgeon who is doing the robotic has to be very good in conventional techniques, because they should understand, see, system can fail anytime. You've seen this. What you call that, the projector was completely off for a second. So if you get stuck up with that, then you will not able to do the surgery. So even patient outcome, we have seen that there is a lower pain, the lower soft tissue release we do, and there is a precise cuts for the implant placement. So obviously there is a differences between the systems available are there. At present I am well versed with the Striker and the Velis. So Striker definitely I am using in Dinanath Mangeshkar, and Velis we are using in Vishwaraj. So Striker is definitely CT based, and for this there is always a learning curve. So coming to conclusion, so our priority is improving the patient's outcome and their satisfaction. That's our priority, whether you use robo, whether you don't use robo, whether you do conventional surgery. The main factor is you have to make sure that when you are doing the knee replacement, your hip center, knee center and your ankle center should come in one line. If you don't do that, it's going to fail. So that's the reason I told you, as a surgeon you should know your principles. So basic principle doesn't change. So that's the reason I was giving the example. It's like a laptop, purchasing a MacBook and having a basic laptop of the HP. So if you are good, you can still give the best presentation on the HP laptop. If you are bad, you cannot give the best presentation on the, even if you have the MacBook also, okay? So just 5 minutes, I'm done. So while early robotic systems have failed to confer any meaningful clinical benefits and justify the excess cost, this is a major problem in India, because obviously when I use robo, we have to charge the patient. So as there is a competition now, the robo which are available in the market for 7 crores, which is coming down to the 4 CR, 5 CR now, because of the competition, and lots of people are purchasing. But neurorobotic adjustment have demonstrated the promise by minimizing the soft tissue damage and reducing the hospital stay. Obviously, as any hospital, whether it's your private small setup where you are doing the joint replacement or a big setup, patient hospital stay obviously matters. So that hospital stay cuts down, patient goes home early. Like if the normal conventional patient with the knee replacement goes like 7 days, then this robotic will go on 3rd day. The reason behind that, I don't open the femoral canal or tibial canal. when I take my bone cuts, and obviously that pain factor is there. The last slide, however, the economic impact, as I mentioned, is always there, which patient has to bear. This is essentially important as conventional TK is already considered as a reasonably successful surgery than this expensive procedure. Already the TKR or THR, they are expensive because of the implant prices. So, and we are adding the robotics also, but obviously the robotic has a good result from the point of view that patient satisfaction is good, their results are good. If you know the system very well, that's most important thing. And as I mentioned, your conventional training or your principles of the knee replacement doesn't change. It will remain same, whether you use robo, whether you don't use robo. And obviously, from the company point of view, what has changed? Initially, they used to carry lots of trays because I don't know what size it will be, whether it's a size 2, size 5, permutation combination, they have to carry all the femurs, lots of trays. But with the robo, this thing has gone down. I can plan my surgery before the day before the surgery, and I can tell them that, okay, keep size 5, keep size 4, one size up and down. So they will not autoclave everything. So the early results from the latest generation of the robotic TK hopefully justify the ongoing investment in such technology. Definitely we have invested. I have to prove that it's a worth investment by doing the good work and by doing the good surgeries and utilizing this for the patients who require robotic surgery. So this is very important thing that every Tom and Dick and Harry that doesn't need a robotic surgery. So you have to choose your patients wisely. That's very important thing. Severe varus deformity where the bowing is like 30-40 degree, you have to go with the conventional because you are changing your cuts, you are changing your plans. So that in those cases you have to change the things and you have to do the manipulation accordingly. So long-term functional outcome and survivorship should be fully appraised to support its continued use. And these are my references for my slides. Thank you very much.
Thank you, thank you, sir. From package point of view, is there any difference in conventional?
It will increase. Yeah, the package will increase from 25 to 40,000 per knee per hip, while using the robo.
Okay.
Because see, the problem is that it's not using the robo. The whole material comes with it, like disposables and everything. That adds the cost.
हॅलो उमेश, आमच्या डॉक्टरांनी पेशंटला काय सल्ला द्यावा की कन्व्हेन्शन करा, रोबोटिक करा, रोबोटिक असं तर कुठल्या रोबोने करायचं आणि कुठं करायचं?
सी माय सजेशन इज, माझं एकच सांगणं आहे की रोबोटिक नॉन रोबोटिक कसं आहे, इट्स अ मार्केटिंग गिमिक. सिंपल गोष्ट आहे एक ते. तर पेशंटला मी नेहमी सांगतो, तुम्हाला गरज असेल तर लेट मी एक्झामिन यू. सिंपल थिंग, पेशंट कम्स टू युअर क्लिनिक अँड पेशंट टेक आउट द स्कॅन फर्स्ट. मी त्याला ते सांगतो, अरे मला तुला बघू दे क्लिनिकली, मला तुला लेट मी डिसाइड. दॅट शुड बी माय डिसिजन वेदर यू नीड अ रोबो और नॉट. So that's the reason in even Dinanath or Vishwaraj, I don't force the patient to have a robotic surgery. I tell them these are the advantages, you choose. Because see, they should buy the surgery. I always tell people, knee replacement, hip replacement, patient should buy the surgery. Buy the surgery means they should come to you and they should ask you, डॉक्टर माझा गुडघा खूप दुखायला लागलाय, माझ्या आई वडिलांचं ऑपरेशन करायचं आहे, आईचं किंवा वडिलांचं. So let them decide about that. Second thing is, my indication for the any hip replacement or knee replacement still today is night pain. जर पेशंटची झोप जर मोडत असेल रात्री, की डॉक्टर मला रात्री माझ्या आईची झोप मोडते, कूस बदलताना दुखायला लागतं तिला, वॉकिंग डिस्टन्स कमी झालं आहे तिचं, सो दॅट इज अ इंडिकेशन. थर्ड थिंग इज, आफ्टर कोविड यू ऑल आर सीइंग लॉट्स ऑफ youngsters are coming with the bilateral avian hips. So in those patients I conserve them for like a quite a long period. The reason behind that, I know that if I do the hip replacement right now, it's good for me financially and for the hospital also, but I am burning out my bridges, because that hip replacement will last for 20-25 years maximum. Suppose he is 25-year-old, he is 50 year, he will come for the revision, first revision, that revision will last for 15 years. At the 70 he will come for third revision. So I am just burning out my bridges. So give them hydrotherapy, give them alendronate, like bisphosphonate, give them ecosprin. That works very well. So these are the things you should discuss with the patient. So let's discuss, sit down and discuss about the management option. So conservative management and surgery. So if this happens, we'll go for surgery. In hip replacement, if the shortening of the leg is there, night pain is there, they started limping around, their walking distance has gone down, night pain, they should go for surgery. Because already there is a collapse has started now. But if there is no collapse, don't go, put them for the surgery. Any other questions?
Thank you, sir.
Thank you, sir.
Thank you.
May I request Dr. Deshmukh, sir, to felicitate Dr. Umesh Nagre, sir. Thank you, sir. Thank you. Thank you very much, sir. Our next session, the speaker is Dr. Squadron Leader Akhileshwar Singh. He is male and female fertility consultant, managing committee member of Indian Fertility Society, Western Maharashtra chapter. His experienced endoscopic surgeon trained into the complex laparoscopic and heteroscopic surgeries. His alumnus from the prestigious Institute Armed Force Medical College, Pune. He's done his MBBS, MS, DNB, fellow in MGS and trained in IFF. He's an assistant professor at CPS, Mumbai. He has a significant experience in handling high-risk obstetric cases. He's life member of IFS, ISAR, FOGSI and IMA. He has special interest in research and new advances in field. So please welcome Dr. Squadron Leader Akhileshwar Singh for his topic, male and female infertility. Thank you.
Good afternoon, everyone. Good morning, everyone. So today I was given the topic at a very short notice about male and female infertility both. So that is my whole department. So that I couldn't be discussing in just 15-20 minutes. So I decided to speak on the evaluation of a male infertile out of the couple. So it will be short also, and I just want to speak about the basics, what should be done at the periphery and what should not be done routinely at the periphery. So male evaluation, like how much responsible are the male factor in any infertility? So around 30% of infertile couples contributes to another 30 to 40% of all the couples, all the infertility. Then it may be present. So occupational health history is very important in those patients where semen analysis is already normal, all the parameters are normal, but still the male infertility is there, including the DFI, means DNA fragmentation index, and other things I will be discussing about. And it's equally important in primary as well as secondary infertility. So sometimes the males think that the first pregnancy has happened, so there is no role of evaluation of that male in if they are having secondary infertility. But still some factors are there. One of them is age, where the male again has to be evaluated if they are suffering from secondary infertility. So what are the goals of evaluation of any male during male infertility? So first of all, we have to identify and correction of any of the causes of infertility, what we find. Or the patients may benefit from IUI or ART procedures if the natural conception is not possible in that couple. And the goals, the genetic abnormalities if we find, and then treatment of such abnormalities or avoidance or taking of donor sperms. And adoption also could be discussed during that evaluation. And identification of any medical cause which can be treated, which was long standing, which was never discovered in this patient, so that also could be treated in those infertile couple. So when those males should be investigated, so at the same time as female. So I always insist when any infertility couple or any female comes, so the couple should come as means they both should come together to the clinic, or to any peripheral hospital also, they should be called together. and they should be referred together. Those should be, because this very simple test of evaluation of a male in the form of semen analysis and just the listening to the history is very important in the first instance only. And earlier, when it is required earlier, when they know any deformity earlier itself, like any history, any pelvic history, pelvic surgery history of that male, obvious fertility risk factors like diabetes or severe hypertension or varicocele, any surgical history, then who has a reason to question fertility, like erectile dysfunction, etc. Imminent treatment plan for malignancy. Then also this semen freezing, these things also could be discussed with the couple. Sexual history is more important, so it should be so my basic idea of telling about male infertility is that it starts with the history. What we think in our major hospitals and in the infertility clinics, that male infertility and treatment starts and stops with the semen analysis and just sending the female again and again, getting the tests done and getting the fertility. So male factor and history of a male is also equally important. Even some cases it is more important. So duration of the infertility and previous infertility, if a history of previous infertility, coital frequency, sexual dysfunction, libido, erectile dysfunction of any of these kind of history, exposure to STIs, and any previous evaluation for treatment if it has been done. If there's a second marriage, then also it should be documented. Any cryptorchism or any congenital deformities and surgery for that sort also should be documented. Childhood illness like mumps and herniorrhaphy, because mumps is very much responsible for any orchitis if the patient is having chronic orchitis. Then these history in the form we all generally take, but in infertility patients we generally forget all these things and we straight away go for semen analysis. So past medical history, previous surgeries or trauma, as I already discussed, exposure to environmental gonadotoxins. Like we always talk. Okay. So like past medical history also equally important. So past medical history, previous surgeries or any trauma, then exposure to environmental gonadotoxins like drugs. Occupation is very important. Like as we all know, the testicles, they are outside the body to reduce the temperature to 2 to 3 degrees Celsius so that the spermatogenesis, the formation of sperms, can take place normally. So any personal history of taking anabolic steroids, recreational drugs or smoking and alcohol is very important. So related organ system dysfunction also should be evaluated, like Carter-Jenner syndrome and Klinefelter syndrome. Family history of infertility was also very important in some genetic causes. So infertility, history of infertility in the family, cystic fibrosis and androgen receptor deficiencies also should be taken into account. I just wanted to show this table where it has been shown that alcohol and smoking, how they affect the fertility. So as you can see, the smoking and alcohol, out of these lifestyle factors, they affect the sperm parameters a lot. Like alcohol is related to reduced abnormal morphology of the sperms. Smoking is generally associated with reduced motility of the sperms, and other anti-rheumatic medications and other medications also responsible for abnormal sperm abnormalities. Then inguinal hernia repair, laparoscopic repairs, any surgeries, they also affect, and other medicines like benzodiazepines and all other medicines in any other department which these patients have been taking, they affect the sperm parameters. Some other drugs also there, as shown in this slide, they also affect they may affect fertility, so they should all should be taken into account. So now the physical examination, we should all assess these males separately from females. They should be examined for their vitals, BMI, secondary sexual characters, whether they have developed, how much they have developed, what stage. Cystic examination and urological examination is a must. We all skip this examination and straight away head for semen analysis and female factors. So we all know this male external genitalia, how they develop and how they are. So they should be carefully examined in the way they should be. Like we all know the anatomy of penis, scrotum, testicular, both sides. So how they should be examined? What is the normal weight? What is the normal shape of these organs? And these are all homologous to the ovaries in females. So they should be examined carefully. The examination should be documented. And epididymis is the structure which is the reservoirs of sperms. In testis, the sperms are manufactured. They are stored in the epididymis, and then they move forward. Then the spermatic cord. So even the male external genitalia should be examined properly. The general pubic region, penis, as I discussed, urethral region should be examined. Scrotum, testis, inguinal region, inguinal lymphadenopathies, and then the Tanner staging of sexual maturity. This should be documented. Hair distribution should be documented, because these are all related to hormonal factors in male infertility. Penis should be examined, it should be retracted. Any abnormalities on the part of glans penis, or inspect the anterior surface, posterior surface, any congenital deformities which were not documented, which the patient hasn't given history of till date, that also should be examined. Any history of circumcision also should be documented. Any signs of infection, that also should be noted during the examination. The examination of penis is also important. Then the abnormalities, phimosis or paraphimosis, or whatever we can think of, even with the help of the surgeons also nearby, they also should be documented, examined, and then sent to the ART center. Urethral examination, any deformities, abnormalities should be documented. Scrotal examination, including inspection, palpation, we all have learned auscultation and even transillumination to diagnose hydrocele, varicocele, or any other deformities of the scrotum. Palpation, hair examination, its contraction in the cold temperature, scrotal mass, enlargements. So these all examinations are very important, rather than just exposing this patient for semen analysis and ultrasound. We all have seen that in our IVF clinics, the patients come after an ultrasound of a scrotum where it was not documented, it was not indicated only. So testis also, it's a major examination we all skip in IVF centers, even in gynecological examinations. During a couple history taking and examination, we should all examine the testis, document its size, bilaterality, any presence of masses, palpate the epididymis, palpate spermatic cord, and any pain, any tenderness. Then along with the predator, organometer is also available to look for the sizes. For a periphery where they cannot assess the exact size of the testis, there the alternate methods are also available. Now I should skip these slides. So when we get the ultrasound done, we have seen in ultrasounds, so they could find some sort of varicocele, grade 1 or grade 2 or grade 3. So all these grades should not be treated or should not be operated. If they need to be treated, then only they should be treated. They should be sent to the surgeon, they should or the urologist. They should take the proper opinion of those consultants, and then they should be investigated further. Lymph nodal examination is very important for any infections or any other deformities also should be looked into. So what are the lab investigations we should advise? So semen analysis is a must. It's a very easy and simple procedure where a male just has to give the sample by masturbation. Then anti-sperm antibodies, sperm DNA fragmentation is also done on the semen analysis sample only. Endocrine tests, ultrasound is when it is required, not in all the cases, and genetic testing. Semen analysis is done as a first line lab, highly sensitive test, and it can be done in all the males coming to the, it should be done in all, it must be done in all the males coming to infertility clinic. If it is abnormal, it should be repeated after a month. It's a highly sensitive test, and it should be done between abstinence of 2 to 5 days. It should not be less than, abstinence should not be less than 2 days and should not be more than 5 days. Can be collected through masturbation, home collection or sexual intercourse using a condom. The third one should not be preferred, but still the patient, if they can't give the sample, then it can be taken, and this should be processed within 1 hour. It should reach the lab within 1 hour. Aspermia is anejaculation or retrograde ejaculation, then semen urine analysis should be done. So these are the normal parameters which as per WHO 2010, which and few things have changed as per WHO 2021, where almost everything is same. Semen volume is normal is around 1.4 ml. The most important thing is the total motility is around 42% of grade 3 and grade 4, means progressive motility and motility without progression. Then immotile sperm should be less than 20%. Sperm number should be around 39 million per total 39 million, and 15 million per ml should be the concentration of sperms. This is an abnormal semen analysis where we found mildly viscous, where it was the consistency should be low viscous. Liquefaction time was more than 30 minutes in this patient, where it should be less than 30 minutes. Then other parameters like volume, absence of block of seminal vesicle or ejaculatory duct causes low volume of semen. So in poor development of seminal vesicles also it could be the cause. Collection problem, androgen deficiencies also can cause this. Partly retrograde ejaculation, where is partly the semen is going into the urinary system also. High volume when there is lot of inflammatory cells and active inflammation of accessory organs like seminal vesicles. pH of semen is generally alkaline, prostate is acidic, so overall pH is almost alkaline, 7.4 to 7.8. Fructose test also should be done. Total concentration is the testicular capacity for sperm production, so affected by secretions from accessory glands like seminal vesicles. The majority of those the secretions come from seminal vesicles and partly from the prostate glands. Severe oligospermia is when the sperm count, the sperm concentration is less than 5 million per ml. Azoospermia is, as we all know, is absence of spermatozoa in ejaculated semen. Cryptozoospermia is only in the sediment post centrifugation. Motility means we look for actively motile sperms. Then importance of fertilization in vivo. So it is very important. More the motile sperms, the highly progressive sperms, more the chances of spontaneous conception. Vitality is also done by a dye test, where we do a hyposmotic swelling test, where we define the vital versus non-vitality test for can be used for ICSI basically for our IVF procedures. Morphology is very important, where I already told that alcohol severely impacts the morphology of the sperms. So defective spermatogenesis is also seen is a marker of means abnormal morphology. So poor morphology is very much indicative that this semen sample or these sperms are of a very low fertilization potential. There are other tests also to look for to do on this semen sample to look for other abnormalities. So we can look for leukocytes. When the leukocytes are more, increased leukocytes, it means there is some infection or chronic infection. So it will also impair the sperm quality, the sperm motility. Anti-sperm antibodies, these are not very important, but these are generally seen in pelvic infections, after the surgeries, cryptorchidisms, orchitis. But role of testing these anti-sperm antibodies is controversial, and generally it is not routinely done. sperm DNA fragmentation. So DNA fragmentation can be found in men with normal semen parameter. That should be known, because we do sperm DNA fragmentation in those patients where semen analysis is absolutely normal. In those patients where they come with history of recurrent pregnancy loss or early pregnancy loss or abnormal embryo formation. Even in during ICSI also, if we find in IVF, there are a lot of embryos are there, but fertilization was late or fragmentation was there, then we generally go for sperm DNA fragmentation test, which is found in 33% of patients abnormal. So there are various methods of testing this DNA fragmentation. So one is SCSA, then tunnel test, then comet assay, which the name should be known, and we routinely do SCSA, which is highly sensitive, and less than the value should be less than 15%, and moderately high is up to 25%. So we can say that this DNA fragmentation test is normal till 25%. Post ejaculatory urinalysis can also be done in retrograde ejaculation cases. Ultrasound should not be routinely done in all the cases. Where precise measurement of testicular size, it's to be noted where it should be done. Varicocele, where it is to be operated, then only it should be done. Or we diagnose with the case of large cysts or spermatocele, where the patient needs to be operated, then it should be done with the help of a urologist after the consultation of a urologist or a general surgeon. Then only it should be done. It should not be routinely done at periphery, because we don't get any information after this USG. Transrectal also is done to assess the prostate and other glands, but not routinely. The ultrasound is not routinely done. Endocrine investigation is a must in oligozoospermia, in azoospermia cases. FSH and testosterone. So I'll just skip to the karyotyping is also important in those patients where azoospermia is there, or we find FSH very high, where we want to rule out some genetic deformities, where we should not be using those sperms because of some fear of carrying forward this abnormality, and like Y chromosome microdeletion. So azoospermia, we always get these patients diagnosed with azoospermia. So always azoospermia should be diagnosed in 2 samples done around a month apart. Then specimen is centrifuged around 3,000 times for 15 minutes at least on those 2 occasions. Then only it should be diagnosed as azoospermia. When the patients come, then we again do a test, semen analysis. Then at our center, if it is azoospermic, then only we diagnose these patients as azoospermic. And we have to identify those patients where these patients are candidates for ICSI, means intracytoplasmic sperm injection, which is a process in IVF. So ASRM, like the American Center of the Americans also, they also prefer and recommend assessment of both the partners, male and female, in reproductive history, semen analysis evaluated by a male reproductive expert, complete history, physical examination. Everything is important. Then counsel about health risks, advanced paternal age more than 40, discuss risk factors about alcohol, smoking, environmental exposures, occupation. All these things I have already discussed. Karyotype and Y chromosome microdeletion is only indication in 2 cases, where non-obstructive azoospermia and severe oligozoospermia, means less than 5 million per ml. DNA fragmentation test I already discussed, where it is to be done. Increased round cells, which should be separated from the germ cells, which could be seen as germ cells, so should be differentiated. RPL cases, diagnostic testicular biopsy should not be routinely done because it damages the testicular tissue and it forms anti-sperm antibodies. Imaging guidelines, scrotal USG should not be routinely done, which is routinely done nowadays, so should not be done. Truss abdominal imaging not to be done for indication of an isolated small or moderate right or left varicocele. Then renal USG, vasal ASNHS to evaluate for renal abnormalities. So these are few tests, but basically I just want to convey that semen analysis is the basic thing which should be done. But before the semen analysis, clinical examination and history, occupational history, drug history is very much important. And then the scrotal USG is not to be recommended at peripheral centers. Thank you.
Thank you very much, sir. May I request Dr. Jhadbuke sir from Temboni to felicitate Dr. Akhileshwar Singh. Thank you. Thank you. Thank you very much, sir. May I request Dr. Balasaheb Raut to felicitate our chairpersons, Dr. Magar sir and Dr. Punde sir. Thank you. Thank you. The chairpersons for the next session, Dr. Shen sir and Dr. R. Shinde sir. So please come on dais to chair the next session, which will be on regional anesthesia by Dr. Vittal Shenge. He's MBBS MD anesthesia from Tata Memorial Hospital, KM. He's done UDAC from Australia, CPR instruction in AHA, DNB. He's a DNB teacher. Right now he's a HOD anesthesia, Vishwaraj Hospital. He has a experience of 15 years in different heads of anesthesia and different parts of Pune. Thank you, and please welcome Dr. Vittal Shenge sir for regional anesthesia.
So, Namaskar and good morning. Myself, Dr. Shendge, working as a anesthetist in Vishwaraj Hospital, leading the department. So, the topic given for me is regional anesthesia. The thing which I want to convey you, anesthesia is all about safety. My client is not a patient. Usually, my client is a doctor. You are not going to call, or patient is not directly coming to me. The doctor is going to ask for help regarding anesthesia, right? So I am supposed to, I am not the primary person who is going to deal with the patient. So why should doctor call me? What aspect he will look before calling me? That is the only safety. The excellent person or excellent anesthetist, that is not required for any doctor. What is required is the safe anesthetist. So what is safety? Safety is everything I am going to look after during the surgery. So how anesthesia evolved? Anesthesia is not evolved on the basis of any equipment or gadgets. It's basically evolved on the basis of safety. So procedures what we are doing, gadgets we are using, or the medicine or pharmacology or medicines we are using, whatever evolution occurred in anesthesia is all about the safety. So today's topic is a regional anesthesia. In regional anesthesia, two things matters. One is a medicine and second is the procedure which I am going to perform. So my skills and the gadgets which I am going to use, those are the important. And the most important thing is the medicines I am going to use. I should know in detail about the medicines. So initially we used to go for the blind blocks. Blind blocks means we are going to locate the nerve by clinical methods, then we are going to locate it by a needle, and then we are going to inject the drug inside the or around the nerve, and then we will get the block. But the problem is that the accuracy of getting nerve block adequate for anesthesia is around, accuracy is around 60 to 70%. So what we did, we increase or we improved our procedure by adding one equipment called peripheral nerve locator or peripheral nerve stimulator. So what is the benefit? The success rate will improve. But what will happen, there is no great idea about the how much inside I am inside the nerve. So if I am injecting the drug inside the nerve, that will cause trauma to the nerve. So what is the beyond that? What is beyond that is the sonography. So we are going to locate the nerve by what? Sonography under vision. So I can put my needle just close to the nerve and I can inject the local anesthetic around the nerve instead of injecting inside the nerve, which will cause nerve trauma. So this is what happening in anesthesia. We are going from blind blocks to the ultrasound guided or CT guided blocks, which we are doing under anesthesia, under vision. So the safety of the patient is increasing. Similarly, what we are doing regarding the pharmacology, we are going with less cardiotoxic drugs like bupivacaine. Bupivacaine has high cardiotoxicity. As compared to that, the levobupivacaine has less cardiotoxicity. So we are going towards the drug which have spectrum of less toxicity. So what is actually a regional anesthesia? In regional anesthesia, what we are going to do, we are going to what we are doing here, we are doing transient and reversible loss of sensation in particular area in the body without loss of consciousness. So this loss of consciousness is going to differentiate between the regional anesthesia, your sedation, and general anesthesia. So in general anesthesia and sedation, we are going to lose the consciousness. In regional anesthesia, what we are doing, we are maintaining patient's consciousness with the help of local anesthetic and different method of localizing the nerves. Okay, so this is how we define the regional anesthesia. There are different methods of regional anesthesia. Most commonly is a routine infiltration. What we are doing for the taking sutures, debriding the wounds, that is called infiltration. So blindly we are infiltrating local anesthetic in a subcutaneous plane where we know there is a neurovascular bundle, and we will infiltrate the local anesthetic in that plane, so that that part of the part of interest you want to deal with, that will get anesthetized, and then you will start with your procedure. So this is called infiltration. Then central neuraxial anesthesia, most commonly used and everybody know about it, that is the subarachnoid block, or we also call it as a spinal anesthesia. Then next is a epidural anesthesia, then combined spinal and epidural anesthesia. Then IV regional anesthesia, this is the terminology very few know, or those who know regarding orthopedics, those know it as a Byers block, but that is almost out of practice now. And then last is the peripheral nerve blocks. So what I want to discuss with you is regarding, this is not something new to you. You are knowing all the things. The only thing is that, can we use same procedure with a different approach, or for different purpose, or with different technique for different solutions? One. Second thing, what we are doing in a Vishwaraj, and what are the safety take-home messages for you to practice? So subarachnoid block, we know we are going to put the needle in subarachnoid space, then CSF will come out, then you will inject the local anesthetic, and you will get the adequate level of block where you can perform the surgery. But what is trend, what is new in subarachnoid block? So Segmental anesthesia is the not actually not a new terminology, but now means it is practice. So what is segmental anesthesia? Here basic thought is regarding the baricity of the drug. In spinal anesthesia we are going with the hyperbaric solution. Here we are going with isobaric solution. So surface surgeries like the surgeries for the breast, so that can be done with a segmental anesthesia. Here at T4 level you are giving spinal anesthesia, then you are putting isobaric solution 5 to 6 ml or 1 to 1.5 ml per segment, and then you will make him or her sit for 4-5 minutes till drug is set. Then you can make her supine, then you can proceed with the surgery which is regarding the breast. Okay, so here you will not get adequate muscle paralysis per se, but the surface surgeries or parietal surgeries can be done with segmental anesthesia. This is the, again this is old terminology, but with new approach, new thought, people are performing. Then some school of thoughts ki this may be dangerous. The reason being you are putting the needle where your spinal cord is still there. Means usually we are putting the needle at L3 L4 where your spinal cord is not there. So damage of spinal cord less likely. But here in T4 space you may damage the spinal cord, but if you are skilled enough, you are used to and you know how to monitor the patient, then segmental anesthesia can be a good anesthesia for the breast surgeries or super special surgeries or the surgeries for the onco patients or cancer patients where already meds are there and lung condition is not good, patient is not fit for general anesthesia. Then for late stage of labor, here when patient is in a labor with a severe pain, when dilatation is more than 5 centimeter, then you can go with only opioids, give subarachnoid block or a saddle block, but that will be subarachnoid block with opioids only, no local anesthetics. So 25 to 50 microgram of fentanyl will suffice, and that will take care of the end stage of your labor, that is a stretching of the perineum and taking out the baby. So here we are not going to give any type of local anesthetic, reason being that can obstruct the labor process. So only analgesia is the aim here. So that is called labor analgesia through subarachnoid space for the end stage of the your normal labor. Then continuous spinal anesthesia when you want to try with you want to proceed with the epidural anesthesia, but somehow what happened, there is a dural tap. So most of us, what we do, we take the needle out, twist needle out, then we will go for the higher or lower spaces. Okay, so instead of that we can put the epidural catheter into subarachnoid space. Considering it as a spinal anesthesia, we will give lower doses of the drug, and we can conduct that surgery with continuous spinal anesthesia with lower doses of local anesthetic, and then we can take it out instead of taking second prick, or there are chances of again multiple punctures. Then intrathecal injections for multiple uses. Intrathecal injections like cysternography. If you want to go for the want to check the patency of CSF or you want to track the CSF flow, then you can put a dye inside subarachnoid space. These are the calls or references we are getting in our hospital or outside the hospital also. So you should aware about that. We are putting here large bore needle, say 23 or 25 gauge, and then we are injecting the dye here, and we are going to track the dye so that you will get any cisternal obstruction and whatever how the CSF is flowing. If there is a blockade, then you will able to find out at what level the block is. Then PDPH, another concept which is not actually new but not yet fully practiced. So post-dural puncture headache, when we are using the Quincke's needle, which are of smaller size like 27 or 26, then incidence is low. Still nowadays, what is the difference between the PDPH of Whittaker needle and Quincke's? Almost 10% difference, what book says or literature says. So why not to go with the Whittaker needle? So what is the difference between the Quincke's needle and Whittaker needle? There is a basic concept is that when you are cutting the entering into the subarachnoid space, you are going through the arachnoid membrane, right? So while piercing the membrane, if you are splitting the membrane, the fibers which are splitted will come again to the normal position, that will not allow the leak of the CSF into outside. So that will cause less PDPH. If you are going with the Quincke's needle, which is a regular needle, then that will cut the fibers and that will cause PDPH. This is the thought given. But personally speaking, what I am doing, I am using the lower size Quincke's needle, which is 27, or with guide 29. I don't find any gross difference between the 25 Whittaker or 27 Whittaker with 27 or 29 Quincke's. But this is the thought which is going on. Caution: subarachnoid space is not optional anesthesia to difficult airway. So there is a trend in a periphery or even in a center. People or anesthetists are saying, this is a difficult airway, I can't intubate the patient, so we will go with spinal anesthesia only. So what they are thinking is spinal anesthesia is safer than the general anesthesia. But never forget, any type of antibiotic allergy, local anesthetic allergy, any high level of anesthesia, you have to intubate the patient at the end of any event, or you have to continue with the CPR. Again, intubation is the part of CPR. So if anybody is convincing you that spinal anesthesia is better for lap cholecystectomy or laparoscopic procedures, or that is safer than the general anesthesia, that will not require oxygen, that will not require intubation, so your tube, your drugs, your all kharcha will go down, then he is making you fool. The last resort of anesthetist is intubation. Nobody can save any anesthetist, for that matter surgeon or the setup. So if you are calling somebody as anesthetist, don't believe the statement that spinal anesthesia is safer than the general anesthesia. General anesthesia is the last resort. Intubation is the last resort of life-saving skills. Okay, so spinal anesthesia is not safer in a hand which says that I am not able to intubate the patient, that's why I am giving the spinal anesthesia. So spinal anesthesia is never replacement for intubation or general anesthesia. Then absolute contraindication, everybody knows, it's a patient refusal. आपल्याकडे पद्धत आहे usually, नाही होऊन जाईल, बसा तुम्ही, हां देतो मी. तर this is not right. So if patient is refusing your spinal anesthesia, don't want to get that injection, then respect that. So patient will is the most important thing. Don't go against the patient refusal for any type of regional anesthesia. Then allergy to local anesthetic, then lack of experience and infection and sepsis. These are the contraindication for your subarachnoid block or spinal anesthesia. Next is your epidural anesthesia. You know, epidural anesthesia can be a supplement to the subarachnoid block for prolonging the duration of action. Second, post-op analgesia, and some surgeries where spinal epidural anesthesia will become the core surgical anesthesia, like a patient with mitral stenosis, where you don't want a sudden vasodilatation, which in a fixed cardiac output states where patient can land up into severe hypotension, which is not responding to your routine or conventional drugs or management modalities. So surgical anesthesia with epidural, basically for such specific cases where rather than muscle relaxation, what is important is the analgesia, and you want to just go through that surgery as early as possible and take out the what you want. Then analgesia for acute and chronic pain management. So this is actually epidural anesthesia is the modality mainly used for the pain relief, either acute or chronic. So how it affects a patient coming to emergency medical services with fractured rib, with lung contusion, right? Patient have desaturation of 80% with tachycardia of say 130, 140, hemoglobin of 7, 8 because of blood loss, with mild to moderate hypotension. In that case, what will work as a magic is your pain relief. So how you want to give? If you are going to give sedatives, you are going to give opioids, then that will cause further respiratory depression with in presence of fracture and contusions. So patient will desaturate, that will cause complications. So instead of that, if we are going with epidural anesthesia like thoracic level, that particular part or segment of rib fracture can be made free of pain. So the depth of your inspiration will increase, and what will happen with that? Oxygenation will improve. Fine. So this will give positive impact on sympathetic stimulation. Fine. That will go down. Oxygen consumption will go down. Depth of breathing will increase. Lung collapse will decrease. Basal collapse basically. And whatever hormonal imbalances or inflammatory mediator imbalances are occurring due to the pain, that will settle, and that will give good outcome in the form of early recovery. Even you can manage patient instead of ICU, you can manage that patient in a ward, and early mobilization. If need, you can go for early correction or corrective surgery. Fine. So this is the role of acute pain management. We start from the patient, from the emergency medical department or your casualty, or when patient is entering into your hospital, provided that you have that person or that team with you, that will be much beneficial in the form of financial burden also. Another thing regarding epidural anesthesia is not just putting a tweeze needle inside and putting epidural catheter by LOR and all that. But what we are doing regarding epidural anesthesia. So interventional pain management. This is the concept which is long before. Means it's more than 10 years we are practicing it. But that has not significant awareness in the peripheral part of Maharashtra or India. So how we can make it? So the radiculopathies like cervical गावाकडे जी काही अशी शेतात कामं करणारी लोक आहेत, having lower backache or cervical radiculopathy, in those cases we can give either interventional CM guided blocks. Initially we will put a needle under CM guide, then we will put a dye, we will locate the position of the tip of the needle, then we can give either local anesthetic or local anesthetic with steroid, and that will take care of her or his pathology for maybe 1 month to 6 months. If there is an obvious surgical correction needed, then we have to go for surgery only. But when the pathology is at multiple level, then we can't go for surgery. In that cases, we have to think about the such interventions. So I will escape this IV regional block or virus block. This is a actually toxic entity that can create complication. So better to avoid it. So peripheral nerve blocks, most of them, those who knows the anesthesia must be aware about the upper extremity block. All plays around the brachial plexus at different level, and then particular nerves. Then lower extremity, what we are doing, lumbar plexus, sciatic, then popliteal, and then ankle. So this is again the same. So with sonography and CM guided blocks, what is happening nowadays is a rectus sheet, transverse abdominis block, ilioinguinal, iliohypogastric. So these are the surgeries, these are the nerves we can locate individually by sonography or with the help of CM, and then we can block those things, so that the patient who are elderly, who are not fit for the surgery, fit for the general anesthesia or spinal anesthesia, with some manipulations we can manage or go through the surgery without any complications. So take home message is patient safety, safe drugs and safe procedure is the key of anesthesia success. So we don't want excellent anesthetists, intelligent anesthetists. What we want anesthetists who is safe. So never compromise on consent, documentation and laboratory investigations. So first most important thing is consent. In periphery होऊन जाईल रे, चला करून टाकूया. So but this is practice is changing. Still we are at periphery, that is acceptable, but in metros people can behave in a different way. So always be cautious about the any type of intervention or infiltration or anesthesia procedure you are going to do with the patient, that has to be consented. उसमें दोनों का sign चाहिए. Then laboratory investigations. So absolute contraindication for your any infiltration or for that matter any deep space block is the platelet count and your INR. If that is compromised, if that document is with you, still you are doing or performing that process, that is something heroic. Okay, so either find out the cause, treat it. If not possible, then at least reinvestigate the patient. If you feel patient is fit, still this is something wrong, then reinvestigate the patient. But you are generating the proof which is against you that there is abnormal platelet count and INR, still you are performing the procedure. If something goes wrong, then you are 100% gone. Don't be heroic in a procedure and drug injections. Okay, so always take good history of allergy, then nerve injury, previous nerve injury, previous weakness, trauma, previous anesthesia. Somebody who is coming for the fissure surgery towards the general anesthetist, I am going visiting the patient, taking history, it's okay. If I am going directly and entering into the subarachnoid space, and after 7 days patient is coming with the common peroneal nerve deficit, so it was previously or it was not there, it was due to your manipulations or it was due to position. This is all difficult to judge, and that person or that patient can blame you for that. So be cautious about that. Explain possible complication of procedure to the patient. That doesn't mean the patient will reject the surgery, otherwise surgeon will reject you. Okay, so always explain in such a way that you should able to convince the patient that this may not happen, these are the possible complications, so don't worry about that, I will manage. But you should make them aware these are the possibilities, like PDPH. otherwise मुझे पता ही नहीं था कि इतना हेडेक होता है, otherwise मैंने किया ही नहीं होता. Always aspirate before injection. When you are giving any local anesthetic or any block, always aspirate, otherwise it will go into intravascular compartment. Bupivacaine is a cardiotoxic that can create a chaos. For that treatment you need to have intralipids. I will guarantee you will not get a single intralipid in whole Indapur. Means we are not getting it. I am 100% sure that there will be no intralipid in any pharmacy or any hospital in Indapur. So be aware of that. You should have adequate basic support for toxicity management. Now, never disrespect disproportionate pain while injecting the local anesthetic. Reason being, if you are intraneural and if you are injecting the local anesthetic, that will cause severe pain. The person who is accepting your prick on the skin is not accepting the pain of internal injection. That means you are somewhere at wrong place. Okay, so probably you are in the intraneural space. So in that case you have to take your tip just little bit out, otherwise what will happen, that will cause nerve damage. Ideally we have to infiltrate around the nerve, not inside the nerve. Then resuscitation equipment and drugs always handy in operation room, including intralipids. Commonly use these two drugs, that's why I will discuss these. Xylocaine plain, usually dose acceptable is 5 mg per kg, and with adrenaline brown bottle, that is 7 mg per kg. Initially whatever toxicity occurred due to the xylocaine, that will be neurotoxic. Initial phase, that will be excitatory, that you will get tingling sensations, okay, where perioral numbness or tingling sensations. Then you will get tinnitus, कानात काहीतरी वाजतंय, or dizziness. These are or there is slurring of speech. These are the initial symptoms. If you are in a too much excess dose, then you will get actually depression, which will cause mainly respiratory depression, and patient that time you need to intubate the patient or sedate the patient, then intubate or paralyze, whatever you want to do, but that resuscitation preparation has to be there. Bupivacaine dose usually 2 to 3 milligram per kg, but I will always accept lower range, so 2 milligram per kg will be okay. So but bupivacaine has significant cardio, it's most cardiotoxic drug which is most commonly used to prolong the duration of anesthesia in a practice. So while giving bupivacaine, never be too lazy to aspirate. Xylocaine एक वेळ तुम्ही दिलं and if you did not aspirating, then that will cause neurotoxicity. Here you have still chance to intubate, resuscitate, but if you are giving bupivacaine intravascular, then there will be no chance because you don't have intralipid also. Okay, so never play with bupivacaine for prolonged duration without aspiration. And most important, always be ready with good monitoring system. Try to upgrade the things. So this is not just Vishwaraj marketing or what we are speaking about Vishwaraj, what we are doing or what knowledge is saying. Upgradation of your hospitals or your operation theater is equally important. Most of the time what happens, anesthetists don't say to the surgeon. The reason being they are worried about their cases. Okay, otherwise next time you will not call them. But try to upgrade, that is, he is or she is for 1 hour, 2 hour, but your patient is for next 3, 4, 5 days with you. If anything goes wrong, then hospital registration, monitoring system, whatever required, given by municipal corporation or Gram Panchayat or Mahanagarpalika, you have to follow that rule. Then all things go on that. So try to help out the anesthetist or try to help out your operation theater for betterment. So good monitoring system, sedatives, adequate drugs, intubation preparation, and your, if you have, please try to arrange defibrillator. So now, so 2 slides only. Acute, what is the role of neuroaxial blockade or regional anesthesia in acute pain management? At EMS or ICU or OT, at any places, your patient will either come to emergency medical services stable, then shifted to ward, or unstable, then go to the ICU, or in emergency that can go into the OT. So try to intervene. The most important function is most important parameter, that is the pain. If you are going to relieve the pain, your 50%, 90% work is done. Then whatever you want to do with the patient will accept it. But if you are not going to relieve the pain in initial few hours, then patient will become toxic. Afterwards, emotionally disturbed and will not cooperate for your surgical procedures, financial issues or administrative procedures. So pain relief is the most important thing, which if you are going to entertain initially in few minutes or few hours, then patient will cooperate you. Epidural, so epidural and blocks. So blocks, usually what we are doing here, we are putting epidurals, or if epidural is not indicated, then we are giving sono guided blocks. So in initial period, if we are giving pain relief, the sequelae for or cycle which bad cycle which initiates, which will stop. So what are the advantage? It decreases pain and inflammatory response, blood loss, better pulmonary function, improved oxygenation, increased cooperation, rapid recovery, early ambulation, decreased hospital stay. And the last slide. So what is chronic pain management? So nowadays pain management with anesthesia or anesthesia, ICU and pain management. This is usually the terminology for anesthesia now. So what we are doing at our setup or Vishwaraj Hospital. So we are also in interventional pain management, in which we are doing for cervical radiculopathy, we are giving cervical epidural which are C-arm guided. Then SI joint, so the old people or even females post pregnancy which are coming with sacroiliitis, not relieved with NSAIDs, and they are just fatigue, obesity. So in those cases we can go with the location of SI joint with needle, with the help of C-arm, and we can put initially local anesthetic with steroids. Local anesthetic will act immediately, so she will get some pain relief, and when steroids will come, that will give prolonged pain relief when inflammation will settle. So SI joint or sacroiliitis can be managed with this. Then transforaminal approach for multiple radiculopathy. This is basically for thoracic and lumbar region. The stellate ganglion block, Burgess disease, vasospasm, cyanosis, all this happens due to sympathetic stimulation. Basically, stellate ganglia in neck is your sympathetic ganglia, which is going to cause vasoconstriction, and then you will get the cyanosis. So you can try Burgess in those particular middle vessel or middle size vessel spasm. In that particular case, you can give local anesthetic. That is actually diagnostic. If they are getting relief by that, then you can go for the therapeutic obliteration also. Then celiac plexus block. This is for CA pancreas. Severe pain, inoperable patient, multiple level meds. In that case, you just want a palliative therapy where you want to give pain relief. In that particular case, CM guided celiac plexus location, and then initially diagnostic modality as a local anesthetic. If getting pain relieved, then you can go for the permanent damage, either absolute alcohol or phenol. So these are the trends in anesthesia, but the one trend which is always constant and will be constant, that is the safety. So never compromise on safety. Thank you.
Any questions? Okay, thank you very much, sir. Xylocard and Xylocaine, what is the difference? If you are going to read the bottle, only thing which differs is a methyl paraben, which is a preservative in Xylocaine, and Xylocard is a preservative free. So it works like a hapten. Okay, it's not a full antigen, but when it goes inside the body and reacts with the body protein, it can become a full antigen, can create a allergic reaction. But in Xylocard it is not there. So Xylocard ka vial usually we finish early, so it can be given for the your intravenous. Xylocard can be given through intravenous route. So whenever we have arrhythmias, if the indication for that arrhythmia is Xylocaine, then we prefer Xylocard, not Xylocaine. गलती से भी Xylocaine लेके मत आना. For arrhythmias we respond to Xylocaine. Okay, means Xylocaine as a molecule. Xylocaine, the preparation is with Xylocaine and methyl paraben, that can cause allergic reactions or toxicity. Fine. Thank you. Thank you very much, sir. May I request Dr. Suraj Madik from Akhileshwar to felicitate Dr. Vittal Shenge, sir. नाही राहू दे. नाही एकच झालं लेक्चर.
हे मला आलं का बघा ना थोडं मॅडम. हां हां.
The speaker for the next session is Dr. Hemant Chaudhari. He is a vascular and endovascular surgeon practicing in Vishwaraj Hospital. He has done MBBS from Sion Hospital, DNB surgery from KEM Hospital, Pune, DNB vascular surgery from JIVAS, that is Jain Institute of Vascular Sciences, Bangalore. His expertise in minimal invasive endovascular as well as open vascular surgery. His areas of interest are pelvic vascular disease, gangrene, angioplasty, bypasses, varicose vein laser, diabetic foot management. He has published multiple papers in Indian Journal of Vascular and Endovascular Surgery. So please welcome Dr. Hemant K. Chaudhary. His topic will be PVD management, pelvic vascular diseases management, peripheral vascular diseases management. Thank you.
Yeah, good morning everyone. I am Dr. Hemant Chaudhari, vascular surgeon practicing in Pune, Vishwaraj Hospital. Thanks for this opportunity. So my topic for the today is the peripheral vascular disease. I am sure many of the physicians, surgeon must be coming across very often with the peripheral vascular disease patient. So I'll be covering this topic in these points, that is the PVD overview, the risk factor for the peripheral vascular disease, pathophysiology, the spectrum of the disease, then the nomenclature of the lower limb arteries particularly, and how to differentiate it between the diabetic foot ulcer and the peripheral vascular disease, which is very often missed, and approaches to the peripheral vascular disease. So we'll go one by one. So peripheral vascular disease is nothing but the atherosclerotic steno-occlusive disease involving the peripheral arteries, predominantly the lower limb artery. The diabetes is the major risk factor which affect the lower extremity, then coronary and the carotid circulation. Almost 90% patient with the PVD are having diabetes. So that's why it is very often confused with the diabetic foot ulcer and PVD. Okay. So PVD is associated with the increased risk of lower limb amputation as well as the MI and stroke and death. So natural history of the disease, the whatever the patient you are seeing with the gangrene or the ulcer or the wrist pain, almost 25% of the patient will undergo amputation at the end of 1 year. And 25% patient will die by the end of 1 year. So this is a very chronic crippling disease. So the risk factors are basically the diabetes, hypertension, smoking, and the hypercholesterolemia. So pathophysiology of the disease is, you can see over here, the left side I have shown the lower limb artery disease. Just picture beside that there is an atherosclerotic block in the vessel, and because of that there is a narrowing of the blood flow, which is shown with the blue arrow. So because of the decrease in the blood flow, there is a decreased supply of the oxygen. Because of the decreased supply, there will be wrist pain, or if some ulcer happen by any cause, that will take very long time in healing, or there it may turn gangrenous, and sometimes patient present with the claudication pain. So the PVD spectrum is, majority of the patient with the PVD are asymptomatic, they don't have any symptom. And the smaller spectrum is symptomatic. The symptoms are nothing but the claudication. In that one also there is a lifestyle disabling and non-disabling. The claudication is nothing but the patient is having the pain after walking some distance. This claudications are many a times confused with the spinal claudication, venous claudication. So how to differentiate the vascular claudication? While walking, the patient will be fine in walking initial few steps or some distance. After that, he will complain of the pain in the particularly calf region, which will go on increasing as the patient walks further. And at one point of the time, the pain might be so severe that he has to take a rest. And after taking a rest for say about few minutes, he is able to walk again. And it is reproducible. Every time he is able to walk that much distance. So it is because of the whatever the because of the narrowing in the blood vessel, the lesser blood is going down, and that lesser blood is not sufficient for the active muscle, that is muscle walking. So whatever that blood get accumulated in that amount of blood or that amount of oxygen, the distance patient is able to walk, that after that distance he has to stop because of the pain. That is a claudication. If this claudication is a lifestyle disabling, if one has to resign from one's occupation, or suppose somebody is farmer, he has to quit farming because of the claudication. So this comes under the lifestyle disabling claudication. The other claudications are patient says that I am able to walk 500 meter and my day-to-day life is going well with it. I am not very much worried. So that comes under lifestyle non-disabling claudication. So indication for treatment is a lifestyle disabling claudication. So another is a rest pain. So at the rest, whatever the basic skin demand of the oxygen, if that much blood is not even reaching to the skin, at that time patient will have the severe rest pain. That rest pain is defined as a pain which persists for more than 2 weeks in spite of taking opioid analgesic. So that is comes in the rest pain criteria, and generally rest pain develops in the end arteries level, that is a toe, particularly toe tips. Okay, and another symptom is a non-healing chronic ulcer or gangrene. So because of the lack of oxygen, the ulcer will take a long time to heal, or it may not heal. So any ulcer which is not showing the healing response beyond 2 to 3 weeks is defined as a chronic non-healing ulcer. And if there is a further lack of blood flow, the wound might turn gangrenous, blackish. So that is another symptom. So indication to treat the PVD is a disabling claudication, then rest pain, and then is a gangrene or chronic non-healing ulcer. So this is a basic arterial tree. So as you can see, there is a aorta which is dividing into the bilateral lower limb arteries. The first artery is a common iliac artery. Will help you understanding the further slides. So how to differentiate between the diabetic foot ulcer and the critical limb ischemia? So many images I have shown over here. Which is the critical limb ischemia amongst it, and which is the diabetic foot ulcer? Can anybody tell? Sorry, yes sir. Which one is the critical limb ischemia or peripheral vascular disease? Okay, this one. Amongst these images, diabetic foot. So there is a lot of overlapping spectrum between the diabetic foot and peripheral vascular disease. So just the only simple thing to differentiate whether it is a diabetic foot or whether it is a peripheral vascular disease is just the simple palpation of the pulses. If the pulse is well palpable, then you can treat as a diabetic foot. So basic wound care and nothing much is required. But as soon as the pulse is not palpable, the disease changes its names to the peripheral vascular disease or critical limb ischemia. So even I cannot tell without examining the pulses. Definitely this is a gangrenous. So as sir said, it is high likely it is a critical limb ischemia only. But amongst these pulses, if the pulse is not palpable, so the name changes to the peripheral vascular disease or critical limb ischemia. So this is the same thing what I told. Any foot ulcer in the diabetes with the non-palpable pulses is a PVD. So how to approach the, so we are coming towards the treatment. So the first will cover the claudication treatment. So claudication which are non-lifestyle disabling. So in this one, the medical treatment basically involve the cilostazol, pentoxifylline, giving the antiplatelet agent, statin, and a prostaglandin E1 infusion. So cilostazol is a phosphodiesterase 3 inhibitor. The dosage commonly given is 100 mg BD. If the patient is having cardiac issue, it may be reduced to the 50 mg BD. The mechanism of action is it is a platelet aggregator inhibitor, and more than that, it has a vasodilatory action. It will act on the smooth vessel of the blood vessel and it will dilate the vessel. So the study has proven that with the cilostazol, the patient who is telling that after walking the 500 meter I have to stop, in such a patient the claudication distance will improve. Gradually they can walk up to the 700, 750, even 1 kilometer or even more than that. The another is a pentoxifylline, that is a methoxyzatide. The dose is 400 mg TDS, and it has a hemorrheological effect and some vasodilation. Basically it causes the changes in the RBC membrane, so that it will increase its motility and the passage through the stenotic segments. The another is antiplatelet therapy. So all symptomatic patients should be prescribed, because the peripheral calcification develops almost 5 years after the central, that is the coronary calcification. So almost all the patient who is having the peripheral vascular disease, to the lesser or the more extent, they must be having this coronary calcification. So all the patients should be straight away started with the ecosprin and the statin. 75/20 dose is enough. So approach to the peripheral vascular disease with the wound or gangrene or say rest pain. So as I said, this is another indication for treatment. So whenever the patient has a wound So it comes under the wound management and the PVD management. So we have to proceed in such a way that we have to see first whether the wound is infected or not infected. If it is infected, the pus should be sent for the culture sensitivity and the antibiotic to be given accordingly. Then we have to take the foot X-ray. If it is a chronic long-standing ulcer, sometimes there is a underlying osteomyelitis because of the long-standing chronic infection, and many a times we'll do the superficial debridement, and because of the osteomyelitis component, there will be persistence of the infection, and which will come again and again. So we have to rule out the osteomyelitis by taking the simple foot X-ray, weight-bearing foot X-ray, and whatever the dead part or whatever the infected part, we have to do the debridement and amputation accordingly. So I will further come to the wound care in the next slide. This is a just brief overview how to manage. Then we have to check the pulses. If the foot pulses is palpable, then we have to treat like a diabetic foot, just wound care, antibiotic and debridement. If the pulses are not palpable, then we have to think in a way of PVD, and we have to proceed towards the PVD management. So what are the basic foot pulses palpable? It is a dorsalis pedis on the foot dorsum. Okay, then comes to the anteritibial at the anterior aspect of the leg, and posterior tibial artery behind the medial malleolus. So any of these artery, if it is not palpable, then we have to think in terms of the PVD or chronic limb ischemia or critical limb ischemia. So the next investigation is a lower limb arterial Doppler. So that will reveal there is a blockage of the atherosclerotic blockage in the arteries, or the narrowing in the arteries, changes of the flow from the triphasic to biphasic or monophasic. Triphasic is a standard flow, and when it becomes the biphasic or monophasic, that means it is further decreasing. So monophasic or biphasic flow are not the normal flow. If you see any Doppler report, it will mention there. Then the next investigation is the MR angiography and CT angiography. According to you, which is the preferable investigation? Yes, sir? CT, MR. Okay. So the basic concept here, as I told earlier, the diabetes is the main risk factor for the atherosclerotic patient, and almost 90% of the patient with the diabetic, they will be having the tibial vessel block predominantly compared to the SFA or the proximal block. So during the CT, whatever the contrast we use, so that will also look white, and atherosclerotic blockages will also look white. So many a times there will not be clear demarcation where the exact stenosis is there, where the long segment block is there. Many times the reporting is like that, the diffuse atherosclerotic disease. They will not be pinpointing because they will not be able to see the exact extent of the disease. So MR angiography, the advantage is it will not show the calcification, it will just detect the blood flow. So wherever the blood flow is there, it will show the vessel normally. Wherever there is a narrowing, it will show the narrowing, and wherever it is not there, complete occlusion, it will show the cutoff. So the MR angiography is a preferred over the CT angiography. And then next comes to the, once you got to know about the blockage, the next step is the to tackle the blockages with the either angioplasty or bypasses or the stenting. So the treatment plan, the wound care, revascularization in terms of angioplasty or bypasses. So coming to the wound care, so what all things are involved in the wound care, particularly the diabetic patient. The basic debridement I already told. Then there comes the some special dressing like a colloid or antibiotic bead dressing. Whenever it is a multi-drug resistant infection, that antibiotic can be mixed with the simulator, and the antibiotic bead can be formed. Here I have shown in the lower picture. So that antibiotic bead can be placed over the wound bed, and each time the wound is, we are cleaning the wound, these beads are taken out, wound is clean, and again it is applied over the wound bed. Okay. Then comes the role of the VAC, then skin grafting, then minor amputation, and offloading footwear. The offloading is a very, very important aspect of the wound care, because what happens in the diabetic, majority of the foot ulcer develop in the area wherever there is a maximum pressure. So because of the foot changes with the long-standing diabetes, there will be changes in the foot arches, and normal pressure area at the great toe base, then little toe base, and at the heel. So in such a patient, the pressure area will shuffle, and because of the more pressure, they will develop the pressure sore over the foot. So just doing the debridement, giving the antibiotic will not be sufficient in such a cases. So in such a cases, we have to do the offloading footwear. The picture is not seen over here. So the sole aspect of the footwear is removed, so that if suppose the patient is having the forefoot wound, the sole aspect of the forefoot is removed, and the patient has to walk in such a way that he will take all the body weight on the hind foot and midfoot. So removing the pressure will help in the wound healing. So yeah, these are the pictures whatever I shown. This is the forefoot offloading, this is the hind foot for the heel ulcer, and these are the silicone soxes, which is soft cushion, which will give the soft cushioning to the plantar area. So coming to the angioplasty stenting. So in the angioplasty, generally the most commonly used approach is the femoral approach. So if the disease is involving towards the foot or the leg or up to the distal part of the thigh, will puncture the femoral artery in the antegrade manner, will pass the wire across the block, will pass the balloon over it, and will dilate. So here it is shown over here. This is a block, this is a wire cross across the block, and this is a balloon placed at the stenotic segment, and with the inflation of the balloon, whatever this arthrosclerotic material will be pushed to the side wall, and it will create a channel, and that will improve the blood flow. If with the angioplasty it is not tackleable, the lumen is not sufficiently opened up, in that case we have to place a stent. So stent will hold on that arthrosclerotic material to the vessel wall, and it will create a channel through the stent. So this is the case of the iliac stenting. As you can see, this is the aorta, this is the right iliac, common iliac, and the external iliac, and this is the left iliac. So you can easily see over here, shown with the arrow, the narrowing in the common iliac artery, which is treated with the angioplasty and stenting, and this is the post stenting picture. You can easily differentiate between the narrow lumen and the opened up lumen over here. So with this one, the blood flow will increase, and with the increase in the blood flow, whatever the gangrene part or the wound part, that will heal. So the another options are the bypasses. The bypasses can be done from the depending on the whatever the segment is blocked. So bypass intention is to carry the flow from proximal and carry to the beyond the blockages. So for the aortoiliac block, it can be bypass like a aorta to femoral artery bilateral. That is the aorta bifemoral artery bypass. This picture shows the superficial femoral artery block over here, and this is bypass with the femoral artery to popliteal artery bypass. And if the blockage is too long, involving the entire leg, in such a case the bypass can be done from femoral to distal. That is the posterior artery bypass. So coming to the few case results. So this is one of the case of the bypass. In this one, as you can see, this is a thigh portion. This is the femoral artery over here, and we have done the bypass from the femoral, distal femoral and proximal popliteal artery to the posterior artery. So we have taken the vein from the leg and bypass from femoral artery distal to the posterior artery. This is the vein and this is the artery. This is the proximal artery. So this is another case of the 90-year-old male diabetic with the gangrenous toe. So what happens if we see the diagram and just amputate without checking the pulses or without doing the further workup? So this is the case of the 91-year-old male. So in this case, the second toe was gangrenous, it was amputated at the outside hospital, and after that, after 1 month, this second toe and the gangrene spreads to the fourth toe also. So when he comes to me, so at that time I amputated this one and simultaneously I did the angioplasty. So this is a femur, this is a femur, and this is a superficial femoral artery. You can see the black contrast proximally, distally, and these are the collaterals, and this is a block. So post tending the block got opened up, and same patient had a blockages at the popliteal trifurcation junction. This is the anteritibial, this is the peroneal artery, and this is the block over here. So that block is opened up post angioplasty, and after that you can see the improvement. This is a 1-month ulcer, lower down. This is a 2-month ulcer, and this is a 3-month ulcer. I don't have the final picture, but you can make out the differences. So this is another case of the great toe gangrene. So in this patient, this is a popliteal artery, this is a tibial, this is a peroneal, and this is a posterior tibial. Posterior tibial is completely blocked below, no flow at all, so nothing to do with that. But the anterior tibial artery, you can see the narrowing here at the multiple area, and the peroneal artery also at the beginning you can see it is very much narrowed down. So post angioplasty you can see this block is opened up, even these blockages are opened up. So after that, there is an increase in the blood flow, and this is the wound picture at the 1 month. This is a 1 month, 2 month, and this is a final healed picture in around 4.5 months. So this is another interesting case of the aortoiliac block. This is basically the patient was a CKD patient, not on dialysis. The creatinine was 2.5. So the limitations are during the angioplasty we have to use a contrast. So whenever the CKD patients are there, we cannot use a contrast. Otherwise, it will further damage the kidney function. So in this case, I have used the CO2 as a contrast medium. So this is a picture of the CO2 angiography in which it will look as a white. So this is the aorta, and this is iliac artery narrowing over here. The distal part of the aorta also narrows. And so post stenting, I did the aortobiliac stenting. So you can see the clear flow in the aorta and both the iliacs post aortobiliac stenting with the CO2 angiogram without using any contrast. So this is another picture of the 76-year-old lady with the fibro-based gangrene. So this is also tackled with the angioplasty and stenting. You can see, hello, yeah, you can see the this is a common femoral artery. This is a superficial femoral artery which is very much narrowed down, and this is a deep femoral artery with the multiple collaterals. And the next segment to this one is this. So this block is containing like this, and with these multiple collaterals, this distal blood vessel is failing. So in her case, as the block is much proximal, I came from the opposite groin, crossed from the aorta to the femoral artery. We have crossed the block and placed the stent. So this is the post-stenting. This artery you can compare with this artery. This is a post-stenting opened up artery, and this block is well opened up. As you can see, as the blood got a primary passage to flow, the collaterals all are disappeared. So, and this is the final foot picture. So these are the common plantar arch. Yeah, that's it. Thank you.
So, any questions? May I request Dr. Kavishwar sir to felicitate our speaker, Dr. Chaudhari sir. Dr. Kavishwar sir, please come on dais to felicitate our speaker. Thank you. May I request Dr. Anil Shirke sir, President, to felicitate our chairpersons, Dr. Shinde sir and Dr. R. Shinde sir. The chairpersons for the next session are Dr. Suraj Madik sir from Akluz and Dr. Zadbuke sir from Temurni. The speaker is Dr. Prati Ajapuje. She's done MBBS DNB internal medicine in infectious. She's done infectious disease fellowship for 2 years, which is CDSI accredited. Her current designation infectious diseases consultant at Vishwaraj Hospital, transplant consultant at DY Patil Hospital. Her expertise areas are HIV, TB, fungal infections, gram-negative infections, transplant infections, joint infection, post-surgical infections. She has done research in 7 national and 1 international publications. Presented study on non-Candida East International Mycology Conference. So please welcome Dr. Prati Ajapuje. Her topic is fungal infections.
इथे मिनिमाइज केलं होतं कुठेतरी प्ले होते प्ले एक मिनटं इथे नहीं थोड़ा ना स्टार्ट स्क्रीन फुल स्क्रीनच दिला आहे फुल स्क्रीन दिला आहे येत नाही आहे का नाही केलं ना प्रेझेंटर व्ह्यू एक मिनटं थांबा इथून डाउनलोड करू का हां डाउनलोड कुठे येतं हो हे ओपन करा तिथे ओपन फाईल ना हां आलो सर आलो ठीक है so thank you organizing team and IMA Indapur for giving me this opportunity to present in front of you ठीक है so today I am going to talk on the fungal infection which is a very vast topic depend on the classification you can see from yeast to mold there are the n number of the fungi so this n number of fungi can cause to the n number of pathogenic invasive fungal disease so routinely in clinician with the physician even ID we generally face with the invasive fungal infection which is commonly due to the candida cryptococcus we commonly see in the HIV patient or the immunocompromised patients and most common even after everyone aware about the mucormycosis after COVID everyone has faced the rhinomaxillary mucormycosis as well as the pulmonary mucormycosis so it is a very vast topic so today I will try to cover up only on the candida which is very commonly seen even at the tertiary level even at the primary setup many physicians face to deal with the candida infections so as per the invasive fungal infection why it is very important to know and why it is important to diagnose at the right time because it accounts for the highest number of the mortality and morbidity of the patients. So as per this paper, there is a 70 to 90% of the invasive fungal infection is occupied by the candidiasis and then after it is a aspergillus which is most commonly seen with the pulmonary aspergillosis in the immunocompromised patient. So what are the disposing factors? Means in whom patient you will suspect that the patient is having the invasive fungal infection and whom patients you can categorize which are the host factors. So host factor are the patients who had underwent the allogenic stem cell transplant or the renal transplant or the liver transplant or the any patients who has a neutropenia where the neutrophil absolute neutrophil count is less than 500 for more than 10 days. And also the patient who has used the prolonged corticosteroid dose like in the rheumatoid arthritis patients or the SLE patients or even the interstitial lung diseases. So in such patient there are the prolonged use of the corticosteroids. So these are the host factor which are very prone for having a invasive fungal infections. And what are the risk factor? Like they are not the host factor. There are no any immunocompromised status previously but which can get acquired after the hospitalization. So who has a prolonged hospital stay, who has on the total parenteral nutrition, who is requiring a prolonged intubation in such patient or who underwent a major surgeries. So these are the patients who are the risk for developing the hospital even in the for the immunity get weakened so they can acquire the candidemia or even the invasive any other fungal infection. So coming back to the what are the diagnostic tool for the diagnosing this invasive fungal infection. So we have developed so many advances, we have developed new biomarker, fungal biomarker, but still blood culture stand to be the standard, gold standard for diagnosing the fungal infection. So whenever you are suspecting, whenever the patients come to your clinic or patients getting admitted to the ICU or patient presenting with the fever, try to set that tradition that you will before giving antibiotic, collect his blood culture and send for the culture. So that is the standard practice you should know because whenever patient come to clinician or whenever patient shifted to the tertiary care center, he had already received n number of the antibiotics and then considering the blood culture, the yield will come to the less than 20%. So whenever at the tertiary care, I hope you have a good lab where the at least blood culture should be done. because at every tertiary center, even in the primary center, blood culture is doing, and they are well set up with the blood culture procedure. So try to take the blood culture, which is still the gold standard for diagnosing the invasive fungal infection. And another fungal marker which was recently developed in last 1 decade, that is a galactomannan and BDG. I think most of the physician must be aware of the BDG, because after COVID, the people started sending this biomarker. So these are the biomarkers which can detect before your blood culture come positive. This biomarker can tell you whether that patient is harboring candida or aspergillosis. So, but as these new advances, this new biomarker, these have all drawbacks also, because if your patient is on the PIPTAS or if your patient is receiving blood products, so this biomarker can come falsely positive and you will end up treating in the wrong invasive fungal infection. So before that, whenever you send this biomarker, have a thought ki why, whether our patient has received blood product, have our patient received albumin, and has that patient is on the antibiotics. Then after, because this biomarker, the cost is expensive. This galactomannan and BDG, it cost you around 8,000 to 7,000. So most of the time patient is not that much paying class. So before sending the biomarker, have a thought and have a pretest probability ki whether are you really suspecting the candida in this patient. So that's why your risk factor and host factors are always important to keep in mind ki whether that patient is harboring or candidate for sending this biomarker or not. So coming to the another biomarker, which is a cryptococcus antigen, which is cryptococcus infection meningitis is commonly seen in the HIV patients. So this antigen has a excellent sensitivity. Like if it is cryptococcal meningitis, it will come definitely 100% positive. So this is the excellent test. If you have any HIV patients and you are suspecting if the CD4 count is less than 200, so definitely from the CFCF and from the serum, you should send the cryptococcal antigen, because it will clear-cut rule out your cryptococcal infection in such patients. Another fungal marker is urine histoplasma antigen. So urine histoplasma antigen has another fungal marker which can give you the definite sensitivity. We had presented one poster at the International Mycocon conference where the histoplasmosis is generally seen in the immunocompromised patients till now. And we used to say it is most in the Gangetic belt, Delhi, Bihar or Kolkata side. But no, it is the epidemiology is changing. Now we are also getting the patients who are the immunocompetent and still they are having a disseminated histoplasmosis. So till now we had almost 7 to 8 patients in the immunocompetent patients who had a disseminated histoplasmosis. But these are the rare things. Primary is the candida, how you should diagnose the candida and the aspergillosis at your center, or which is going to be helpful in your routine day-to-day life practices. So another marker for the diagnosing invasive fungal infection are the biopsy. If you are suspecting that patient is having a pulmonary aspergillosis, and if you are considering the bronchoscopy, so sending a right sample in a right container is always important. So sometimes we get the call कि मैम bronchoscopy हो गया है and अभी sample सिर्फ formalin saline में ही है. So I cannot run the culture, I cannot run any biochemical markers on that, I cannot do anything. Apart from histopath, I am not getting anything clue, because on histopath you will see the angio invasion. What, you are not going to know the species name, you are not going to know the susceptibility pattern for that species. So you are in the middle of again that situation of the confusion ki you don't know what to start, because not all antifungal have the activity against the all fungus. So you have to realize ki whenever the procedure is going to happen for any patient, like if you are going to do lung biopsy, if you are going to do face, or if you are going to suspecting any spine infection which are going to be a fungus because that patient had received a steroid, that patient had received multiple antibiotics. So try to communicate with the surgeon that we want only 1/3 sample in the formalin and rest of the 3/4 sample we want in the normal saline. So the procedure, if you don't get anything in the normal culture, then you can plan to process on that sample. So that's how you can save that patient's money as well as you can save that patient's time also. So try to do that at the your level, because that's what I always face challenges while I'm roaming around the hospitals. After surgery they call me. No, ID or physician role don't start after surgery or after report. Ma'am blood culture का report है आप treat करो. ऐसा नहीं होता है. The role start from the beginning of the patient comes to your ICU or patient is land up into the crisis. So it's not only that we treat the reports, we treat the patients. So another tissue diagnosis is always the gold standard. Try to take, if you are suspecting any pulmonary aspergillosis or if you are suspecting any maxillary, rhinomaxillary mucormycosis, try to get the tissue sample. Sending a swab is never been the sufficient. Swab bhej diya or throat swab bhej diya. So that is not going to give you conclusion, because so many microbes are going to have a colonization in your nasal flora, in your throat flora. So you will not get the exact pathogenic organism in that sample. So try to get the exact sampling which will represent your pathogenicity. Then another advising KOH, calcofluor is also helpful in diagnosing your fungal infection. So this state, I guess blood culture and KOH and calcofluor staining can be done at any center, or even in the short setup also, where there are not many microbiologists. We don't want any excellent microbiologists for that, but still you can advise this basic test which can give you clue for diagnosing your patients. So coming to the antifungal drug spectrum, so as I said, not antifungal cover everything. So if you can say in this chart that fluconazole don't have any activity against the mold like aspergillus or even for the mucor. Giving voriconazole even is the very dangerous for treating the mucormycosis, because we have seen many patients that they have diagnosed the mucormycosis or they are suspecting clinically mucormycosis and they randomly keep that patient on the voriconazole. So it is not helpful, but it is very harmful for treating the mucormycosis. In fact, fluconazole has a very limited activity for the even candida, as we have used rampantly empiric antibiotics as well as empiric antifungal is commonly used. Whenever I go to the ICU for any reference, then I see the chart, Mero, Tico, fluconazole. Why it is giving? No one knows. Fluconazole, it's like a mirch masala. Everyone gives that. So that is the fact. I know most of the clinicians will deny this, but this is the fact that I'm seeing every ICU. So fluconazole, it's not the thing you can give empirically. We have used so much empiric antifungal drugs without thinking anything why we are treating or what we are treating. Now fluconazole getting resistance also. So we have presented a poster on the international conference कि fluconazole started resistant and the many species are getting resistant for the fluconazole. Now you don't have a fluconazole option. So look at the era we are entering, which is a very easily available drug, which is cost effective. We are not having that drug going to act on our patient. So please precisely use that antifungal in your clinical setup. So these are the antifungal susceptibility, that some of the candida species are inherently resistant to the fluconazole. So some of the time, most of the time, we left with the choice of the echinocandins, amphotericin and flucytosine. So candida are the normal colonization of the skin, GI tract, urinary tract and upper respiratory tract. So if anytime in your ICU, if patients come and intubated, and if you have sent the ET culture, which is a normal trend in every ICU setup. So if in the ET culture the E is seen, so will you treat that? Any physician? Would you like to treat? That patient is requiring high FiO2, that patient is spiking, and if ET culture has been sent, so will you treat that? And the microbiologist told you, ma'am, yeast are seen, candida is growing, so will you treat that? Any of you? So Arunaloke Chakraborty sir, who is a godfather in the mycology in our India, at least and international level. So if you get a call from lab that ET culture, sputum culture or urine culture suggesting of your candida, and the colony count is more than 10 raised to power 5. So still, if the colony count is 10 raised to power 50, still I will not treat in ET. Because that is not the pathogenicity. Candida pulmonary is always caused the abscesses. It is very rarely seen, less than 1%. So never ever treat ET colonization with candida. That is always a colonization. There has to be some other pathogen. So never start with the antifungal. They are not to be treated. So, and sometimes we are in the fear, we cannot ignore the candida. How we can ignore? We should treat it. So you are not treating it. You are just giving them fluconazole. They are not the deficiency of the fluconazole. They are not the deficiency that intubated and then you have to give the fluconazole. So that is not the sin. So please keep in mind, whenever the patient has a VAP, whenever patient has a pneumonia, Candida is the least pathogen. Candida is always seen in the fungal infection, most of the time in the immunocompromised patients, or either they are from the prolonged ICU stay. So always think in that way, not to treat for the ET secretion at least. And even if the patient come with the urine culture that yeast is seen, mostly it says कि 15 to 20 pus है, and patient को कोई urinary symptoms ही नहीं है, but yeast है तो दो fluconazole दो. So that is not the sin. Even asymptomatic candidiuria we don't treat in post-renal transplant patient. So there are the new guideline come, even in the asymptomatic candidiuria we don't treat in the post-transplant patient, and our patient to immunocompetent. So we need not to worry, we should ignore that, and we should always try to find out the exact cause of their symptoms, not to treat from the empiric pathway. So that is what I wanted to tell every time in every conferences. Please don't give empiric antifungal, because we are landing in the crisis of resistance, and then we won't left with any antifungal of the choices. Then these are the most common species among the Candida seen is the Candida tropicalis. In our center, Vishwaraj also, we have seen the Candida tropicalis is the most common cause for the candidemia. And after that, Candida parapsilosis and Candida albicans. So this was the data. Now coming to my cases, I have only 2 cases. So this is a 68-year male known case of diabetes and hypertension who is presented with the fever, abdominal pain, burning micturition and nausea. His lab parameter is leukocytosis was there, WBC count was 20,000, creat was 6.4, procal was done, so it was 0.65, and urine routine micro shows 20 to 25%. CT-QB was done because he had a renal angle tenderness also on the part of the examination, and it had found that he has a bilateral hydroureter with hydronephrosis with the calculus. So he had underwent a digestenting. Whenever the patients come to our casualty with the complaint of fever, or if the patient is seen to be a sepsis, he has a red flag signs for the sepsis, we first send the blood culture, that we have set the trend, and it is very easy to follow in every setup. So I will recommend that you also start that tradition, send the blood culture, you will definitely get some yield, and it will improve your patient's outcome. Definitely it will also make you help to improve your antibiotic therapy also. So on third, he underwent the digestenting with bilateral ureteric dilatation. We have started on the meropenem. And then the blood culture and urine culture, both culture had grew pseudomonas, which was carbapenem resistance. So then we have done Zavicefta aztreonam synergy, which comes to be luckily positive for that patient. And he had received 14 days of antibiotic. He was doing well, catheter was removed, central line was in situ. And eventually that patient get out of the ICU. The fever was subsided, creatinine come down to the normal. But after stopping Zavicefta aztreonam, after 14 days of completion of therapy, he started again getting a fever on post of day 17. So, but he is on the empiric fluconazole, because every time you cannot, I can say in many conferences, but then your colleagues has to accept that also. But because that patient has a bilateral digestant, that patient has a urinary catheterizations, so they had been started on the fluconazole. So any thought what could be the cause for the fever? We had sent the repeat urine culture, blood culture. He never had a urinary symptoms after that. So any thought you want to upgrade antibiotics, you want to start any other things? What should be done to that patient? Or should we continue that Zavicefta aztreonam again? Anyone feel that duration of the therapy is not enough for this patient? So his central line was C2. We have sent his blood culture and urine culture. So not to surprise to this patient that blood culture had grew Candida parapsilosis. So this is what I'm saying, even on the empiric fluconazole, you cannot prevent the next event of the candidemia. So you are not giving benefit of anything, giving empiric fluconazole to any patients. You cannot prevent candidemia because if most of the species are resistant to the fluconazole, so you are just wasting that fluconazole, or you are just increasing the cost of that patient's therapy. So then blood culture had grew Candida parapsilosis, and you can see that fluconazole comes to be resistant, and MIC was more than 32. The exact MIC we want for the sensitivity is less than 8, and it is more than 32. So then central line was removed. We have started him on the micafungin because only blood culture has glue. He had candidemia. He didn't have a candiduria. Because if you have a urinary tract infection associated with the candida, the echinocandin don't penetrate to the urinary system. So you have to start with the amphotericin, or you have to start with the 5-fluocytosine. Echinocandins have less than 1% penetration to the urinary tract. So you have to think what system you are treating. Does my antifungal penetrating well? Are the dosing are done rightly for that antifungal or not? And whenever there is a candidemia, you have to, there are the guidelines that you have to do 2D echo by per se, by the protocol and the fundus examination, because candida has a propensity that it can disseminate, it has a hematogenous spread, and it can lead to your infective endocarditis and even candida retinitis. So you are always have to do the 2D echo to rule out whether there is vegetation or not, and fundus examination irrespective of the symptoms of the patients. In every candidemia, you should do this two tests by the protocol. And repeat the blood culture after 48 hours is mandatory in treating the candidemia, because you have to see the clearance whether your drugs are proper and whether the clearance has been done or not. Because if after 48 hours the patient's having this still growing the candida in the blood, then you have to think whether any other source in the body is there, whether you have to figure it out whether the drugs are not enough, why patient has a persistent candidemia. So then your treatment line, your duration also increases, your duration becomes 21, because on the second, when the first blood culture come negative, only after that you have to give the 14 days of antifungal therapy. So that is all the mandatory things. So we have presented this, published this paper on the fluconazole resistance in the international journal, which is the medical mycology. There is an increasing resistance of fluconazole for the candida species also. And the number has been increased. This was the study was published in 2022, 2 years back. 3 years back, the isolate was 9. And now we have continued this study, which shows the isolate is almost around the 50. So the numbers are increasing. So please carefully use the antifungal to any of your patients. So these are the things that I have already mentioned, that you have to repeat the blood culture at the 48 hours. You have to do the 2D echo. You have to do the fundus examinations also in the case of invasive candida infections. And then asymptomatic candiduria, that already we have talked, that we should not treat the asymptomatic candiduria, but only there are the 3 conditions that you need to treat the asymptomatic candiduria. In the neutropenic patients, like the patients who had underwent the bone marrow transplant, only in the bone marrow transplant, because these patients have the neutropenia. And then very low birth weight infirm, whose weight is less than 1.5 gram, and the patients who are undergoing a urologic procedure. So patients who had already candida, or if you are doing the urine culture and your urine culture came to be positive, so while doing urological procedure only you have to give the antifungal therapy, because while doing the urological procedure the dissemination can happen and then they can land up into the candidemia. So only in 3 conditions you have to use the antifungal therapy. Apart from that, asymptomatic candiduria not to be treated. Yeast is always seen in urine culture. Most of the 90% of the urine culture you will see that yeast is seen, always been there. So please ignore until and unless patient don't have any symptoms. If patient have symptoms, definitely you need to treat it. Then you don't need to ignore. So this is my second case. This is a 61-year female who is known case of the hypertension. Admitted outside with the complaint of fever and abdominal pain. Then she was referred to our Vishwaraj hospital with the worsening hypoxia and the hypotension. On admission, patient was drowsy. She needed intubation because her saturation was 84%. BP was 80/50. She required inotropic support. And on lab investigations, procal was mildly raised, that is 0.61. And she was already started on the meropenem, tico, fluconazole. So we only continue for meropenem, and we had stopped ticoplanin and fluconazole. So looking at the CBC report, looking at her chest X-ray and everything, we thought it is a viral infection, likely H1N1 or either COVID. So we had sent the upper respiratory biofire and the swab also, which come H1N1 positive. So we had started her on the Fluvir. This was the first CT of her on the time of the admission. You can see there are the multiple GGOs, almost involving the 3/4 of the lung on the both side. So 4 cycle of proning cycle was given. She improved on that. We have switched to the Magnus-Ford because blood culture, ET culture, nothing was growing. So we have switched to the Magnus-Ford and Fluvir was continued. Intubated on day 8. And she was for the hypoxia and bronchospasm, she was on the hydrocod, and then eventually by the pulmonologist was kept on the steroid. So after extubation on the day of the 4th day, she had again started having a hypoxia. So as we know, H1N1 and COVID, mostly H1N1 has associated with the pulmonary aspergillosis. These are the risk factor for the pulmonary aspergillosis. So we had sent her serum galactomannan, which comes to be 1.4. The range is less than 0.5 considered to be the normal range, and it comes to be the 1.4, which is highly significant. Then we have done her bronchoscopy. Bile sample also came to be the positive for the galactomannan. We have started on the posaconazole, which is a drug of choice for the pulmonary aspergillosis, as we all know. We had stopped protein pump inhibitor. These are the strong drug interaction. You have to see all the drug interactions also, because if patients on the antacid, then it will decrease your posaconazole level. Then definitely you will have a suboptimal therapeutic level of the posaconazole, and patient eventually will not improve. And then I have to bargain with my pulmonologist that please taper a steroid as soon as possible, because steroid and pulmonary aspergillosis both are the disaster being in the one system. So taper the steroid whenever you are dealing with the invasive fungal infection. If the patient on the steroid, try to discuss with your other faculty and other colleague that steroid should be tapered off as soon as possible. So then we have done her serum trough level, drug levels as we have done, and to our surprise, it trough level comes to be 0.3. We want more than 0.7. So then we got the reason that though we have diagnosed well, though we have kept her on the right drugs, still the patient was not improving. Then this is the third we go on that the drug level was not enough. That's why the patient was not improving. It's not that we are diagnosed wrongly or drug was not right, but the drug level was not optimal enough. There are the multiple factors which can affect your drug level. So then we have increased her level posaconazole to 400 mg, but still the level come to be low. So then we have to switch to the other antifungal drug, which is a isavuconazole. So isavuconazole has a better absorbability in the system. It has a very less interaction with the other drugs, right? If pulmonary aspergin in SLE patient if I found and these have a interaction, posaconazole has a strong interactions with your MMF, with your tacrolimus, but isavuconazole has very less interactions with this drug. So we have switched to the isavuconazole, and this was the last scan of these patients. After 8 weeks, we have continued therapy till the 8 weeks, which is indicated in pulmonary aspergillosis for 6 to 8 weeks. And this was the scan. The first scan was done on the 8th August, second scan done on the 20th August, and third scan was the 20th November. So you can clearly differentiate the difference between the HRCT even. The patient went to discharge on home on the home oxygen, and the patient came to my OPD with no oxygen and walking. So that's what the satisfaction you get when you do the things right from the starting point. You should not compromise at the time of the diagnosis, because then your therapy and your outcome will again be compromised. So that is, I will summarize my talk that high index of suspicion should be kept in the patients like who are at the risk factor or who are the host factor. try to discuss whenever there is a diagnostic utility. We have to discuss with your microbiologist, discuss with your colleagues who are pulmonologist, your radiologist, your microbiologist are equally important to give you the clue for these invasive fungal infections, because they are equally important. And all attempts should be made to get microbiological evidence. I know sometimes tertiary care or the primary setting or at the PhD level it is not possible, but try to get the all microbiological evidence, or try to get send to sample to such lab which can give you the good results. So whenever you are planning or whenever you are thinking that this my patient is having any invasive fungal infection, so before sampling, plan your things. If you are doing any procedure or anything, send that sample to the proper lab, so you will get the proper outcome from that patients. And definitely optimizing your antifungal therapy is equally important. Thank you so much.
Any questions? Thank you very much, ma'am. May I request Dr. Kavishwar ma'am to felicitate Dr. Prati. Dr. Kavishwar ma'am. Thank you very much. Thank you very much. Our next speaker is Dr. Mahesh R. He's a consultant nephrologist and transplant physician. He has a 15 years of experience. He's done MBBS, MD Medicine from BJ Medical College, Pune, DNB Nephrology from Nadia, Gujarat, Fellowship in Special interest in connected kidney injury, dialysis, and renal transplant. He's presently working with Vishwanath Hospital as a consultant nephrologist and transplant physician since last 7 years. His topic is renal transplant.
Good afternoon, everybody. My topic given was renal transplantation, but I am going to give you an overview about renal replacement therapy. See, whenever a patient is having chronic kidney disease and the GFR is less than 10, that is the time when the patient is going to require some kind of support, and that support can be in the form of either replacement of the kidney. Support means either put the patient on dialysis or change the kidney of the patient by doing kidney transplantation. So in the coming slides we will be discussing in short what are the indications for renal replacement therapy, briefly about hemodialysis, and finally we'll be coming to our main topic, which is kidney transplantation. So whenever a patient's GFR goes below 10%, I am specifically talking here about chronic kidney disease patients, and the patient is having hyperkalemia, metabolic acidosis, fluid overload, uremic pericarditis, or other non-specific uremic symptoms, like the patient is losing weight over a period of time, the patient is having persistent nausea, like specifically people will say that घरात फोडणी जरी दिली तरी उलटी आल्यासारखं होतं. That is specific nausea for patients with chronic kidney disease. Then in advanced stages, even the patients will have very impaired cognition. So these are the indications for starting renal replacement therapy in chronic kidney disease patients. So whenever a patient is diagnosed to have CKD stage 5, that is the time when the patients will be offered treatments either in the form of dialysis, which can be hemodialysis or peritoneal dialysis, or straight away the patient can be initiated on kidney transplantation. See, in this slide, this is a data from USRDS. This data is very, very old. It's almost 10 to 11 years old. But what we can see very clearly in this slide, what we can see in this slide is that the number of patients who are developing chronic kidney disease is increasing by the day. The number of people who are put on dialysis is also increasing. But the people who are being offered transplantation and the people who are put on peritoneal dialysis, the two lines which you can see at the base is the people who are on transplantation and people on peritoneal dialysis. So with every passing year, the number of patients who are diagnosed with chronic kidney disease are increasing, and most of these patients are being offered dialysis, and in dialysis also most of the patients are being offered hemodialysis. Peritoneal dialysis is not very prevalent, or it is not even offered by most nephrologists, and even if it is offered, people are not very receptive to start peritoneal dialysis. The most common treatment, that's why, which is being offered is hemodialysis, and the number of hemodialysis patients are increasing day by day. But if you compare that with the patients who are receiving kidney transplantation, it is very, very less. And this data, though it is very old, even 10 years down the line, the data and the graphs remain almost similar. Again, this data is from USRDS 2013, and here you can see that in USA, the healthcare is funded by the government. And here you can see that the bottom graphs are, the bottom graphs you can see is the Medicare cost, which is done on patients with hemodialysis. And the top you can see that this is the amount which is spent by the government on peritoneal dialysis and renal transplantation. So even this data shows that the patients which are being offered hemodialysis are more, and the patients receiving kidney transplantation or peritoneal dialysis are very, very low. This has been commonly found in clinical practice of every nephrology center or every tertiary care centers, that the patients who are diagnosed to have CKD are referred quite late in the course of their illness. And most of the times they are being managed at primary care level. And when the patient's GFR goes very low, when the patient starts vomiting, then they are referred directly for initiation of dialysis. So I strongly appeal to all of you that the patients should be referred early when the GFR is starting to go just below 30 ml per minute. And why this is important? Because whenever the patients are referred to us early, that is the time when we can actually start discussing with the patients options of the therapy. Whether, starting dialysis would be very late. It would be when the GFR will go below 15 in cases of diabetic patients and less than 10 in the patients with non-diabetes. So early referral, it is going to help in optimization of the therapy, retarding the progression of the chronic kidney disease. And when the GFR starts going below 20 ml per minute, that is the time when we can start discussing with the family of the patients regarding whether they want to go for hemodialysis or whether they want to consider kidney transplantation. And if they opt for hemodialysis, or if they are undecided whether they want to do transplantation or hemodialysis, that is the time when the patients should be offered doing AV fistula, because that is how you can avoid dialysis catheter insertions and subsequent infections because of the catheter insertions. Also, you should be aware that try to avoid central line insertions wherever it is not necessary with patients with CKD, so that there are no IGV blocks or thrombosis in such patients, because vascular access again is a major issue for patients with hemodialysis. So it has been clearly documented in various studies that early referral of patients with progressive CKD to a nephrologist or a higher center, it improves the patient preparation for renal replacement therapy. Because that way you can have a greater use of permanent vascular access by constructing early AV fistulas for this patient, by trying to avoid catheter insertions in such patients, and avoiding the need for emergent hemodialysis insertions. That is the time when we can discuss about the modalities of renal replacement therapy with the patient. If a patient is amenable to starting peritoneal dialysis, then when the GFR is less than 15, that is the time when they can be counseled regarding peritoneal dialysis or home hemodialysis for that matter. And even modifications in medications to retard the progression of the chronic kidney disease can help in a long way to prevent the need for dialysis in near future. Also, another important thing which is very easily missed many a times in major centers also is vaccinations in chronic kidney disease. See, any chronic kidney disease patient, even if the GFR right now is 50, but we need to understand it is a progressive disease. So there is going to be a time in the life of that patient when the patient is going to be on dialysis, maybe 6 years down the line, 7 years down the line. So you should not forget that this patient is going to be exposed to a dialysis center where several patients are going to be undergoing dialysis at the same time. So this is the time when cross infections can happen and patients can develop hepatitis B infections or other infections. So the role of vaccination is very, very important. See, commonly triple H is done for patients requiring hemodialysis. One is HIV, hepatitis B and hepatitis C. Out of this, only hepatitis B has a vaccine. So whenever a patient is diagnosed to have chronic kidney disease, he should be offered hepatitis B vaccination. And the vaccination dose, the immunologic response for CKD patients is low. That is why a double dose of hepatitis B vaccination is given to CKD patient. So 1 ml which you give intramuscular and deltoid in normal people, in CKD patients it is given 1 ml in each deltoid, this deltoid and both deltoid at the same time. Many a times we get calls from the hospitals whether I have written that by mistakes that it is to be given in each deltoid. See, 2 ml you cannot give in one deltoid because deltoid is a small muscle. So you have to give 1 ml intramuscular in each deltoid. And the dose should be 0 month, 1 month, 2 months and 6 months. Normally you give 0, 1 and 6 months. And after 1 year also you should check anti-HBS titers, because the immunological response of the anti-HBS titers is very low in such patients, and that is why they may need booster doses or re-immunization completely in CKD patients. Other vaccinations like influenza vaccine, which is given annually, should definitely be given to CKD patients, and polyvalent pneumococcal vaccines for patients who are receiving immunosuppressions, nephrotic syndrome, diabetes population and elderly population should be considered in CKD. This is the same slide. Yeah. See, now once the patient has been referred, he's been following up the nephrologist, now the time has come to initiate dialysis. If the early referral to the nephrologist has ensured that the patient has been constructed an AV fistula instead of an emergency dialysis by putting a IJV catheter or a femoral catheter. See, in hemodialysis also, see, hemodialysis is a simple procedure where you are just purifying the blood by diffusion from with the help of a dialysis machine and a dialyzer, right? Here I want to not go into the details of dialysis, but I want to just brush upon two important guidelines here, because see, we are not aware that patients have vascular access issues in dialysis population, and vascular access people literally both their arms are used up, like multiple vessels are used and all the fistulas have failed. the IJVs are thrombosed, so these patients are in a situation where there is no vessel available to construct a vascular access. So it is very, very crucial that very early in the stage of GFR, like when the GFR is 30 to 40, we should start preserving the arm vein. Whatever IV cannulations you want to do, it should be done on the dorsum, and you should try to preserve the arm veins. Specifically, fistulas are concerned in the non-dominant hand, but you should try to preserve the arm veins of both the arms. And subclavian catheter, vein catheterization should also be avoided, because these veins usually develop stenosis very early. So save the non-dominant arm for vascular access is very, very crucial for patients who are going to be initiated on dialysis later in their life. No BP measurements in that non-dominant arm, no IV cannulations, no blood draws, and place vascular. This is for people whom you are anticipating that you are going to do a vascular access placement within a year of hemodialysis. Within a year, the dialysis is going to be started. See, now why have I started with, though my topic was kidney transplantation, why have I started with all this renal replacement therapy, hemodialysis, AV fistula? Because these were very important things. And now I'm coming to the main thing. See, even if we are referring the patient early, everything is being done, medicines are being optimized, patient's fistula has been concerned, we are trying to avoid IJV catheterization, everything is being done, vaccination is done. But despite the patients being on 2 per week or 3 per week dialysis, if you see this data, the survival rates on dialysis are really, really dismal. At the start of dialysis, 1 year mortality is somewhere between 10 to 29%, which is very, very huge. And in rural population, it has been found that it can be up to 30% more. See, there is no CKD registry in India. So all of this data is anecdotal. In foreign countries, the data collection is very properly done. There are registries maintained, there are USRDS. But in India, there is no registry where all this data is maintained. But this data is real. 1 year mortality for patients who are started on dialysis is between 10 to 29%. And at the end of 5 years, only 40% of patients who are started on hemodialysis are alive. Only 40%. Peritoneal dialysis offers a slight survival advantage. At the end of 5 years, you will see that 50% of peritoneal dialysis patients will be alive. But this data is really, really startling, and that is why whenever you utter the name dialysis in front of patients or relatives, they are really in a shock and they want to do everything. They request you that काही केलं तरी चालेल पण आम्हाला डायलिसिस चालू नाही करायचं. They are literally in fear. They have stories where they know that some relative, some neighbor was started on dialysis and he died within 6 months, he died within a year, he suffered from a lot of problems. So there is a lot of fear on dialysis. But see, even if you do things properly, many things can, like complications can be avoided. But this data will not change like drastically. Like the mortality will come down with many measures, but still this data is very, very startling that at the end of 5 years, just 40 to 50% of your patients are alive. And what is the main cause of mortality of these patients? See, it is said that whenever you develop chronic kidney disease, you get a free gift of cardiovascular disease. And even if patients are not started on dialysis, like let us take an example of a patient whose creatinine is say 2.5, or in terms of GFR, if we say that the GFR is 40 or 50, still that patient's cardiovascular risk and the risk of death from cardiovascular disease is 10x compared to another person who is same age, same everything, socioeconomic status, everything same, but the risk of death from cardiovascular disease is 10x. And obviously, same patients, when they go on dialysis, the risk of dying from cardiovascular disease is going to increase further exponentially. So the primary cause of death in hemodialysis patient One is cardiovascular disease. Second is infection related. Either it can be line related or sepsis from other causes. Another important thing which is usually not addressed is nourishment or nutrition of this patient. See, for any of us sitting in the audience, the protein requirement is 0.8 gram per kg per day. Whenever some CKD patient is there and he is not on a stage of dialysis, his protein restriction would be 0.6 gram per kg per day. Here we are reducing the protein by just 25%. But now the same patient who is now put on dialysis, his protein requirement is now 1.2 gram per kg per day. So it is doubled from what it was before. And the same patient, if he opts for peritoneal dialysis, it is 1.5 gram per kg per day. And data has clearly shown that patients who have malnutrition, see, even albumin, serum albumin level 4, which we think is normal, patients with serum albumin levels less than 4 have been found to have a higher mortality rate. Here I am specifically talking about patients who are on dialysis. I am not talking about the general population. So other reasons for dying on dialysis is cerebrovascular accidents, repeated admissions with fluid overload or pulmonary edema, withdrawal from dialysis or vascular access failure. It has also been seen that the dialysis efficiency, which is calculated by KT by V, it is ideally supposed to be more than 1.2. So KT by V less than 1.2 contributes to more mortality on dialysis. Similarly, dialysis frequency, patients doing 2 per week dialysis versus patients doing 3 per week dialysis. The mortality is more in patients doing 2 per week dialysis. And this point which I just mentioned, albumin levels, serum albumin levels less than 4 also contribute to malnutrition. It's a pointer of malnutrition, and it causes increased mortality in patients with chronic kidney disease on maintenance hemodialysis. Also, it has been found that diabetes patients, female gender, and higher interdialytic weight gains also contribute to higher mortality on dialysis. So, obviously, now we know that whatever therapies are available for patients with chronic kidney disease, one is being on dialysis, second is offering a kidney transplantation. See, in kidney transplantation, either it can be a live related kidney transplantation or from a deceased donor. The major difference here is in hemodialysis, what you are doing dialysis 2 times a week or 3 times a week. Still, you cannot correct the uremia completely. There are so many things. Because of the high urea, the cardiovascular death risk is going to be there. The effect on other organs is going to be there. There are other factors which are not going to get corrected, like anemia, dyselectrolytemia, so many things, the PTH levels which are high. So, for a patient on maintenance hemodialysis, though he is doing dialysis 2 times a week, 3 times a week, he still has to be dependent on erythropoietin, protein supplementations, antihypertensive drugs, and protein supplements and other things. And we also have seen that the data shows that the death rate of maintenance hemodialysis patients is really, really high. So that is why kidney transplantation is a very, very good option for patients on chronic kidney disease. See, patients, many people think that for kidney transplantation, the original kidneys are removed. The original kidneys are not removed. Kidney is removed from the donor and it is transplanted in the right iliac fossa. God forbid the right kidney fails, this kidney is also not removed. 4th kidney is placed in the left iliac fossa. So this kidney is removed along with the renal artery, renal vein, and ureter. And a new ureter is being made in this bladder, and just because that the stitches should heal properly, a DJ stent is inserted, which is removed after 1 month. The absolute see, now transplant also cannot be everything is goody goody and no problems at all. Everything is going to have its own bag of good things and bad things. So there are certain contraindications for the recipient, which obviously if you are having these contraindications, you cannot be offered or considered for kidney transplantation. So if a recipient has active malignancy or advanced lung disease or ongoing infection, or for that matter advanced cardiovascular disease which is not amenable to revascularization, and the life expectancy is very, very less, so such patients shouldn't be even considered for kidney transplantation. Liver cirrhosis, primary oxalosis, unless and until it is done with a combined kidney and a liver transplantation, primary oxalosis also is a absolute contraindication for kidney transplantation. Also, poorly controlled psychiatric illness and morbid obesity also is a absolute contraindication, not a relative, absolute contraindication for kidney transplantation. See, now coming to the transplant donor type, either it can be live related, and in live related we consider parents, sibling or the spouse as the immediate options for live related kidney transplant. Preferably the age should be more than 18. Textbook mentions less than 55 years, but see, for practical reasons, in Pune itself, the donor of 77 years was accepted. He was a villager and was in very good health condition. So all the tests were good. So that donor, see, these are exceptions. So ideally, a donor should be like somewhere between 60 to 65 years, provided that the patient doesn't have diabetes, hypertension, IHD, or any communicable disease. So in short, the donor should be a completely healthy individual and highly motivated to donate the kidney to his relative. And obviously for the deceased donor, those who do not have this option of receiving kidney for a family person, see, nowadays even the blood groups are matching. Relatives are not willing to donate their kidneys to their family members. So a lot of people are getting added on wait lists of deceased donor. But here the problem is that, see, on an average in any good city where there is good awareness of deceased donor transplantation, even then on an average in a year 30 to 35 kidney transplantations are done, the cadaveric transplantations I am talking about. See, the transplantation, the basic concept is there. Your body has an immunity, right? Your body, see, immunity recognizes each and every organ of your body, each and every cell of your body. You are taking an organ from your relative and trying to put it in your body and expecting it to work properly, right? Here your immunity is going to kill it because it is going to detect it as a foreign body. So this is called as rejection. So obviously we do not want rejection, and we want that kidney to survive as long as possible, and that the patient should not need dialysis. So obviously here your immunity is acting as your enemy. So what is done? You are suppressing the immunity of the recipient. It is suppressed with the help of steroids, tacrolimus and mycophenolate mofetil. These are the three standard drugs which are being offered to a recipient. If the donor is like sibling or parent, you do not need induction. Induction is optional. If the donor is spouse, obviously the HLA match is not going to be there. So such patients, either basiliximab or rabbit ATG is offered as an induction agent. And see, the more immunity you are going to suppress, obviously there is going to be a risk of developing more and more infections, right? So you are at one end trying to prevent rejection, at the other end you are trying to prevent infection. So you are, a life of a kidney transplant recipient is always like a walk where you are trying to avoid falling on this side and that side. But see, it is not that difficult as I am trying to make it sound. See, to avoid infections, two most important things to be done. One is the infection can come from the air or from water or food which you are going to eat. So kidney transplant recipients, whenever they are visiting the hospital or a crowded area, they should use a simple mask is also okay. No need to use an N95 mask. Second thing is you should eat fresh food which is home cooked. Even you can eat from a good restaurant where you are aware of the hygiene of the food. water should be boiled and cooled, or you can drink from RO or Bisleri water or whatever mineral water is available, packaged mineral water is available, right? So now coming, see, we in the previous slides already saw that the dialysis survival is just 40% at the end of 5 years. Here you can see that at the end of 5 years, the graft survival is 75 to 80%. So now let us see if we take 5 years as the benchmark. Even if 75 to 80% grafts are surviving, the patient survival is even more in that patient, right? So at the end of 10 years, 60 to 65% grafts are surviving, but more patients are surviving than that. And in fact, the factors which are affecting survival, see, the age of the donor as well as the age of the recipient. A younger recipient as well as younger donors, both are going to have better survivals. Pre-transplant dialysis duration, the longer, like suppose you are on dialysis for 5 years, 10 years, that is how what happens, you developed antigenemia, and that can lead to more and more episodes of antibody mediated rejections late even after you receive kidney transplantation. So that means more immunosuppression and more risk of developing infections and more risk of dying. Non-adherence to medications also can lead to graft loss. And factors affecting survival, see, in a live related atmosphere, it is a controlled atmosphere where you are going to plan a surgery according to your convenience. A cadaveric transplantation, what is happening, you can get a phone call at the mid of the night, right? And you do not even know whether your kidney transplant recipient who is registered with you from some remote place is in good shape or not. You have to just rely on that phone call. You call the recipient and ask him whether you have dialyzed recently, you are not missing dialysis, you have infection, fever, etc. So you rely on that and you just call the recipient to accept the kidney, right? So obviously in cadaveric transplantation, the survival rates are slightly lesser than in live related kidney transplantation. Even in transplant patients also, cardiovascular disease is the highest cause for death, and death with a functioning graft. See, graft is not going to get damaged or rejected first. People can have a functioning graft and they can die. So loss of graft can be because of death because of functioning graft also. Like person has died but with a functioning graft because of cardiovascular disease. Other reasons for death are infection and post-transplant malignancy. So here I want to reiterate the fact that kidney transplantation is the most cost-effective modality of renal replacement. Transplanted patients have a way better quality of life and longer life. And early transplantation, which is called as, even there is an option of preemptive kidney transplantation, like even before you start renal hemodialysis, you can offer transplantation to that patient, and the results are even better in preemptive kidney transplantation. And living donor kidney outcomes are superior to deceased donor kidney outcomes. And early transplantation is more likely to occur in patients that are referred early to the nephrologist. And that is why I again urge that patients should be referred at least when the GFR has started going below 30 or even earlier is better. This is the same thing which I just mentioned, that the most common cause of transplant loss is death with a functional transplant due to either heart disease, infections or malignancies. And immunosuppressants can act as a double-edged sword. They are going to protect the kidney from rejecting, but at the same time they are putting you at an extra risk of developing infections. And you can see just here that a death with transplant functioning graft, one of the reasons for that is infection. Thank you. Another important thing I want to mention here is the Vishwaraj Hospital. I am attached with Vishwaraj Hospital since last 7 years. Renal transplantation program is just picking up. Last 3-4 years we have started doing transplantation. Total we have done 10 kidney transplantations, and I am blessed with a good team, of urologists, good team of vascular surgeon. Just now you listened to Dr. Vittal Shendge, so he is our transplant anesthetist also. And the good part is that the infrastructure is very good. We have a separate transplant room, a 2-bedded transplant room, where for the first 6 to 7 days we have one doctor and one nursing staff dedicatedly for the recipient. And we have a very low infection rate also, and in our short experience we have already done an ABO incompatible kidney transplantation. In fact, this patient was very challenging. He was already hepatitis B positive, he had ischemic heart disease, his ejection fraction was just 20%, and he was not accepted by other hospitals, but still we took a chance, and he is almost 2 years down the line. His kidney function is very good, his creatinine is 1.1, and he is very happy. And in fact, of these 10 transplantations, we have 2 patients which were brought by our own patients who got transplanted with Vishwaraj Hospital. And even the package is reasonable, 8.5 lakhs, and fortunately we have attachments with Chief Minister Relief Fund and other funds where we are easily collecting up to 3 lakhs. So out of that 8.5 lakhs, almost all patients received 2 to 3 lakhs of fund relief, and that is why the effective package which they had to pay from their pocket was just 5.5 to 6 lakhs. Thank you.
Thank you. If you have any questions. Okay, thank you very much, sir. May I request Dr. Shende sir to felicitate Dr. Rokde sir. Thank you. May I request Dr. Amol Khanore to felicitate our chairpersons, Dr. Madik sir and Dr. Zadbuke sir. The chairpersons for the next session are Dr. Kavishwar sir and Dr. Kavishwar ma'am. Please come on dais and for the chair to chair the session. Dr. The next session by Dr. Prasad Joshi sir. His MS Ortho, MBBS MS Ortho. He's done MBBS from Sassoon Hospital, MS from Sassoon Hospital, and DNB Orthopedic Surgery, the DNB Orthopedics from Government Medical College Indore. His achievements are he has a 40-bedded hospital fully equipped in Fulton. He's done total joint replacements. He has a total joint replacement center with experience of 1500 hips and 2000 knees surgeries in last 15 years in Fulton. About 2000 complicated spine surgeries done individually, including cervical, thoracic and lumbar spine. All trauma, lower limb and upper limb, including acetabulum surgeries, full orthoscopy, setup with shaver system, presented papers, total hip replacement, peripheral setup, solutions, interlocking femur nailing, unstable interlocking neck, femur, and various national conferences. He has done about 1500 total knee replacement in his own setup. He has taken special training of computerized navigation, joint replacement surgery in Chennai. He's currently chairman of Joshi Hospitals, Fulton, director of Joshi Hospitals, director of Avino MRI and Diagnostic Private Limited. He's director of Shashwat Lifeline Hospital. His specialties are general fracture trauma surgeries, joint replacement surgery, spine surgery, laser surgery, orthoscopy surgery, deformity surgery, and plastic surgery. So may I please welcome Dr. Prasad Joshi sir from Fulton to deliver his lecture.
At the outset, I thank Indapur IMA Association for calling me to deliver this different topic. I think last time I have already initiated this topic, but this time it was compulsorily said that you should speak on something like work-life balance again, and so that I changed the topic of art of being holistic. After seeing all these academic sessions from the morning, I think this will be a different topic altogether. The topic name is Work-Life Balance, Art of Being Holistic. So as a doctor, we have a life. We have 24 hours in a day. Health is wealth. So if we are healthy, we can achieve anything. We can do whatever job we are doing, and in a happy and a healthy way, and that's the success. So I will just take you an overview that how should we go about to have a work-life balance. So everybody aims after passing that post-graduation, we should settle somewhere, settling the practice in the rural area or urban area. I was very fond of settling the practice in urban area like Pune, but my godfather, Dr. Parag Bide, sent me to Fulton and said ki you should practice in Fulton and not in Pune, because Fulton people need you. And that was in 1998, which is about 27 years back, and I started my practice in Fulton in 2000. So now 25 years down the line, I am really happy and not repenting at all that I left Pune and came to Fulton, because whatever I achieved is really very good. Then there are problems of each and every practice. Whether you are in a rural setup or in an urban setup, they have different problems. They have different pitfalls as well as they have different advantages. Overcoming those is a real challenge, and that is life. Achieving the final goals is a real peaceful pleasure. So our Mahatma Gandhi, the godfather of nation, said that the future of India lies in its villages. So most of the people now should come to villages, because there is a very big saturation in the urban areas, and village people need your expertise. As said by Swami Vivekananda, take up one idea, make that one idea your life, think of it, dream of it, live on that idea. Let the brain, muscles, nerves, every part of your body be full of that idea, and just leave every other idea alone. This is the way to success. Again, one saying, things work out best for those who make the best of how things work out. So you should learn the art of how you should practice. Aims and objectives of practice: to set a good standard practice. People medical field is a noble profession, and still people really worship you like God. You are not God, we know that we are not God, but still they worship you like God. So it's a good standard practice you should develop. Abide by medical ethics, be sincere, hardworking and passionate. In the new generation, I definitely will like to say that this hardworking, sincerity and passion is definitely lacking in the new generation. Those who have passed out or those who are learning, because they are not that sincere. I am seeing those people. Work is in such a way that money will follow you and you will not follow the money. Have moral and social binding, respect your colleagues, because you may require their help and assistance anytime in your work. So what are the problems in a rural setup? When I started my practice in the rural setup, there were limited resources, limited expertise, less appreciation by the people, illiterate people. They didn't know what is your credentials, what is your expertise, low socio-economic conditions, paying capacity may be less, but nowadays it is changing. Less facilities were available. Doctors are easily approachable. In a big city, in a big corporate hospital, the doctors, the one doctors who operate on the patient is not seen by that patient as well as by the relatives till he is discharged. And that is the saga of the story. But we doctors in a rural area are easily available. The doctors approach us in and out in a day, and that is the problem. Less recreation. We don't have good recreating facilities if we want to go. like good gyms, like good swimming pools, like good playing grounds. But there are definitely some advantages in a rural setup. You require less settling time. You become a boss early in your locality. You give results, people will rush from any part of the world. Because I am getting patients from America, I am getting patients from Dubai in Fulton, I am getting patients from Singapore, I am getting patients from Gulf countries. So give results, people will rush to you. Get a mass rather than class, but they have great faith in you. And this is the real important point which you should mark upon, that the people and the patients in a rural setup, they really have great faith in your setup or your practice, and you should abide by this faith. So abide by medical ethics. So 7 C's of success. Anybody who start his practice or start his career, you should have a courage to start new thing. You should have that confidence that you can do this. You should have the consistency and perseverance. You should concentrate on your work, focus. You should have a good character, build up your character, because you should be seen as a important, responsible person by the society. You should have commitment. Once you are committed, you should abide by the commitment, and you should be creative. Always start doing new things, because monotonous life becomes a boring life. So something new has to be there after some years. So these 7 C's of success everybody should follow to be successful. So now coming to my topic, that work-life balance. What is work-life balance? It is the equilibrium state where one efficiently balances work or career demands and those to their personal life. It can be also called as work-life fit, work-life blend, work-life harmony, and work-life synergy. So everybody has 24 hours in their total day. So time management is very important. Those who are really busy can get some time for all these things, but those who create that they are really very busy but they are not busy, they don't have time for anything. So time management is the ability to use time productively and efficiently these 24 hours. It is an art of doing everything that you need to without feeling stressed about it. So 7 skills you should imbibe in yourself to do this time management. One is prioritization. Whatever is important at that moment, that should be done immediately, and rest of the things should not be done at that moment. So prioritize your senses. आता तुम्हाला जी महत्त्वाची गोष्ट आहे तीच आत्ता करा, जी नाही आहे त्याच्याकडे विचारही करू नका. So that will save your time. Delegation and empowering. You are a single person, सगळं तुम्ही नाही करू शकत. So delegate some persons who can do your job for you and who are responsible for that job. Empower them. Ask them to learn the skills, so that build up a team, so that you will be, as a team you can come up. Goal setting and planning is important, and stress management. Don't take any stress of your work, because if you love your work, there will be no stress. But if you don't love your work, the stress starts building up. Efficient multitasking. Organize yourself. Scheduling and rescheduling, self-control and self-awareness. Always improve yourself and have a good awareness about yourself, that where were you and where you want to go. Now, what helped me a lot in Fulton, that first I took ISO certification way back in 2005. Then NABH entry level, ours was the first hospital to have an NABH accreditation in 2015, which was the first rural hospital in all over Maharashtra. At that time, all over India, only 215 hospitals were NABH accredited, and that helped me a lot. Mission and vision. Your all hospital staff should have a common mission and vision, because they should know that what you are doing, what they want to do, and what everybody as a team has to go and where they have to go. Keeping the records up to date, because we know that medical legal cases are increasing more and more against doctors. So our records should be kept up to date, and for that you can use computers. I will come to that. Involving social media is another thing. So some people do time pass on social media, but you can do your marketing, very healthy marketing on the social media, and that is really important in this part of the world and this juncture. Regular training of the staff is also important. You should have some like this conferences, like at a single hospital by a single surgeon. This is the modular OT. which I am operating upon. This was the navigation system which I installed in 2012. And these are the body exhaust suits which I use while operating on the patient, so that it protects yourself also, and it protects the patient also from getting the infections. So my dear friends, develop your brand. Don't just do your practice. You should develop your brand. Everybody should know you. Not in your village, not in your town, but in all over Maharashtra and all over India, and also in the world. So develop your brand. Like that, how you can developing of a live website and updating it frequently. Now most of them are, our patients are Google users. Most of them see your profile on the Google. They search your profile in the Google before they come to you. And this is very common thing in urban areas like Pune, big cities, Solapur, like Sangli, Kolhapur. But in still in small towns like Fulton, Indapur, now the people are really aware, and they come search you on Google, and then only they meet you. So having live websites is really important. Registering with Just Dial, which I did in 2008. And I got very good feedback, and I got very good patient phones, and that helped me a lot to gain my patients and increase my patient work. Then using Google services, Google has a special thing like 3D photography of your hospital. Call the Google persons, let them take a whole photograph of your hospital, and that is with a minimal charges of 20 or 25,000 one-time charges. And they take all the photography of your hospital, and they place that all 3D photography in their Google site, and the patient can just walk in through your hospital at their home searching on the computer. So the patient can see which room they want to stay in, what is the hospital setup, what is the OT setup, where is the OPD, everything the patient can see. So that again helps you. Using Facebook, business, WhatsApp, and social awareness marketing tools, and helps you for medical tourism. Being active on LinkedIn, Instagram, and Twitter handle also helps you to develop your brand. And radio programs, publication media, TV programs, that are the another allied things. So advantages of technology: upgrades yourself and the system, improves your results and practice, pays you in long term, proud and privileged in your locality to have these technologies, propagate yourself in a healthy way on social media, and builds your team confidence to tackle difficult cases. So upgradation of technology and yourself is important. My journey in rural practice started a small setup of 5 beds in my own home in 2000, shifted to 10-bed rental setup after 2 years. Then I shifted, at present I am a 40-bedded hospital of 14,000 square feet, which is a 5-story building. Took navigation tool in 2012, then have a MRI and CT in my setup, and employed about 40 odd staff working sincerely for the betterment of patients. This is my hospital building, this is the OT setup, this is the MRI machine, and this is the conference hall which I was talking about. And I am happy to announce that I am using the first robo at a taluka level in India, which was taken 1.5 years back, and which was also the 7th robo all over India, and first at a taluka level. So this robo we have named by the name Vithu, because Fulton comes in the center of Pune Pandharpur road, and we call it Vithu. परवा तर गंमत अशी झाली, एक पेशंटचा सर्जरी केल्यानंतर तो म्हणला मला विठूला नमस्कार करायचा आहे, आणि त्यांनी माझं ऑपरेशन केलं आहे. सो वी टूक दॅट पेशंट इन द OT अगेन ॲट द टाईम ऑफ डिस्चार्ज. ही वर्शिप त्यांनी नमस्कार केला वाकून त्या पेशंटने, मग तो घरी गेला, त्याशिवाय तो घरीच गेला नाही. सो दिस binding of the patients can be there with, so you have to do it. And this is just a value-added addition and marketing tools. Patient should feel like a family in your hospital, and it should not be as a customer. So we started this Vithu Robo in 25/5/2023, and built up your team. This is the Valis Robo, and this is our team setup. The results are really remarkable. You can see the pre-op, post-op. The fitting of the processes is really good. We celebrated this first robotic surgery by the patient by cutting a cake at the time of going home. So my dear friend, these are the small value-added additions. आता आम्ही बऱ्याच लोकांचे केक कापले घरी जाताना, आणि पेशंट्स आमचा असा फीडबॅक आला काही म्हातारे पेशंट्स की आमच्या वाढदिवसाला सुद्धा आत्तापर्यंत आमच्या घरात कोणी केक कापला नाही, पण तुम्ही घरी जाताना हॉस्पिटलमध्ये केक कापलात. सो दिस बॉन्डिंग is really very important. हे बघा सगळेच प्रॅक्टिस करतात, पण शेवटी वी आर नोबल प्रोफेशन्स, वी आर ॲक्च्युली हेल्थ प्रोव्हायडर्स, आणि आपण जे देतोय ते चांगल्या पद्धतीने देणं आणि पेशंटला त्याचा फायदा होणं आणि त्याचं एक बॉन्डिंग होणं, दिस इज व्हेरी इम्पॉर्टंट. सो प्रॅक्टिस लाईक अ नोबल प्रोफेशन. Now what I have done in my setups, 20,000 trauma cases till date in last 25 years, 4,500 joint replacements, 2,000 knee spine surgeries, 5,000 surgeries around the hip, and these are the things. So lessons I learned actually is what matters is the attitude and not the place where you are. Tumhi kuthei asa, but your practice should be healthy, should be upgrading yourself, should be used with the technology. Be loyal, hardworking, passionate, sincere with your work, it pays surely. Upgrade yourself, set target goals and achieve them. Be kind and social, know your limits, no heroic things, untoward incidences, negative impact. Chhotya gavamade you should be very calculated, don't go for heroic things. Respect your colleagues, you may need their help later on. We started walkathon and celebrating World Arthritis Day way back in 2015. And we gathered all our patients of joint replacements together. We walked them for 2.5 kilometers in Fulton, and we booked a theater for them, and we showed them the cinema Murder Mystery, which was casted by Dilip Prabhavkar. आणि त्याचा इतका सुंदर फीडबॅक आला. 450 पेशंट्स त्या थिएटरमध्ये, अख्खं थिएटर मी बुक केलं होतं, आणि दे वर रिअली ओव्हरवेल्म्ड विथ ग्रॅटिट्यूड की आत्तापर्यंत आम्हाला असं कुठल्याच डॉक्टरांनी सिनेमा नाही दाखवला थिएटरमध्ये नेऊन. So these are some value additions which you can add. And now that walkathon, these are our patients, we gather them every on 12th October of each year. This is the oldest patient of 95 years of age, which I have done joint replacement. Dr. Hardikar, Ramaraja Naik Nimbalkar, Mai. These are the dignitaries which we call on each every 12th October. We have a theme, and Amte also, Prakash Baba Amte, Mandakinite Amte, and this is the gathering of our patients only which come on 12th October. So this is the dedication which you should have for our patients. It's a teamwork, it's a homely atmosphere, and this Ajji which I operated, the age of this Ajji was 95, fractured neck femur, fixed with implant. आणि मी राऊंडलाच जेव्हा गेलो तेव्हा आजी गॉगल बिगल घालून बसली होती, डिस्चार्ज करायचा होता, तर तिच्या हातात बुके होतात. मला कळेना काय करतायत. तर आजी म्हणली, माझं छान ऑपरेशन्स केलंस रे बाबा, तुझा सत्कार करायचा आहे. आय वॉज विथ टीयर्स की अशी आजी आता इतक्या म्हाताऱ्या बाई आणि आपले ज्येष्ठ बाई आपला सत्कार करतायत. सो दिस इज लाईक समथिंग विच डिड नॉट एक्सपेक्ट, पण दिस इज वॉट यू गिव्ह टू द पेशंट, वॉट यू गिव्ह यू विल गेट बॅक. आणि मग असं यू शुड डेव्हलप युअर प्रॅक्टिस. We had arranged a shariyat of these all the patients of joint replacement, knee replacement kelele patients आहेत. See how they are enjoying that walking together. So my dear friends, key to success is go step by step, never try to jump. Planning, determination, execution of goals, sky is the limit. I have received 5 national awards and 2 state awards up till now. This is Indian Achiever Awards in Delhi. This is Bharat Gaurav Award in Bangalore. This is Excellence in Orthopedics Award. Recently, last year I received Times Now Doctors Conclave, the Inspiring Orthopedic Surgeon of India in first 20 doctors of India. And this is the most trusted doctor batch which I received recently in October last year. And also Bharat Ratna Dr. Abdul Kalam Gold Medal Award. So now coming to other part of the life, 10 minutes fakta. Growth is only evidence of life. You should have a length, breadth and depth. So length is longevity of healthy living. तुम्ही जर healthy living असाल, healthy असाल तरच you can grow. Your breadth is your academic and life achievements, and your depth is your spirituality and social growth. त्यामुळे you should have these 3 अंग जे आपण म्हणतो की length, breadth and depth. Longevity, academic achievements, and spirituality and social binding. Health is wealth. You should be healthy. You should exercise daily. I do yoga. I am fond of yoga. आणि जेव्हा आपल्या कोरोनामध्ये आपल्याला वेळच वेळ होता, तेव्हा आय डेव्हलप माय योगा प्रॅक्टिस, कारण तेव्हा काहीच काम नव्हतं. दुपारी 2 नंतर निवांत आपण शांतता होती. हॅव ग्रॅटिट्यूड, ऑलवेज रिस्पेक्ट युअर सिनियर्स. He is Dr. Parag Bhide in the center, and Dr. Anand Kelkar. These were two my guides and the godfathers. They are from Pune. Dr. Sancheti. Nurture your hobbies, because these hobbies are the only thing which will remain with you till the end. तुम्हाला जे करायचे ते तुम्ही करू शकता. I am fond of trekking. I am fond of, this is the Mount Everest base campला मी गेलो होतो, त्याच्या मागे Mount Everest दिसतोय. I am fond of cycling, I am fond of running, I am fond of singing also. गोंदवलेकर महाराजांच्या इथं मी दरवर्षी एक सेवा देत असतो. This I am fond of photography also. हा फोटो मी स्वतः काढला आहे. दिस इज गोल्डन माउंटन्स काय असतात ते मी स्वतः अनुभवलेत हिमालयामध्ये. अँड दिस इज द फोटोग्राफ. अर्ली मॉर्निंग सन जेव्हा सनराईज होतो तेव्हा माउंटन्सवर जे किरणं पडतात त्याच्यामुळे तो माउंटन असा ग्लो होऊन तो गोल्डन दिसतो. अँड दिस इज गोल्डन माउंटन विच आय हॅव एक्सपिरियन्स माय सेल्फ. दिस फोटोग्राफी आय हॅव डन इन माय फार्म. संध्याकाळचा सूर्यास्त होत होता आणि ते नारळाचं झाड होतं, पण तो सूर्य बरोबर तिथे मला दिसला आणि त्यात तो फोटो काढला. इतका सुंदर फोटो आला आहे. दिस इज अगेन सम गुड फोटोग्राफी. दिस इज अगेन माय फोटोग्राफी. अँड दिस इज अगेन हे फलटणमध्ये गोविंद मिल्क, जिथे लोकांना माहिती आहे त्या गोविंद मिल्कच्या तिथून जाणारा जो रस्ता आहे, सकाळ सकाळी जर गेलो आपण तर तिथून जी सूर्यकिरणं पडतात त्याचा एक सुंदर फोटो मला घेता आला. So enjoy the moment. Built as a team, not as an individual person. And not the least, last but not the least, family time always is a relaxation. Be with your family. Always respect your seniors. हे माझे काका काकू आहेत IEA मध्ये. Always play with your children. बिकॉज मुलं जेव्हा लहान असतात तेव्हाच आपल्याबरोबर असतात. एकदा ती 10वी 12वीच्या नंतर मोठी झाली की ती आपल्याला विचारतसुद्धा नाहीत, कारण त्यांचं लाईफ बदलून जातं, त्यांच्या फ्रेंड्समध्ये आपण अडकतो. सो ऑलवेज प्ले विथ युअर चिल्ड्रन. Ambition is the path to success. Persistence is a vehicle you arrive in. Without continual growth and progress, such as words as improvement, achievement and success has no meaning. Success is not an accident. It is a hard work, dedication, perseverance, loving what you do. So these are 7 deadly sins, as again said by Mahatma Gandhi. I will not enumerate that. So my dear friends, life is a song, sing it. Life is a game, play it. Life is a challenge, meet it. Life is a dream, realize it. Life is a sacrifice, offer it. Life is a love, enjoy it. It makes a big difference in your life when you are positive. Be healthy, be positive and live life king size. I will just skip. So healthy life म्हणजे काय त्याच्याबद्दल एक 2-3 slides आहेत, and I will end my talk. You should exercise at least for 1 hour per day. आणि दिस इज मॅन्डेटरी फॉर बीइंग हेल्दी. आता कोरोनानंतर इतके लोकांचे प्रॉब्लेम्स आलेत. दोज डिसीजेस विच वेर सीन इन 60s नाव आर सीन इन 40s. दोज डिसीजेस विच वर सीन इन 40s नाव आर सीन इन 20s. 19-20 वर्षाच्या मुलामुलींना सर्वायकल स्पॉन्डिलोसिस, लंबर स्पॉन्डिलोसिस, हिप आर्थरायटिस, नी आर्थरायटिसनी जर्जर झालेले पेशंट्स आम्ही रोज बघतोय. आणि त्याचं कारण म्हणजे हेल्दी लिव्हिंग नाही, व्यायाम नाही. सो 1 hour ऑफ एक्सरसाइज, 2 types of fruits each day, 3 minutes of reading, 4 colors on the plate, 5 minutes of meditation, 6 minutes of laughter, 7 glass of water and 8 hours of sleep and 9,000 steps in a day. हे जर 9 मंत्र आपण जर पाळलेत तर आय थिंक युअर लाईफ विल बी रिअल हेल्दी अँड सक्सेसफुल. बेस्ट टाईम टू ईट. मागच्याच वर्षी डॉक्टर दीक्षितांचं इथं लेक्चर झालं होतं, मला आठवत आहे. तर दीक्षित सर म्हणतात 2दा खा, दिवेकर मॅडम म्हणतात 4दा खा, 5दा खा. नक्की किती वेळा खायचं कोणालाच कळत नाही आणि मग जम्बलिंग होऊन जातं. तर त्यावेळी सुवर्णमध्ये आपण काढूया 3 वेळा खा. सकाळचा ब्रेकफास्ट, दुपारचं लंच आणि रात्रीचा डिनर. आणि प्रत्येक खाण्यामध्ये 6 ते 7 तासाचं 6 तास नाही 4 ते 5 तासाचं अंतर असू दे. आणि मध्ये आधी काही खाऊ नका, म्हणजे नक्की वजन वाढणार नाही. Keep watering yourself with good thoughts, good people, patience, empathy, healing, hope, open mind, kind words, self-belief, acceptance and love. हे सगळे जर आपण आपल्याला वॉटरिंग केलं तर डेफिनेटली वी विल हॅव अ हेल्दी लाईफ. 10 फिजिकल फिटनेस टेस्ट मी आता इथे देत नाही, नेक्स्ट टाईम आपण बघू. कंट्रोल युअर 5 M's. युअर माउथ, व्हॉट यू से यू शुड कंट्रोल. What your mind, what you think you should control. your mood, what you ekdam reactions tumcha you should control, your manner of talking with others, and your money. These 5 M's if you control, you will have a successful and healthy life. So last 2 slides. Don't just learn experience, don't just read absorb, don't just change transform, don't just relate advocate, don't just promise prove, don't just criticize encourage, don't just think ponder, don't just take give, don't just see feel, don't just dream do, don't just hear listen, don't just talk act, don't just tell show, don't just exist live. And take home message is medicine is still a noble profession. Be ethical and loyal to your patients, love your job and also love your own family. Imbibing new technologies and upgrading yourself is the key to grow. Nurture your staff, be healthy and be happy yourself. स्वतः चांगले healthy असाल तरच दुसऱ्याला healthy राहा म्हणून सांगू शकता. Nurture your hobbies. No time is an excuse, it's all about your priorities. Positive attitude is mandatory. Increase your spiritual emblem and aura. That for by meditation. Be social, work for them, educate them, get inspired and also inspire others. Reduce stress by practicing yoga and meditation. Life is meant to be lived happily. Holistic approach can make life much better, and time management is the essence. Thank you my dear friends. हा फोटो मी स्वतः काढलाय. मी रनिंग पण करतो, सकाळी जाताना सकाळच्या वातावरणातला आहे. त्यानंतर हा फोटो पण मी स्वतः काढलाय. हे गोव्याला बीचवर फोटो काढलाय. तो मस्त बोट जात होती आणि सूर्यास्त होत होता, पण तो मोमेंट पिक्चर करणं महत्त्वाचं आहे. आणि हा फोटो पण मी स्वतः काढलेला आहे. शेतामध्ये संध्याकाळी तो सूर्याची किरण इतकी ग्लो झाली, पण ते यू शुड लुक फॉर दिस मोमेंट्स. प्रत्येक मोमेंटमध्ये जगा, ना की पास्ट आणि फ्युचरमध्ये. यू शुड लिव्ह इन द प्रेझेन्स. थँक्यू अगेन.
थँक्यू.
Thank you, Dr. Joshi, for nice and informative lecture. I mean, it's difficult to follow all the things which you have told, but even if we follow a part of it, I think the quality and the quantity. It was good lecture to listen, I mean, but in practice it is very difficult to follow all the points which you have told. But if some of the points or some of the things which you have affinity for, if you follow those points, it is going to enrich our life and it is going to increase the quality and quantity of life. So we should all pick some points from this lecture and try to follow it. कळतंय पण वळत नाही, पण आपण वळवायचा प्रयत्न करायचा. So thank you, Dr. Joshi, for the lecture.
Thank you. Thank you very much. May I request Dr. Balasaheb Rao to felicitate Dr. Prasad Joshi, sir. Balasaheb Rao is a very good friend of Prasad Joshi, sir. Yeah, Dr. Balasaheb Rao will.
प्रसाद जोशी सर, जे की फलटणसारख्या ग्रामीण भागामध्ये आज प्रॅक्टिस करतात, त्यांच्याबद्दल फक्त एकच सांगणार आहे की आठवड्यामधील 3 दिवस OPD आणि 3 दिवस सर्जरी. त्यांचा साधारणतः 4 ते 5 महिने त्यांच्या OPDचा देखील नंबर लागत नाही सर. म्हणजे साधारणतः जे रुग्ण मला भेटतात ते सांगतात जोशी सरांच्या आम्हाला 4 महिन्यानंतर OPDचा नंबर मिळालेला आहे. म्हणजे अशा प्रकारे त्यांची प्रॅक्टिस आहे. एक परमेश्वरूपी माणूस म्हणून एक आमच्या फलटण तालुका आणि सातारा जिल्ह्यामध्ये त्यांचं खूप नाव आहे. सोशल, सामाजिक आणि खूप चांगल्या प्रकारे प्रॅक्टिस करून गोरगरीब लोकांना देखील चांगल्या प्रकारे मार्गदर्शन करतात. आणि त्यांचे जे काय ज्या दुसऱ्या देखील ॲक्टिव्हिटी खूप मॅरेथॉन आहे आणि सामाजिक कार्य देखील खूप चांगलं आहे. तरी मला अभिमान आहे, मी फलटणला देखील प्रॅक्टिस करत असतो. त्यामुळं आज माझ्यातर्फे त्यांचा सत्कार झाला, मी माझा अभिमान समजतो.
थँक्यू. थँक्यू व्हेरी मच. Yeah. Now the next session, the next lecture will be on neurovascular disorders by Dr. Ashwin Shirish Valsankar. He's a well-known neurologist from Solapur. He's done MBBS from IMA Talegaon Davade. He's done MD from Bangalore, JNMC Belgaum, sorry. He's done DM Neurology from Bangalore. He's a practitioner in Solapur, SP Institute of Neurosciences, his own institute. He's done fellowship in interventional neurology under Dr. A.P. Karapurkar. He's a practicing consultant and director of Ashwin Neurosciences in Solapur. He has a membership of many API, IN and Society of Neurovascular International India. He's done many paper presentations, and he's well-known neurologist working in rural area setup in Solapur in SP Institute of Neurosciences. So please welcome Dr. Ashwin Shirish Varsankar. His topic is neurovascular disorders.
धन्यवाद की मला आज या कॉन्फरन्ससाठी इथं बोलवलं आहे. तर टेक्निकल काही ग्लिचेस आहेत, त्यामुळं हे प्रेझेंटेशन होईल का नाही मला माहिती नाही. पण मी आज बोलणार होतो की मेंदूला जे स्ट्रोक आणि रक्तवाहिन्यांचे जे आजार होतात त्याची ट्रीटमेंट आपण कशी करतो. सो लकीली हे चालू झालं. सो सध्या ओव्हरऑल चालू झालं का पुढे मला स्क्रीन नाही 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 मी करतो राहतो. सो ब्रेनच्या सध्याच्या आजारांमध्ये सगळ्यात जास्त इन्फ्लुअन्स आता आहे तो स्ट्रोकचा, म्हणजे रक्तवाहिन्यांचे आजार. सो स्ट्रोक म्हणजे आपण कॉमनली काय बघतो की एखादा पेशंट हातात पायात वीकनेस किंवा हातात पायात मुंग्या अचानक येतात, बोलणं तोत्र होतं म्हणून आपल्याकडे येतो आणि बेसिक इव्हॅल्युएशन केल्यावर आपण रक्त पातळवायची औषधं चालू करतो, अँटीप्लेटलेट्स देतो त्याला. पण त्याच्या पुढं त्याचं काय होतं. सो ओव्हरऑल म्हणजे 100 जर स्ट्रोकची संख्या असेल तर त्याच्यामधले साधारण 15 ते 20% लोकांना रक्तवाहिनीत ब्लॉकेज असतं, त्याच्यामुळं होतो स्ट्रोक. सो हे समजणे अत्यंत महत्त्वाचं आहे, कारण याचं जर इव्हॅल्युएशन आपण वेळेवर केलं नाही तर हा पेशंट आपल्याकडनं मिस होतो आणि स्ट्रोक होण्याची त्याची शक्यता खूप वाढते. सो मी तुम्हाला पहिल्यांदा एक इलस्ट्रेटिव्ह फक्त एक केस दाखवतो की हे कसं होतं आणि आपण त्याची ट्रीटमेंट कशी करतो. सो हा त्या पेशंटचा MRI आहे. त्याच्यामध्ये डाव्या मेंदूमध्ये तुम्हाला छोटे छोटे डॉट्स दिसत आहेत, कारण त्याला स्ट्रोक ऑन अँटीप्लेटलेट्स झाला होता. उजव्या बाजूची त्याची मेंदूची रक्तवाहिनी बंद आहे. ही आर्च आहे मानेपासून वरती. सो एक रक्तवाहिनी म्हणजे ICA उजव्या बाजूची बंद आहे, डाव्या बाजूची चालू आहे. आणि तुम्हाला दिसत असेल एकदम त्याला टाईट स्टिनोसिस आहे. सो आम्ही कॅथलॅबमध्ये ॲक्च्युली ही प्रोसिजर कशी करतो हे मला तुम्हाला दाखवायचं आहे. तर ही रक्तवाहिनी मेंदूच्या आत म्हणजे इंट्राक्रेनियल स्टिनोसिस आहे. सो अशा पेशंट्सना आपण साध्या लोकल ॲनेस्थेशियामध्ये हे करू शकत नाही, तर त्याला अंडर जनरल ॲनेस्थेशिया आपण ही प्रोसिजर करतो, ज्याच्यामध्ये पेशंटला मास्क लॅरिंजल मास्क फक्त आपण लावतो, ॲनेस्थेशिया देतो आणि पेशंट न हल्ल्यामुळे ही प्रोसिजर अतिशय सोपी होते. सो रिसेंटली मेंदूच्या रक्तवाहिन्यांचं जे काम आहे ते फिमोरल म्हणजे मांडीच्या रक्तवाहिन्यातनंच व्हायचं. तर आता मी हे जास्तीत जास्त प्रोसिजर हाताच्या रक्तवाहिन्यातून म्हणजे रेडियलमधनं करायला चालू केलं आहे. कारण रेडियलमधनं केल्यानंतर ती शीत काढणे, हेमॅटोमा होणे, ह्या सगळ्या गोष्टी त्याच्यामुळं ते होण्याचे चान्सेस कमी होतात. सो हे मी कॅथेटर वरती घेऊन गेलो आहे. हे पुढं करता येईल का? इथनं कंट्रोल याचा नाही आहे, याचा कंट्रोल मला व्हिडिओ इथं दिसत नाही आहे. शो नॅव्हिगेटर नाही. सो बेसिकली इथं स्टेनोसिस आहे. सो आपण स्टेंट कार्डियक जसा करतो ती प्रोसिजर सेमच आहे, पण हे केल्यानंतर 5 मिनिटात पेशंटला उठवून त्याला आपण चालवू फिरवू शकतो, हे त्याचं ॲडव्हान्टेज आहे. सो मी आता या व्हिडिओत पूर्ण जात नाही, पण नाही एक मिनिट मी हे करतो, मला हे ओपन करायचं आहे. तर अजून एक गोष्ट मला सांगायची की आम्ही प्रोसिजर कुठल्या करतो की मेंदूत रक्तस्राव असेल त्याचं काय कारण आहे शोधतो, रक्तवाहिनीचा गुच्छ असेल तर तो एम्बोलायझेशनने बंद करतो, रक्तवाहिनीत फुगा असेल तर कॉइल्स किंवा स्टेंटचा वापर करतो, किंवा रक्तवाहिनीत ब्लॉकेज असेल तर आपण स्टेंट करतो त्याला. ड्युरल एव्हिफिस्युला म्हणजे रक्तवाहिनीत कनेक्शन्स असतील तर परत ग्लू किंवा ऑनिक्सने ते बंद करतो. या बेसिकली 4 प्रोसिजर आहेत. सो ह्या जेव्हा आम्ही प्रोसिजर करतो तेव्हा हे अत्यंत महत्त्वाचं आहे की तुमचं एन्व्हिरॉन्मेंट आजूबाजूचं स्टँडर्ड आहे, तुमचे टेक्निशियन्स जे रोज तुमच्याबरोबर काम करतात तेच तुमच्याबरोबर पाहिजेत, आणि अशा प्रकारे आपण आउटकम चांगलं करू शकतो. तर गेल्या 4 वर्षात मी साधारण म्हणजे कॅरोटिड एक्स्ट्राक्रेनियल कॅरोटिड 500 प्रोसिजर माझ्या पूर्ण झाल्या. इंट्राक्रेनियल म्हणजे मिडल सेरेब्रल आर्टरी, बेसिलर आर्टरी, व्हर्टिब्रल आर्टरी ऑलमोस्ट माझ्या 150 प्रोसिजर कंप्लीट झाल्या. पण हे करत असताना मला हे जाणवलं की हळूहळू जसा एक्सपिरियन्स वाढतो आहे आणि जसे माझे लोक ज्यांना मी माहिती आणि मला काय पाहिजे हे कळतं, हे जसं बिल्ड होतं आहे तसं प्रोसिजर्स हळूहळू सोप्या व्हायला लागल्यात माझ्यासाठी. आता हे करत असताना सगळ्या गोष्टी सरळ पण होत नाहीत, पण काही वेळेला तुम्हाला थोडासा पेशन्स आणि शांतपणे काम करावं लागतं. तर आता 1-2 दिवसापूर्वीच मी ही केस केली. हा 70 वर्षाचा म्हणजे शेतकरी आहे, ऑल वेल, ही वॉज डुईंग हिज फार्मिंग एव्हरी डे, ही वॉज सो ॲक्टिव्ह, ही डेव्हलप्ड अ स्ट्रोक. तर इथं तुम्हाला दिसत असेल की हा ब्रेनस्टेम आहे, पॉन्स आहे. तर इथं स्ट्रोक आहे, त्याला सेरेबेलममध्ये छोटे छोटे डॉट्स आहेत, म्हणजे सेरेबेलर आणि पॉन्टाईन इन्फॅक्शन त्याला झालं. तर ह्या रक्तवाहिनीत त्याला इथं ब्लॉकेज आहे. हे दिस इज मोर दॅन 90%, म्हणजे बेसिलर स्टिनोसिस आहे. तर आता बेसिलर स्टिनोसिसची हिस्ट्री काय आहे की अशा पेशंट्सना ऑन अँटीप्लेटलेट साधारण 50% लोकांना पुन्हा स्ट्रोक होतो. सो 1 आठवडा त्यांनी ट्रीटमेंट घेतली, तो घरी गेला आणि देन ही डेव्हलप्ड अनदर स्ट्रोक, ही केम बॅक. आणि तेव्हा मी त्यांना सांगितलं होतं की हे लॉंग लिजन आहे, दिस इज डिफिकल्ट, पण जर परत हे व्हायला लागलं तर वी डोंट हॅव एनी चॉईस, वी हॅव टू टेक दॅट रिस्क ऑफ 10% मॉर्टॅलिटी ड्युरिंग द प्रोसिजर, बट देन विल हॅव टू डू इट. ते परत एकदा झाल्यावर तो आला. सो वी डीड DSA. सो हा DSA. सो DSA आणि प्रोसिजर मी त्याच वेळेला केली की बिकॉज आय ऑलरेडी न्यू दॅट ही हॅड बेसिलर स्टिनोसिस. सो दिस इज व्हेरी टाईट स्टिनोसिस. खाली आर्च आणि व्हर्टिब्रल आर्टरी तिकडं खूप टॉर्च्युओसिटी होती. सो आय हॅड टू यूज स्पेशल डिस्टल ॲक्सेस कॅथेटर्स. तर हे म्हणजे माय डिफिकल्टी, माझं अँटिसिपेशन असं होतं की माझं कॅथेटर्स पहिल्यांदा वरती जाणार नाही, तिथपर्यंत मी पोचणारच नाही. पण दॅट पार्ट वॉज लाईक केक वॉक, काहीच प्रॉब्लेम नाही झाला. स्टेंट कुड ट्रॅक व्हेरी इझिली. या दुसऱ्या स्लाईडमध्ये दिसेल की हा स्टेंट इथं ओपन केला आहे मी बलूनने. Everything was perfect after inflating stent. Blood pressure was normal, pulse was normal. And I did a check shoot. So check shoot मध्ये you can see there is a big bleed, rupture झाली आहे from the lower part of the stent, basilar. So basilar is a very important artery, म्हणजे pons आणि brainstemला ती लागून आहे. आणि imagine तुम्हाला असं spurt of blood is going, what will you do? So what we did, पहिल्यांदी BP 60 केलं, systolic blood pressure. And then I inflated the balloon in that stent. Already माझा balloon होताच त्याच्यात. I inflated the balloon and I shut the artery for 10 minutes. आणि विटॅमिन के पॉज आणि हेपॅरिन रिव्हर्स केलं प्रोटामिनने. आणि प्युपिल्स मी क्लिनिकली बघितली, प्युपिल्स वेर नॉट डायलेटेड. सो असा क्षण होता की आता काय इट इज ऑल ओव्हर. पण आफ्टर वेटिंग फॉर 10 minutes द ब्लिडिंग स्टॉप्ड. सो मला सांगायचं की मेनी अ टाइम्स तुम्हाला 100त 90-95% वेळेला नथिंग हॅपन्स, पण दीज आर द केसेस वेअर यू हॅव टू बी व्हेरी व्हेरी काम अँड डू वॉट एव्हर यू कॅन. आय मीन एव्हरीथिंग इज नॉट इन युअर हँड्स, बट हिज लाईफ वॉज सेव्ड. सो हा स्कॅन मी इमिजिएटली केला, त्याच्यामध्ये ऑब्वियसली यू कॅन सी मॅसिव्ह सबरेक्नॉइड हेमरेज. आय स्टील हॅड माय डाऊट्स की काय होईल याला, पण काही वेळेला ते the destiny is different. So here is he. This is 72 hours after the procedure. No deficits at all. He is just as he was before. Nothing has changed in him. सो आपण आता इश्चिमिक स्ट्रोकबद्दल लिहूया. इश्चिमिक स्ट्रोक इज ऑफ मेजर कन्सर्न इन आवर सोसायटी, कारण फॉर एव्हरी 1 हार्ट अटॅक देर आर 4 strokes. So every day in India about 1,000 people are disabled by stroke. So it is a cause of major concern. So how do you address that? सो इश्चिमिक स्ट्रोकमध्ये जी ॲडव्हान्समेंट आज जगात झाली आहे त्याच्यामध्ये पामी जशी आपण हार्टमध्ये करतो तशीच ब्रेनमध्ये आता चालू केली आहे. सो एनी पर्सन हू कम्स विथ मेजर वेसल ऑक्लुजन अँड ही कम्स ॲट अ राईट टाईम इन हॉस्पिटल. आता राईट टाईम म्हणजे काय, आधी कन्सेप्ट होता टाईम की 4.5 तास, पण नाऊ इट इज टिश्यू. टिश्यू म्हणजे काय, यू शूड डेमॉन्स्ट्रेट दॅट ही हॅज अ व्हायबल टिश्यू. म्हणजे त्याला हेमिप्लेजिया आहे एका बाजूला, हातपाय गेला आहे, पूर्ण बोलणं बंद झालं आहे, पण ऑन हिज इमेजिंग MRIवर तुम्हाला हे कळतं की व्हॉट इज इरिव्हर्सिबल डॅमेज. जर ते इरिव्हर्सिबल डॅमेज नसेल तर यू कॅन स्टील सेव्ह हिज ब्रेन अँड मेक हिम नॉर्मल. सो द प्रोसिजर इज कॉल्ड थ्रोम्बेक्टमी. सो जो क्लॉट आहे तो आर्टरीमधनं आपण स्टेंट रिट्रीवर म्हणून एक स्पेशल डिव्हाइस असते, इट इज अ रिट्रीवेबल स्टेंट. सो तो क्लॉट ते इंगल्फ करतो अँड यू रिमूव्ह इट. सो इफ यू डू इट ॲट राईट टाईम द पेशंट कम्स बॅक टू नॉर्मल. सो दॅट इज द इम्पॉर्टन्स ऑफ थ्रोम्बेक्टमी. सो बऱ्याच वेळेला काय होतं छोट्या गावात किंवा जिथं फॅसिलिटी नाही आहे तेव्हा हे थ्रोम्बोलायसिसचं सध्या सगळ्यांना वेळ लागला आहे की आला 3.5 तासात करायचं थ्रोम्बोलायसिस. पण इज इट गोइंग टू बेनिफिट इज ऑल्सो इम्पॉर्टंट. कारण आपल्याकडं काय आहे की साहेब मी एवढे पैसे देतो आहे तर मी बरा होणार आहे का नाही, ह्या प्रश्नाचं उत्तर आपल्याला आधी द्यायला पाहिजे. सो ही इज अ 35-year-old, no risk factors, acute onset of left-sided weakness 2 hours prior to admission, conscious but restless, blood pressure 148/90, dense grade 0 झाला आल्यावर, आणि शुगर स्वेअर नॉर्मल, कोॲग्युलेशन नॉर्मल, इको नॉर्मल. सो दिस इज अ स्कॅन. सो जगात काय रेकमेंडेशन आहे याला की न बघता थ्रोम्बोलाइज करा. सो वुड यू रिअली डू इट? सो हा त्याचा MRI त्याच वेळी केलेला. सो यू कॅन सी द होल ऑफ द ब्रेन इज इन्फॅक्टेड. and thrombolysis is going to make him worse कारण याला decompression लागणार आहे, craniectomy लागणार आहे आणि thrombolysis आपण केलं की bleeding post surgery pre surgery होण्याची शक्यता जास्त आहे. सो पहिली गोष्ट मला ह्याच्यातून ही सांगायची आहे की डोंट रिलाय ऑन CT. आता इंदापूरमध्ये आणि बाकीच्या छोट्या ठिकाणी सगळीकडे सुद्धा एव्हरीवेअर देर इज अ MRI. So use that facility. That will give you accurate assessment whether he's a right candidate for thrombolysis. So second case is 82-year-old farmer. One day prior to admission had an episode of dizziness, vomiting, improved over next hour. So TIA like posterior circulation. And next day morning again had slurring of speech at 9:30. He went to some local hospital, then developed right-sided weakness. Blood pressure 160/90, right hemiplegia grade 0. आमच्याकडे जेव्हा आला तेव्हा इमर्जन्सी MRI आम्ही करून घेतला. MRI करता करताच तिथे टेबलवर तो अनरिस्पॉन्सिव्ह झाला. सो इमिजिएटली ट्यूब टाकली. प्युपिल्स वेर स्मॉल बट रिॲक्टिव्ह, डॉल्सा वेर अब्सेंट, डिसेरेब्रेट टू पेन. आणि ह्या MRIवर यू कॅन सी देर इज अ सेरेबेलर हायपर इंटेन्सिटी. म्हणजे एक छोटासा सेरेबेलममध्ये फक्त इन्फॅक्ट आहे, पण इफ यू सी हिज पॉन्स मेड्युला दे आर इंटॅक्ट. म्हणजे देर इज अ पिनम्ब्रा दॅट इज अ लिव्हिंग टिश्यू बट इश्चिमिक. So we have a chance to get him better. So हा MRI angiogram है. So this is a basilar artery. Pointer याच्यावर दिसत नाही का? So this is a basilar artery. इथनं ती अशी वरती जायला पाहिजे पूर्ण. इकडे bifurcation व्हायला पाहिजे. You are not seeing that. So that means it is occluded. Obviously clinical syndrome is relevant to it. सो आता आपण काही करू शकतो का? का करू? हा प्रश्न पहिल्यांदा का? कारण ऑलरेडी 24 तास झालेत प्रेझेंटेशन नंतर. द इंडिकेशन फॉर थ्रोम्बोलायसिस इज फर्स्ट 4.5 hours. नाव इट हॅज एक्सटेंडेड टू 6 hours. सो मी जे सांगत होतो की टिश्यू विंडो, की ही इज आउट ऑफ टाईम विंडो बट ही इज इन टिश्यू विंडो बिकॉज द टिश्यू इज व्हायबल. सो यू कॅन हेल्प हिम. सो क्लॉट रिट्रीवल, आता ऑब्वियसली क्लॉट रिट्रीवल needs some amount of money definitely. So looking at his economical condition, it was not possible नातेवाईकांना हे counseling केल्यावर. So we decided to go ahead with thrombolytic. आता हे का? कारण we have seen and we had references where even out of window patients can improve with IV thrombolysis. There is no bleeding risk. If you demonstrate that there is only a small infarct, there is no increased bleeding risk. So he received tenecteplase, which is the standard now. So after 2 hours he improved back to normalcy. So this is me with him celebrating. Next day he was on he was ventilated the other day, and the next day he was normal. And I learned that he's a 94-year-old and he had some role in independence. And this is his angiogram after I did, which showed a severe basilar stenosis, which I discussed before. So what is the outcome of such patients? Do you think any intervention is needed for that basilar stenosis in a 94-year-old? So we discussed in this stroke group. We have a big stroke group of nationwide of IS, Indian Stroke Association. And everybody said, just leave him, he is 94-year-old. But I said, he is working, he is active, we should give him a life. Whatever risk, if family wishes, we can go ahead with stent. So what happened is he was on medical treatment, and 3 months later, for some reason, he stopped his antiplatelets and he developed a massive brainstem infarct and died. So I don't know really how I helped him, but this is how stories evolve over a period of time. Oh, this is a case from quite a long time. In 2010, somebody young patient coming with basilar occlusion. He had a APLA syndrome, antiphospholipid antibody. They are known to have thrombotic tendency. So he developed again major, loss of consciousness, quadriplegia. He was intubated. This was his scan. And in scan on diffusion sequence, you see that it is absolutely normal. Maybe there is some hyperintensity which is developing, but brainstem is intact. So this is his emergency angiogram. This is angiogram, which shows that there is no flow beyond the mid-basilar segment. So this is for the first time we gave IA, intra-arterial TPA, in the clot itself, and he improved almost back to normalcy. So in every patient there is a different approach, different understanding, and each patient teaches you different aspects of treatment. So this is very interesting case. This gentleman was admitted somewhere else with recurrent right hemiparesis. He used to improve and then he used to deteriorate on antiplatelets, on heparin. So obviously when he came to us, we did his imaging and it showed border zone infarcts. Border zone infarcts are one of the indications that there is stenosis inside the artery. The border zone of the brain between two cortical mantles is more susceptible to ischemia when artery is stenotic. So this is a typical pattern of border zone. So on angiogram, you see that there is diffuse narrowing in the cavernous portion, but you also see on arterial phase the venous sinuses are getting opened. So this was very interesting. So what was happening is blood coming to the common carotid and going to external and internal. It was going into the venous sinuses through a dural AV fistula. So he was not getting that flow in his brain and he was developing vascular steel. So this is the dural AV fistula. You can, in arterial phase, when artery is opacified, you don't see venous structures in angiography. But here you see both of these simultaneously. So we identified the fistula and this is the embolization video. And this is after embolization. Now the connection is gone. He became normal, fluctuation stopped. So, discussing all aspects of these neurovascular disorders is beyond the scope of this discussion. But through these cases and through my understanding, I just wanted to let you know that every patient is different and you learn from each and every patient. And the other message is, be aware of stroke, because stroke is such a common thing and leads to disability and destruction of the whole family, because the earning member just cannot do his job and the whole family depends on him. So making a right decision for him is the most important thing that you can do and change his life. Thank you. Thank you for your patient listening.
Thank you. Any questions? Yeah.
In acute stroke, in which patient you should thrombectomy and which patient you should thrombolysis? Is there any clear-cut indication?
Yeah. So, somebody who comes within, say, window period of 4.5 hours, which is standard in the whole world, you should urgently do imaging. So on imaging, if you see that there is a clot in cervical ICU, cervical ICU is occluded, or the basilar or vertebral is occluded, that means it is a large vessel occlusion. So you should thrombolysis or thrombectomy. thrombectomy is 90% as compared to 30% of IV TPA. So, considering patient's wishes, considering his economic status, and then taking the right choice for him, whether it is mechanical or whether it is IV, all should be combined and then that decision should be taken. Sometimes I have done IV thrombolysis because the patients were not willing, but within an hour, when I monitored the patient, it was not improving, and we discussed the situation with relatives, and then we went ahead with mechanical thrombectomy as well. So there are multiple factors which make you decide, but if you look at scientifically, mechanical thrombectomy for large vessel occlusion is a must thing. I mean, it is standard of care now. No, mechanical thrombectomy can be done up to 24 hours, but you have to demonstrate on MRI that the tissue is viable, because the time to tolerate hypoxemia or ischemia varies according to each and every person.
Thank you.
Thank you.
Thank you, Hemant.
Now, may I request Dr. Chandan Shiva sir to felicitate our chairpersons. पटकन बुके कुठे गेलं बुके 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 अर्धे ना शिल्लक राहतील. Now, before pre-lunch session, now may I request Chandan Shiva ma'am and Shinde ma'am to chair the session. And next speaker is Dr. Next speaker is Dr. Rohit Kavishwar. He is son of Kavishwar sir and ma'am. Please welcome Dr. Rohit Kavishwar.
He is a spine surgeon. He's done MBBS from BJ Medical College, Pune, MS Orthopedics from SMS Medical College and Hospital, Jaipur. He's done spine surgery fellowship in Korea, St. Mary's Hospital, Catholic University of Korea, Dijonwari Hospital, Korea. Right now he is working in Asha Nursing Home, Valchanagar. So please welcome Dr. Rohit Akshay Kavishwar. His topic is endoscopic spine surgery.
चालतोय. कुठं ठीक आहे तुला कन्वर्ट करतो सॉफ्टवेअर अपडेट नाही ना ॲपल नाही चालते. हेच ना कोणतं आहे माईक लागेल तर मला वायरलेस नाही ना ह्याच्यात गुड आफ्टरनून एव्हरीबडी. येतोय का? देर वॉज एक्सिलेंट लेक्चर बाय डॉक्टर प्रसाद जोशी सर. आणि त्यांनी जसं सांगितलं की सर्वायकल स्पॉन्डलोसिस आणि लंबर स्पॉन्डलोसिस सध्या फार अर्ली प्रेझेंट होतं आहे. आणि जे पूर्वी 60मध्ये प्रेझेंट व्हायचं ते आता 40sमध्ये होतं. आणि जे पूर्वी 40sला व्हायचं जे लंबर PIVD आहेत ते स्लिप डिस्क वगैरे आता 20-30ला प्रेझेंट होत आहेत. सर जस्ट ब्रीफ डिस्कशन करूयात त्याबद्दल आणि काय टेक्नॉलॉजिकल ॲडव्हान्सेस आहेत सध्या. सो मणक्याचं ऑपरेशन म्हटलं की सगळे एकदम घाबरून जातात की आता काय मी चालू शकणार नाही किंवा आमचं ते काय नातेवाईकाचं झाले आणि ते बेड रिडन झाले. तर असं काही नाही आहे, हे मिथ आहे. कारण मॅक्सिमम प्रॉब्लेम्स L3, 4, 4, 5ला होतात वगैरे. तिथे त्याचं पॉवर बेसिकली फूट डॉर्सिफ्लेक्शन आणि प्लांटर फ्लेक्शन. जरी काही वर्स पॉसिबल झालं तरी फूट विकनेस येईल, असं बेड रिडन वगैरे नाही होणार कोणी. सो I've done my FNB spine surgery and I was in Korea for 1.5 years. Singapore 1 वर्ष होतो मी. Currently I'm working at Dinanath Mangeshkar Hospital, Pune KM, Ruby Hall Shirur and Vishwaraj Hospital. So endoscopic spine surgery came very late. This endoscopy in spine came very late because it's a natural cavity नाही आहे. As गॅस्ट्रोस्कोपीमध्ये असते किंवा लॅप्रोस्कोपीमध्ये असते CO2 इन्सफ्लेट करतात. बट स्पाईनमध्ये सम कोरियन जिनियसेस आले आणि त्यांनी म्हटलं की आम्ही ट्राय करू. आणि व्हॉट दे डिड वॉज दे यूज फ्लुईड सलाईन आणि सलाईनच्या प्रेशर यूज करून मल्टीफिडसच्या खाली थोडीशी जागा बनवली. सो दॅट वॉज केप्ट अ सिक्रेट फॉर 2-3 years आणि त्यांनी ती प्रॅक्टिस केली आणि मग देन रिव्हिल्ड इट टू द वर्ल्ड अराउंड टाईम ऑफ कोविड. सो जस्ट अ ब्रीफ ॲनाटॉमी. 7 सर्वायकल वर्टिब्रे असतात, 12 थोरॅसिक जस्ट बिकॉज पुढे MRI एक्सप्लेन करायचं आहे मला, आणि 5 लंबर वर्टिब्रे आणि सेक्रम. सो स्पाइन इज लाईक अ बिल्डिंग विच नीड्स लॉट ऑफ मस्क्युलर सपोर्ट आणि प्रत्येक वर्टिब्रेच्या मध्ये डिस्क असते, त्याला आपण गादी म्हणतो. आणि हा जो पोस्टिरल लिगामेंटल स्ट्रक्चर आहे दॅट इज व्हेरी इम्पॉर्टंट. सो दिस इज लिगामेंटम फ्लेवम जे आपले ॲनेस्थेटिस्ट पिअर्स करून इथे स्पायनल ॲनेस्थेसिया देतात. इंटरस्पायनस लिगामेंट. So open spine surgery when usually we sacrifice all the interspinous ligament and spinous processes. So त्यामुळे destabilize होते spine. So whole concept about minimal invasive is की target oriented. So हा anatomy आहे, हा vertebra आहे, डिस्क आहे मध्ये आणि नर्व रूट फोरॅमन मधून बाहेर येते आणि ह्या 2 लॅमायनाच्या मध्ये इंटरलॅमायना स्पेस असते जिकडे लिगामेंटम फ्लेवम असतो. हा एक्सरे मी पर्पजली टाकला तर ओपीडीत लोक विचारतात मला मणक्यात गॅप आहे, तर ते गॅप म्हणजे नॉर्मल आहे, म्हणजे गॅप असणं हे चांगलं आहे. रादर दॅन इट इज नॉट अ प्रॉब्लेम. गॅप असणं इज अ डिस्क जी काही एक्सरेवर दिसत नाही, त्यामुळे आपण MRI करतो. सो गॅप असणे हा प्रॉब्लेम आहे, हा असं काही नाही आहे म्हणजे. सो हे 3D मॉडेल आहे एक स्पाईनचं. सो दिस इज इंटरलॅमिनर स्पेस 3, 4, 4, 5. मी का सांगत आहे कारण डिस्कचे मेजर प्रॉब्लेम म्हणजे 2 असतात. एक रॅडिक्युलर सिम्पटम जे डिस्कमुळे आणि एक मागून जे प्रेस होतं जे लिगामेंटम फ्लेवम हायपरट्रॉफीमुळे होतं. सो इकडे लिगामेंटम फ्लेवम असतो आणि ह्याची हायपरट्रॉफी झाली की स्टिनोसिसचे सिम्पटम येतात, पेशंट चालू शकत नाही. आणि अर्लियर वी हॅड अ टॉक अबाउट जे क्रिटिकल लिम इश्चेमिया. सो हाऊ टू डिफरन्शिएट. सो न्यूरोजेनिक क्लॉडिकेशनचे पेशंट फार हेवी, दोन्ही पाय हेवी, पल्सेस प्रेझेंट असतात अँड दे कॅनॉट वॉक बियॉन्ड 10-12 minutes. रेस्ट करतात, थोडंसं स्टूपिंग पोश्चर असतं. टिपिकली स्वतः सगळं सांगून देतात OPD यूज तोपर्यंतच. सो आणि बाकी असतात पॅरास्पायनल मसल्स, जे की आम्ही युजल ट्रेडिशनल ओपन सर्जरीमध्ये सॅक्रिफाईस करतो. सो हे मसल्सला कॉटरीनी बर्न केल्यावर डिनर्वेशन झालं की फॅटी चेंजेस येतात, आणि त्यामुळे पेशंट इज नेव्हर हॅपी. कुठेतरी काहीतरी थोडंसं बॅक पेन होतं आहे, इज रेडिक्युलर पेन कमी आहे, बट ही इज नेव्हर हॅपी. सो हा स्पाईनचा MRI हा आपला ब्रेन आहे, हे ऑल द वे थ्रू इट्स लाईक अ हायवे, खाली स्पायनल कॉर्ड जाते आणि इथे कुठे फ्री आहे सगळं. सो प्रॉब्लेम येतो जेव्हा हा पुढून गादी सरकते किंवा मागून लिगामेंटम फ्लेवमची हायपरट्रॉफी झाली, पुढून गादी सरकली तर स्लिप डिस्क PIVD, आणि मागून काही प्रॉब्लेम आला तर इट इज कॉल्ड स्टिनोसिस. सो दिस इज अ नॉर्मल लंबर MRI पिक्चर. आणि हे MRI जे दिसतात मागे, दिस इज हा बल्क, दिस इज व्हेरी इम्पॉर्टंट. सो दिस इज पॅरास्पायनल मसल्स, हा एक्झियल व्ह्यू आहे, ही डिस्क आहे इकडे, आणि हे जे डॉट डॉट आहे ते नर्व रूट्स आहेत. आणि युजल MRI असा पाहिजे एकदम क्लीन. आता इफ यू सी, या पेशंटला डिस्बल्ज आहे, 4-5ला मोठी डिस्क बाहेर निघालेली, पेशंट पेन फार सहन करतोय पेन किलर घेऊन वगैरे, बट इफ यू सी इथे मागे पॅरास्पायनल मसल्सला ऑलरेडी फॅटी चेंजेस झालेले आहेत. सो ॲज अ क्लिनिशियन मला त्या फंक्शनची पडलेली आहे. पेन कॅन बी कंट्रोल बाय मेडिसिन्स, पण मग फंक्शनचं काय होणार पुढे, आणि व्हॉट अबाउट नेक्स्ट लेवल्स. ऑलरेडी वर खाली थोडंसं डार्कनिंग आहे, यंग एजला द डिस्क इज हेल्दी, इट इज लाईक अ स्पॉन्ज, पण ग्रॅज्युएशन डिहायड्रेशन होऊन जातं, डेसिकेशन रिपोर्टमध्ये आपण वाचतो डेसिकेशन झालं, डिग्रेडेशन, सो त्याचं वॉटर कंटेंट कमी होतं, त्यामुळे सिग्नल डार्क यायला लागतात MRIला. सो इफ यू कम्पेअर दिस टू, इथे पॅरास्पायनल मसल्सचा बल्क बघा आणि वर फॅटी चेंजेस झालेले आहेत फार. सो नुसतं पेन कंट्रोल जरी केलं आणि फंक्शन नसेल तर दॅट इज नॉट अ गुड थिंग फ्युचरला, कोणी ॲक्टिव्ह इंडिव्हिज्युअल असेल तर. सो दिस इज अ नॉर्मल स्कॅन, आणि हा स्टिनोसिस हा मागून येतो, डिस्क वॉज पुशिंग फ्रॉम अँटिरियर. सो हा जस्ट ब्रीफ कन्सेप्ट का दिला, कारण वी हॅव टू चेक फॉर द पॅरास्पायनल मसल्स. नुसतंच डिस्क क्लिअर झाली की इथे स्टिनोसिस क्लिअर झालं एंडोस्कोपिकली, मागून कुठे काही ट्रेसेस नाही, कुठे अटॅक झाला आहे, all the paraspinal muscles are intact 1 year follow-up ला सुद्धा. So these patients do very well. The whole concept of minimal invasiveness is this, आणि हेच ओपन सर्जरी आहे. पेशंट क्युअर झालेला आहे, बट मागे पॅरास्पायनल मसल्स आर ऑल चेंज इन टू फॅटी कन्व्हर्जन झालं आहे त्यांचं. सो दे डोंट हॅव पॉवर, त्यामुळे अख्ख्या स्पाईनला सपोर्टच नाही आहे. सो दे कीप ऑन कंप्लेनिंग, दे आर नेव्हर हॅपी. सो स्पाईन सर्जरीनंतर खुश नसतात वगैरे, अगर प्रॉपरली वाईजली इलेक्ट केले पेशंट, जे की आमचे 100पैकी 20 वगैरे असतात, बाकी 80% कन्झर्वेटिव्ह होऊन जातात. सो कन्सेप्ट ऑफ मिनिमली इन्व्हेसिव्ह इज की पोस्ट ऑपरेटिव्ह रिकव्हरी लगेच व्हायला पाहिजे, देर शुड नॉट बी एनी बेड रेस्ट, आणि वॉकिंग वगैरे लगेच चालू करतो आम्ही सेम डे इव्हनिंग. सो दॅट ब्रिंग्स की लगेच डिस्यूज ॲट्रोफी होते. माझं स्वतःचं पटेला फ्रॅक्चर झालेलं आहे, सो विदिन 2 weeks क्वाड्रिसेप्स वेस्टिंग झालं, आणि थाय अजूनही म्हणजे मी एवढा ॲक्टिव्ह होतो स्टील. सो डिस्यूज ॲट्रोफी फार कॉमन आहे, बट लास्ट 4-5 years वी हॅव सीन की टेक्नॉलॉजी फारच इम्प्रूव्ह झाली, आणि कॅमेराज अँड ऑल 4K कॅमेराज आलेत. सो वी कॅन सी वन कॅपिलरीज, ब्लड फ्लो एकदम छान दिसतं. म्हणजे इट इज व्हेरी डिफिकल्ट टू इंजर न्यूरल स्ट्रक्चर, असं मुद्दाम केलं तरच होऊ शकतं ते. सो बेसिक कन्सेप्ट इज टू डिकम्प्रेस न्यूरल एलिमेंट्स अँड प्रिझर्व फंक्शन, आणि मग रिझॉल्व पेन. सो दिस इज मायक्रोस्कोपिक सर्जरी. मायक्रोस्कोप इज युजली आउटसाइड द बॉडी, आणि इन्स्ट्रुमेंट आत जातात. एंडोस्कोपमध्ये स्कोपच आत जातो, इट इज व्हेरी नियर टू द पॅथॉलॉजी, and that's why we can decompress exactly किती पाहिजे तेवढं आहे, and we don't disturb the normal other elements. So this is traditionally what I got trained first, की मायक्रोस्कोपिक मध्ये इन्स्ट्रुमेंट बाहेरून आत जातात, आणि आय आपला बाहेर आहे. किती जरी झूम केलं, जाईसचा मायक्रोस्कोप जरी असला, सो इट इज नॉट ॲज गुड ॲज हिअर. आणि जो फील्ड आहे तो इकडे ब्लडी फील्ड आहे, अँड हिअर यू कॅन सी हे छान ड्युरा आहे, इकडे फॅट आहे, यू कॅन सी लिगामेंटम फ्लेवम, बोन, ते दाखवतो पुढच्या व्हिडिओमध्ये. सो वाय शुड वी चूज एंडोस्कोपी, कारण लेस स्कार आहे. हे 8 mm स्कारमध्ये डिस्क निघून जाते, आणि इनिशियली जेव्हा न्यू एंडोस्कोपी आल्या डिस्केक्टॉमीसाठी फक्त, बऱ्याच लोकांची सर्जरी फेल झाल्या, असं म्हणजे एंडोस्कोपी फेल होत. पण नाव विथ न्यू टेक्नॉलॉजी 2 पोर्ट बनवतो आम्ही. मे बी इट वॉज इन्स्पायर्ड बाय लॅप्रोस्कोप, आणि आता पण वॉटर बेस्ड आहे. सो कंटिन्युअस इरिगेशनमुळे पिक्चर फार क्लिअर आहेत. सो वी कॅन डिकम्प्रेस फ्युजनही एवढ्याशा इन्सिजन्समध्ये व्हायला लागले. अँड ऑल आवर ओपन सर्जरी इन्स्ट्रुमेंट्स ऑल्सो गो. सो एक्सपेन्सेस वाईज फक्त जे सेम ट्रॉली आहे गायनेकमध्ये जे वापरतात तशीच सेम कॅमेरा, सेम वी कॅन यूज द सेम थिंग, आणि फक्त स्कोप चेंज होतो. 170 mm चा येतो लेंथ वाईज, आणि 4 mm विड्थ. सो हा चार्ट बघितला तर अराउंड कोविड सडनली सर्च झालं. अराउंड दॅट टाईम कोरियन्सनी ती टेक्नॉलॉजी बाहेर काढली. दे बिकेम द एक्सपर्ट्स अँड देन त्यांनी रिव्हील केलं की दुसऱ्यांना शिकवायच्या आधी स्वतः एक्सपर्ट झाले प्रॅक्टिस करून. सो करंटली जनरेशन्समध्ये वी आर इन टू 4th जनरेशन अँड लकीली आय हॅड अ चान्स टू ट्रेन विथ डॉक्टर सॉंगक्युसॉन. इज द पायोनियर फॉर द UB सर्जरी जी आमची आता करंट व्हायरल आहे, करंटली एकदम गेम चेंजर आहे. सो हा व्हिडिओ बघितला तर दिस इज ट्रेडिशनल ओपन सर्जरी, जिकडे इन्सिजन घेतल्यावर आम्ही कॉटरीनी सगळं बंद करत जातो, हे सगळे मसल्स एंडपर्यंत. इट इज मॅक्सिमल इन्व्हेसिव्ह. इकडे जाऊन लिगामेंटम फ्लेम काढून ड्युरा रिट्रॅक्ट करून मग डिस्क काढतो. दिस इज युजली अराउंड 8 to 9 सेंटीमीटर इन्सिजन. मग मायक्रोस्कोप आले त्यात 4 सेंटीमीटर अँड नाव वी कॅन डू इट इन 8 mm. बट त्यावेळेस टेक्नॉलॉजी नव्हती अँड कॅमेराज वर ऑल्सो नॉट डेव्हलप्ड. सो आता दिस इज ओपन डिस्केक्टॉमी, मायक्रो डिस्केक्टॉमीचा इन्सिजन, ट्युब्युलर अँड एंडोस्कोपिक. सो चालू शकेन का नाही मी असं विचारतात लोक, तेव्हा मी हा व्हिडिओ दाखवला होता. नाही, वेन आय वॉज डुईंग माय फेलोशिप रेग्युलर होतं. विदिन 4 to 5 hours पेशंटला चालवायचंच, बिकॉज ते कोणाला थांबायचं नसतं जास्त हॉस्पिटलमध्ये. सो हा ॲम्ब्युलेशन प्रोटोकॉल अँड डॉक्टर हॅज टू गो हिमसेल्फ हात पकडून. सो मी चालू शकणार नाही वगैरे हे काहीच प्रॉब्लेम नाही. मॅक्सिमम काय थोडंसं फूट पॅरास्थेसिस वगैरे राहतात. So with minimally invasive same day mobilization at the max next day morning is usually what we follow. आता हा 4K कॅमेराचं व्हिज्युअलायझेशन बघितलं तर यू कॅन सी दिस इज ड्युरा, कॅप्युलरीज सगळं एकदम क्लिअर ब्लडलेस सर्जरी होते. आणि कंटिन्युअस सलाईन इरिगेशन असल्यामुळे हे फॅट आहे एपिड्युरल फॅट. सो कंटिन्युअस इरिगेशन असल्यामुळे कुठे काही प्रॉब्लेमच येत नाही, ॲटलिस्ट व्हिज्युअली. सो ब्रीफली एंडोस्कोपिक डिस्केक्टॉमीमध्ये वॉट वी डू इज सियाममध्ये गाईड वायर टाकतो, एकदम टार्गेट ओरिएंटेड आहे आणि इट इज परक्युटिनस कम्प्लिटली अंडर सियाम. सो आफ्टर वी एंटर द स्कोप ते कंटिन्युअसली दिसत राहतं. सो नरला रिट्रॅक्ट करून दुर्बिणीद्वारा काढता येते. आणि जी डिस्क आहे ते काढली तर तिथे काय होणार, हा काही कॉमन प्रश्न आहे. तिथे काहीच करत नाही, इथे टेअर असतो. तिकडे कधी कधी PRPP टाकतात किंवा काहीच करत नाही, फक्त रेडिओ फ्रिक्वेन्सीवर लेझरनी ॲब्लेट करतो, सील करतो आणि बाहेर येतो. त्यानंतर थोडेसे फक्त पथ्य पाळायला लागतात की वजन उचलायचं नाही वगैरे. बाकी इमिजिएटली नेक्स्ट डे वॉक रुटीन चालू, काही बेड रेस्ट असं काहीच नाही. आणि सध्या याला पॉप्युलराइज केलं स्टिचलेस सर्जरी म्हणून. ते 8 mm आहे. स्टिच इज द चॉईस ऑफ सर्जन. स्टिचलेस आहे का नाही दॅट इज अप टू पेशंट, त्यांनाच विचारतो स्टिच पाहिजे का नाही, जस्ट बँडेड इज ओके. सो दिस इज बेसिकली युनिपोर्टल सर्जरी, ज्यात ह्यात कॅमेरासुद्धा आहे आणि ड्रिलसुद्धा आत जाते. सो बेसिकली वी आर शेविंग ऑफ द बोन. 3 mm वर टिप येतो आणि शेव करताना हार्डली 1 to 2 mm बोन काढतो आम्ही, जास्त काही नाही, फक्त जस्ट टू डिटॅच द लिगामेंटम फ्लेम. आणि ते एकदा ड्युरा आयडेंटिफाय केला की रिट्रॅक्ट करून डिस्क काढून लगेच बाहेर यायचं. अँड युजली डोंट नीड एनी असिस्टंट, काही नाही, फक्त आणि आय लेवलला स्क्रीन असतो. सो इट इज व्हेरी कम्फर्टेबल सर्जरी. अनलाईक ओपनमध्ये यू ऑलवेज नीड असिस्टंट की ज्याला सक्शन किंवा जो वेल ट्रेन असिस्टंट लागतो. सो इट इज गुड फॉर द डॉक्टर ऑल्सो. सो हे न्यूक्लियस पल्पोसस आहे. युजली इट हर्निएट्स आणि न्यूक्लियस पल्पोसस इज नॉट एक्सपोज टू अवर इम्युन सिस्टम. सो वेन इट कम्स आउट ते एकदम हायपर इम्युन रिस्पॉन्स होतो आणि ते फार सारं इन्फ्लेमेशन येतं, स्वेलिंग येतं. सो डिस्क हे इनिशियली थोडंसं अँटी इन्फ्लेमेटरीने कमी होऊ शकतं, पण एकदा प्रेशर सिम्टम आले की दॅट इज नॉट युजली रिझॉल्व. सो दिस वॉज डन बाय मी इन अराउंड 2021. हे पोस्टिरियर सर्जरी जिकडे स्पायनस प्रोसेस काढले, लिगामेंटम फ्लेवम काढले, और 3 level डिकम्प्रेशन आहे, ड्युरा दिसतोय व्यवस्थित. बट दॅट वॉज द नॉर्म आय फॉलोड देन. पण आता हे सगळं कळल्यावर की विथ एंडोस्कोप हेच होऊ शकतं. सो आय हॅव चेंज माय प्रॅक्टिस. मलाही वाटलं दिस इज टू मच डॅमेजिंग, म्हणजे पॅथॉलॉजिकल टिश्यू वगैरे मागे सपोर्ट काय, फक्त मसल क्लोजर आहे ह्याच्यावर आणि स्किन आहे. सो बाकी ज्या गोष्टी ब्रिजसारख्या आहेत, स्पायनस प्रोसेस येते, दॅट शुड बी इंटॅक्ट. सो दॅट पेशंटची मुवमेंट आता हे फार प्रायोरिटी आहे. सो हे फक्त 4 स्टेप इन्सिजननी फ्युजन होतं सध्या. सो इंडिकेशन्स आर द सेम, बट इम्पेअरमेंट ऑफ बाउल ब्लॅडर फंक्शन विथ अ डिस्पेशन ही इमर्जन्सी, त्याला कॉर्डाइक वेना सिंड्रोम. सो इफ दिस पेशंट इज नॉट डिकम्प्रेस विदिन 12 hours, परमनंटली ते फंक्शन जाऊ शकतात आणि ते कधी रिकव्हरी फार काही होत नाही. समो ब्लॅडर फंक्शन गेलेलं आहे वगैरे असं होतं आणि डिकम्प्रेस केल्यावरही पूर्णपणे काही येत नाही. सो लिव्ह नो ट्रेस इज द मोटो. सो हॅपी पेशंटसाठी असेल तरच आपण हॅपी राहू. सो ही डिस्केक्टॉमी डिस्क केलेली आहे, मागून कुठेच काही कळतच नाही की बोन रिमूव्ह केलं आहे वगैरे काय. सो दॅट इज द पॉवर ऑफ मिनिमली इन्व्हेजिव्ह एंडोस्कोपिक स्पाइन सर्जरी. विथ 8 mm इन्सिजन एवढी डिस्क निघू शकते, कारण ग्रास्पर्स वगैरे इतके शार्प आणि इतके पॉवरफुल इन्स्ट्रुमेंट्स आले आहेत सध्या. सो लेस देन 8 to 9 mm मध्ये होऊन जातं. सो एंडोस्कोप, द पॉवर ऑफ एंडोस्कोप इज ऑल्सो लेस डिसेक्शन. सो बाय चान्स कधी रिव्हिजन सर्जरी लागली, सो वी डोंट गेट एनी फायब्रोसिस इनसाइड अँड ब्लिडिंग इज ऑल्सो लेस. आणि आयडेंटिफाय करणं की डिस्क आहे की फायब्रोसिस आहे की रिकरंट प्रॉब्लेम आहे काही, तो 4K इमेजिंगमुळे इट इज इझी टू डिफरन्शिएट. अनलाईक ओपन सर्जरी सक्शन करतोय, एपिड्युरल ब्लिडिंग होतंय. सो नाव द इंडिकेशन्स हॅव एक्सपांडेड टू थोरॅसिक आणि सर्वायकल ऑल्सो. सो पूर्वी फक्त लंबार डिस्क व्हायची, आता वी हॅव एक्सपांडेड टू सर्वायकल फोरामेनोटॉमी वगैरे. सो बेसिकली लेस पोस्ट ऑपरेटिव्ह पेन, शॉर्टर टाईम टू रिटर्न टू वर्क, शॉर्ट हॉस्पिटल स्टेचा खर्चही कमी होतो. सो मिनिमली इन्व्हेजिव्ह इज पॉवरफुल इन मेनी वेज. आणि बऱ्याच वेळा फ्यूज वगैरे केलं की ॲडजस्टिंग लेवललाही प्रॉब्लेम यायला लागतात. सो आय डोंट लाईक टू पुट स्क्रूज. हे मिनिमली इन्व्हेजिव्हमध्येच पॉसिबल आहे, जितकं होईल तेवढं. सो कन्व्हेन्शनल सर्जरी इज लाईक बालाकोट स्ट्राईक, जिथे सगळंच टेररिस्टही गेले, फॉरेस्टही जळून गेलं. आणि MIS एंडोस्कोप इज लाईक अर्जुनच्या मानासारखं, एकदम टार्गेट ओरिएंटेड अप्रोच आहे. सो इतकं ब्युटिफुली दिसतं ड्युरा, हे वेसल्स, इच अँड एव्हरी वेसल कोॲग्युलेट करू शकतात विथ रेडिओ फ्रिक्वेन्सी. हा युज्युअल OT सेटअप आहे. हा टॉवर असतो, कॅमेरा, लाईट सोर्स आणि RF. सो वॉट मेनली आमचं 3 layers म्हणतो आहे. दिस इज लिगंटम फ्लेवम, एपिड्युरल फ्लॅट. वी वर्क अंडर द फ्लेवम आणि फॅट इज लाईक थोडंसं प्रोटेक्शन ड्युरापासून. पेशंटला स्टिनोसिस विथ डिस्क दोन्ही होतं. डिकम्प्रेस केल्यावर सिम्पटम रिलीफ, स्क्रूज नाही, काही नाही. सो एकदा वन्स वी लँड, वी क्लिअर द इंटरलेमिनर टिश्यू विथ रेडिओ फ्रिक्वेन्सी आणि छान आयडेंटिफाय होतं सगळं. सो दिस इज येलोइश लुकिंग इज येलो लिगामेंटम फ्लेवम. जे काही पिंक आहे ते थोडेफार ब्लड वेसल्स आहेत आणि ते इझिली कोॲग्युलेट होऊन जातात. आणि RF ओनली वर्क्स अंडर सलाईन. Usually herniated disc stains blue with indigo carmine. So in all the procedures we put a dye. So extra disc पण काढायची नाही. So whatever is herniated, कारण त्याचं कनेक्शन तुटून जातं मेन डिस्क पासून. सो दॅट इज स्टेन ब्लू. दिस ऑलरेडी झूम्ड इन व्यू. सो दिस बर इज ओनली 3 mm. तर शेव करताना हार्डली 2 mm वगैरे बोन शेव करतो. सो जास्त बोन वगैरे काही बोनवर राहतच नाही. वी डोंट टच द जॉईंट्स. सो इन्स्टेबिलिटी वगैरे फार कमी होते. फॉर सर्जन्स आय वॉन्ट द फ्लेवम इज अ फ्रेंड. जोपर्यंत काम होत नाही बोनीवर फ्लेवम काढायचं नाही. सो फ्लेवम प्रोटेक्ट्स द ड्युरा. स्मॉल चिझल, 3 mm चिझल. बोनी एजेस थोडेसे चिझल ऑफ केले. आणि इरिगेशनमुळे जे थोडंसं छोटेसे ब्लिडर असतात ते वॉश आउट होऊन जातात. सो ह्याच्या खाली स्पायनल कॉर्ड आहे आणि ह्याला रिट्रॅक्ट करतो आम्ही. रिट्रॅक्ट केलं की ब्लूइश टिंज दिसला की दॅट इज अवर डिस्क. सो नो नीड टू हंट. The bulging disc fragment. So एक केस रिपोर्ट केली होती सर्वाइकलला. So we removed a small osteochondroma. So endoscopy can be done in the neck also. So minimally invasive surgeries are the future आणि यातनं ओपन हे रिड्यूसच झालेलं आहे भरपूर. तर दिनानाथलाही सगळे प्रोसिजर ऑल द प्रोसिजर्स आर मिनिमली इन्व्हेसिव्ह आणि एंडोस्कोपी मोस्ट ऑफ द सर्जन्स हॅव पिक्ड अप नाव. So no need to fear about spine surgery. असेल तर properly selected candidate, the results are very good. And what if I have seen further than others, it is standing upon the shoulder of the giant. This is for our seniors who have already done a great job. त्यामुळे आम्ही या जनरेशनला हे सगळं बघायला मिळतं. थँक्यू.
थँक्यू सर. Chairpersons, kindly summarize the session.
Thank you, Dr. Rohit, for the wonderful elaboration about the minimally invasive spine surgery. Thank you very much. You have explained it in a very simpler way. Very nice talk. Thank you.
Thank you.
Now may I request Dr. Panbode sir to felicitate Dr. Rohit. Now may I request.
Actually, Rohit has explained the non-invasive surgery very nicely. How through a 8 mm incision, how you can go up to the dura mater and all that, and how, and he has also explained some sort of anatomy also, because we have forgotten that anatomy of the spinal cord. What is meant by disc prolapse and what is meant by canal stenosis? I really tell you, even I was not knowing what is canal stenosis. By listening to your lecture, I have come to know that it is because of the hypertrophy of the ligamentum flavum, which is pressing from backwards, and that is causing canal stenosis. We are explaining to the patients, and when we see the MRI report, we are seeing there is disc prolapse, there is desiccation, there is canal stenosis, but we are not knowing what is happening there. Even we have studied the anatomy. So hats off to Rohit. You have given very nice insights about the lecture. Again, I thank for coming over here for our lecture, and I hope as you are a product of Indapur, you will definitely visit our IMA and give us more insights about the new topics. Thank you.
Now may I request Dr. Komal Gade ma'am to felicitate Chandan Singh ma'am and Shinde ma'am.
All the delegates are requested that now we will have a lunch break of 20 minutes. But my humble request to all the delegates is that we have a stall exhibition and many pharma companies have come on our request. So I request all the delegates to visit the stalls. You can see the advanced medical equipments there. You can see the newer medicines also, so that it will be very helpful for the delegates. So I again request you to visit stalls, those who have taken their food, and others, they can go upstairs and have a very delicious, tasty food. Thank you. Maharashtrian food. you may be still awake to hear from our faculties. I request our senior gynecologist and respected Dr. Nagre sir and Dr. to chair this session.
Request Dr. Arbet sir for next lecture. Arbet sir has completed his MBBS in 2000, University of Mumbai, and sir has completed his MS Ortho in KM, University of Mumbai, third place in the university, and sir has completed his MCH Orthopedics in 2007 in Royal College of Surgeons, Edinburgh, UK. I request Dr. Arbet sir to start his lecture.
A new hip replacement technique called SuperPATH hip replacement. We are doing in 3 inches incision. Couple of lectures on robotic surgeries, and by grace of the Almighty, we have all the 4 robos what are available in the market now.
व्हिडिओ आहे का पीपीटी तो व्हिडिओत लावायचा
कंट्रोल माझ्याकडे ठेव. Sorry for the delay. So 2-3 things. We are specialized in special specific instrument. I have done my MS from KM Hospital, Mumbai, and my FRCS from England, and I have done my fellowships from US, Princeton, in robotic replacements, and I have been working in this field of robotic hip replacements and knee replacements for the last 17 years. Definitely my base started with Fortis, then I was in charge of Lokmanya hospitals. Now am I working in Jahangir and Oyster and Pearl hospitals, and we have finished more than 13,000 successful hip and knee replacement surgeries. These are my professors whom have trained me in the US in joint replacements, and they remain the pioneers of joint replacement. I was the first Asian to receive gold medal in FRCS also, and nevertheless our Indian bosses. I started robotics in 2014, then we moved from one dimension to two dimension, and since 2020 we are doing what is known as 3D robotics, which includes use of all the 4 robos, and we have tied up with Microsoft. So if you have listened to the lectures today, so somebody must have talked about the Mako, the Cori. So in all the 4 centers we have worked, we have each robo. But what we have found out nowadays that robotics is being taken over by implant companies. And what is happening is every robo forces you to put their company implants. So we had to move away from sticking to a particular implant because every implant is different, every patient is different. So we have now tied up with Microsoft to select the best patient-specific implantation. So what happens in robotics is there is no surgeon control, and each design, each company might not suit the patient. I always give an analogy that even if Merc is a very good car, it might not work in the rural areas. So it's better to give the patient a Fortuner than to give a Merc. So we are choosing, every patient gets a patient-specific implant, and that's what we are going to talk about today. And the results that we are seeing are breathtaking. Now, coming to our topic today, that patient-specific implantation, complete surgeon control, what does that mean? I have to select the implants which fits the patient 98%. So we'll be using special Microsoft software where we do CT scans, and like this, we study the anatomy in 3 dimensions. We plan, AI tells us which implant goes best. Before touching the patient, we do a virtual surgery for the knee and the hip, and we have completed more than 5,000 AI-based surgeries now, and now the version 3 has come, and this is known as the Robo 3 Viz, where we also choose which robo to use, because each implant should suit the patient more than 98%, especially in the hips, where hip replacement is now to be chosen from 13 different implant companies, and getting the best implant which suits the patient is the final goal. The commonest problem which you as general practitioners are facing must be the avian, which is post-COVID. Post-COVID, if you see these kind of x-rays, they complain the pain in the groin, the buttocks, restricted range of movement, loss of mobility for more than 15 days, no relief on pain, and have disproportionate limb length. They have a limb length discrepancy. You expect avian. This was the statistics. As doctors, we should know this. I'm reporting to the PM office. I'm one of the selected doctors for avian of the hip. You will be astonished that 40 lakh people in COVID time have got avian. 95% of the patients are males, young males. These were the initial thought about processes of avian use, corticosteroids or alcohol, sickle cell, smoking, pancreatitis, but COVID-19 has opened up Pandora's box, and post-COVID-19, the volume of the world has gone to 6 crore avian patients which are lying in and around Asia and also Europe and Americas. So it's a very serious topic, and a lot of these patients need the total hip replacement. But there's a common dictum that there are approaches available which most of the surgeons are taking, the superior approach, the posterior approach, the anterior approach. But nevertheless, these all approaches, the basic problem is muscle cutting. And mind you, joint replacement is a soft tissue surgery. It is a plastic surgery. Saving these muscles are going to give us good results. Whichever implant we use, but if we don't save the basic structures, the hip replacement is going to fail. So we moved out to a newest technique to prevent these kind of complications in the hip, which is because of the muscle cutting, called a SuperPATH hip replacement. So what is SuperPATH? As the name suggests, it is superior approach percutaneous hip replacement. Technically, we are doing the hip replacement in 2 inches incision. And how do we do it? This is the animation. What are the basic requirements of SuperPATH? There's certain specialized instruments, saving all the muscles, even the basic ligaments. Internal capsule is also not cut. And so this is the anatomy, if all of us remember to brush through it. The capsule, which is cut in the regular hip replacement, the static stabilizers, the ligaments, each and every muscle is saved. The green arrow is the approach that we take, which is not muscle cutting, it is muscle splitting. There are special retractors that we are using. The incision ranges from regular THR is done in around 18 inches, if you have seen. This SuperPATH we are doing in around 2 inches. It is like technically endoscopic hip replacement surgery. When we use these special instruments, unlike the regular hip replacement where the head is dislocated every time and cut, we do the surgery in situ, in the patient's position. So what does that do? When it is done in the patient's position, I know his angles, I know his versions, I know what angle I have to put each implant which matches the patient. And that is the beauty of the SuperPATH. We don't dislocate the hip at all. And head is resected in situ in the patient's angle. And as doctors, you understand, when it matches the engineering of the hip, this hip is going to last for life. Hip replacement now has become more of engineering than, unlike the knee replacement where everything is open. Since it's a keyhole kind of a surgery, acetabular angles and everything we are measuring with robotics, but placing, saving. See how small incision we are taking to put the best of the implants in the world. Beauty now, since we have done so many cases, we are using any implants, 13 company implants from the world which suit the patient. The incision, so we are using ceramics, we are using cemented implants, we are using, so what we do is, we have robotic software from Microsoft. We will plan the surgery before the surgery one day. Each patient, the AI tells us which implant suits, what is the angle, what is the inclination in 3 dimensions. This is planned by us. And once we know which implant, which company, we are using complete AI for this, then we place the implant. So it is not a rocket science that when the implant is suiting to the patient, this is going to be surviving for life. You can appreciate that other zig coming from the other side. It is percutaneous rimming because we don't open much. So everything is percutaneous. So it is now possible to do replacement through the skin. It is such a small incision, nothing is disturbed. And each implant, when it's placed, there is only 1 or 2 layers of closure. Technically, I make the patient stand on day 1, which was not possible in hip replacements. So whichever implants we use, if we do it with SuperPATH, percutaneously assisted, it becomes a different game changer for the future coming generation, because most of them are young people. So this is how intraoperative we see with robotics. And only robotics is not going to help. We need to respect the soft tissue, because robotics is 30%, 70% is the soft tissue. So these are special instruments that we are using. And see, I'm placing the acetabulum in just around 2 inches incision, which normally takes 18 to 19 inches incision, and complete hip replacement is done. Patient technically is scarless. Even for the women, the scar is known as a bikini incision. It goes under the undergarment. So tomorrow if you are wearing a swimming dress, nobody will tell that you have undergone a hip replacement. See the activities that the patients are doing. I don't see any restrictions like sitting down, sports. My patients are even running marathons. They are doing namaz positions. I'm getting a lot of international patients in Jahangir for this. In 2025, we celebrated the highest number of hip replacement in Maharashtra. And thanks to people, your support, we were awarded the Governor's Award for in the year 2020. We are doing a lot of charity work because most of these patients come from poor background. There are a lot of talks that we give and media. My website is interactive. There is a lot of PR activity in the media also. So SuperPATH hip replacement, whenever your patient needs, we are the people to understand, because it is a very serious stuff. There are a lot of sports people that we have operated. They are playing international sports, and nevertheless, understanding the nuances of hip replacement. Hip replacement remains a soft tissue surgery. It's like a plastic surgery. When you choose the right surgeon, the things really can make a difference. So our mission is customized joint replacements for everyone. We even have 3D printed implants. I have an interactive website. Those who want, you can visit our website and help your patients and contact us for any hip related issues. Nevertheless, we are also into conserving the hip. So when I do around 800 hips per year, I might be saving 1600 hips. There are a lot of new techniques that are come for conserving the hips, like stem cells and other factors. But when a person needs a hip replacement, now if we do with SuperPATH, on paper we can give guarantee of 70 years without any restrictions. So such implants have come. Only thing, respecting the soft tissue, doing it at the right time, and saving the soft tissue is the whole ball game. Thank you. Any doubts? Hi,
Thank you, sir.
Okay.
Thank you for excellent presentation. And the session is open for any discussion. Any questions?
Sir, for this SuperPATH technique, what is the exact quotation for case?
You're asking when can we do a SuperPATH?
Yeah.
So it's a very good question. When the neck is okay, head is, see what happens in AVN is the head is completely collapsed, and many a times even the neck and anatomy is destroyed. So when the anatomy is destroyed, number one. Second thing, the patient is totally stiff. We cannot do the SuperPATH. So patient has to have some jog of movement. See, the structures that I'm saving have to be there in place. So soft tissue, if the movement is okay, reasonable, and when we examine the patient, even in your clinic, the spine is not moving with the hip, it's not fixed, then we can do. So around 80% of the patients we have to do the SuperPATH, we can do the SuperPATH. Secondly, when it is a lot of limb length discrepancy, if the patient is having more than 2 inches of shortening, SuperPATH is not possible. We go for the regular THR, that is always an option. But almost every case now we are doing with the SuperPATH. Range of movement is one requirement where the patient has to understand that before getting completely stiff and the spine stiffness, we cannot do the SuperPATH.
And what is the difference between conventional and SuperPATH about quotation?
Cost?
Costing.
Nothing.
Okay.
It's just center of the bat se marna hai ya खींच के marna hai, that's it. Nothing, no cost difference. It's a technique which I feel has evolved in the US for a long time now, and it was developed in 2011, and it is taking the furor because as you see, sir, everybody is moving to conserving in the angioplasty, is conserving the tissues, respecting the nature. So we really don't know which nerve, which artery, which small tissue can really prevent dislocations and give the patient all the range of movement, because those muscles are been trained for life. Like आता शेतकरी आहे, त्याला त्यांनी ट्रेन केलं आहे, कोणी डान्सर आहे त्यांनी ट्रेन केलं आहे. आम्ही शाहरुख खानच्या लॉयरला ऑपरेट केलं आहे, तो मिस्टर इंडिया आहे 3 वेळा, त्याला वर्कआउट करायचं. त्या मसल्स आपण जर सेव्ह केले, ही कॅन गो बॅक टू हिज ॲक्टिव्हिटीज फॉर लाईफ. सो SuperPATH इज नथिंग बट टू सेव्ह ईच अँड एव्हरी स्ट्रक्चर दॅट आय कॅन सेव्ह ॲज अ सर्जन.
And in case of revisions,
definitely we cannot do, because already sir the incision असतं. And in revisions we have to open more, because even taking out the implant is a big thing. So this is primary. Young patient, we don't worry much in 70 plus patients for the SuperPATH, because already the ligaments are very tight. But in young, this is for why this is developed is the COVID. Sir, 40 lakh people in India are suffering. 6 crore in the world. We don't know. These are reported. We really don't know from northeast. I'm getting patients from Bihar, Darbhanga, that kind of places where literally they are not knowing because they are afraid of hip replacements. People tell them that hip replacement, you आप नीचे नहीं बैठ पाओगे, आप कुछ नहीं कर पाओगे. That kind of patients, the patients who want to do religious activities, namaz. So that kind of patients, I'm literally getting patients from Jamaica and Oman and that kind, because for them religious activities, one patient we did, she was thrown away from the house. As ladies, you understand, कि वो नमाज नहीं पढ़ रही थी तो people, that fellow divorced her. So this is not a reason. So you at least help her and now she is back to her life. So why I have saved a soft tissue? So joint replacement is a soft tissue surgery. We have to respect it. Implant, everything is 20%. That 80% we should be talking about, and that's where the focus is.
Okay, thank you.
Thank you.
Sir, kindly conclude the session.
Thank you, sir, for very informative lecture.
Thank you.
And thanks.
Thank you.
Now, may I request Dr. Rohan Hegde, sir, what is our, to felicitate Dr. Arbert, sir.
Nice.
Now, may I request Dr. Rushikesh to felicitate our chairpersons.
After the very advanced SuperPATH technique in robotic or hip replacement, now we'll move to a very tiny organ, that is the eye. So it's a oration. It's Dr. Padma Shri Dr. Manohar Dole oration, and for this oration I request Dr. Raghavendra Borgaonkar to come on the dais. Padma Shri Dr. Manohar Dole was a Ayurvedic graduate from Pune. He practiced Ayurveda for 5 to 6 years, but on insistence of his teacher, he moved to the rural and Adivasi area to serve that poorly health related area to the Narayangao. After practicing for few years, after the sad demise of his closest friend, Mr. Mohan Thuse, he started an ophthalmic unit in Narayangao, and since 1965 more than 1.30 lakh cataract surgeries have been done in Narayangao free of the cost, and that's why he was awarded the third highest civilian award, that is the Padma Shri, and at the age of 95 he succumbed to the death last 2 years. To give the lecture we are Dr. Raghavendra Borgaonkar, who has done his MBBS from Dr. D.Y. Patil Medical College, Kolhapur. Then he has done his postgraduate DNB from prestigious Arvind Eye Care Institute from Madurai. He has a fellowship in cornea and anterior segment from Arvind Eye Hospital, Coimbatore. Lesser in diabetic retinopathy, he has done short-term fellowship from Arvind Eye Hospital. Also a short-term fellowship in LASIK from the Center for Sight with Dr. Rupal Shah. He was consultant in Inlex and Budrani Hospital, Pune from 2016 to 2020. Now he is attached to Dr. Dole Hospital in Narayangao, and also he is running his own OPD in Wagholi, Pune. Over to Dr. Borgaonkar.
Good afternoon, everybody. Today I am going to talk about LASIK surgery. Okay. So LASIK surgery is basically to get freedom from glasses. So coming to the what are the disadvantages of glasses? Just basically, first disadvantage is discomfort. Glasses can cause discomfort due to incorrect fitting, leading to headache or pressure on your nose or ears. The fogging, it can cause fogging in the rain, a dusty or dirty environment. The cosmetic appearance is not usually good, especially due to very high powered glasses, causing heavy weight. And also there is always a risk of loss or damage of the glasses, which can be replaced, which need to be replaced frequently. The weight of the glasses can be very heavy when there is a very high power and it slides down on your face. Again, the glasses can be very, if they are very heavy weight, then due to very high power, it slides down on your face. And basically, if it is initially, it causes very high eye strain due to if you are using new glasses. It causes distorted images in case of very high astigmatism. Again, adjusting is a very big problem initially in the initial usage of glasses if the prescription is very new. And the peripheral vision is always distorted due to frames. It can distort your peripheral vision, which is especially needed in outdoor sports, professional reasons, Army, Navy, Air Force, driving, and outfield work. So basically, what is meant by refractive error? It is a condition when it is a type of it is a condition when the image of the object is not falling exactly on the retina. Sorry. What is meant by refractive error? It is a condition when the image of the object is not falling exactly on the retina. If it is falling in front of the retina, it is called as a myopia. If it is called falling behind the retina, it is hyperopia or hypermetropia. So myopia when the length of the eyeball is long, or hypermetropia when the length of the eyeball is short. So if we use concave lenses to keep in front of the eye to get the image exactly on the retina. So what does LASIK laser do? It corrects the minus power on the central portion of cornea to make it flat centrally. In case of hypermetropia, LASIK laser corrects mid-peripheral portion of the cornea to make it steep centrally. Astigmatism is a type of refractive error according to the shape or curvature of cornea. Hence correction, LASIK laser correction is done on the same curvature of cornea. So what is meant by presbyopia? Is a type of refractive error due to changes in the accommodative power of natural crystalline lens, usually comes after 40 years of the age. In case of presbyopia, we cannot do LASIK surgery. So what is meant by exactly LASIK? LASIK stands for laser assisted in situ keratomiliasis. It is a type of laser assisted surgery that corrects the refractive error of the eye completely by changing the shape of cornea, that is clear covering front of the eye, by using excimer laser. It is a type of laser. So basically LASIK is the advanced and commonly performed laser vision correction surgery available today. It has a very high success rate of 95 to 98%. The most successful surgery amongst medicine branch. It is performed on the clear covering of outer central portion of the eye called as a cornea. So this we can see the laser is done over the cornea. We can see In one diagram we can see the flap is created, and another diagram it is a type of epilastic surgery. If we cannot cannot prepare the flap, we remove the epithelium, superficial epithelium, and do the LASIK surgery. So what are the eligibility criteria for patient selection? The most important eligibility criteria is age of the patient, that is above 18 years and below 35 years. Refraction should be stable from 6 months to 1 year. So we can correct refractive error of myopia from -1 to -8 diopter depending on the thickness of cornea for high power. So hypermetropia we can correct up to +1 to +6 diopter, astigmatism up to 3.5 diopter, and corneal curvature from 39 to 47 diopter can be corrected. Of course, posterior segment should be within normal limits. So coming to the pre-LASIK evaluation, which is very important. So 80% of the success rate of LASIK surgery depends on pre-LASIK evaluation. So when the patient comes to OPD, we should do detailed basic refraction along with cycloplegic drugs. Dry eye evaluation should be done thoroughly. The topography of the patient, of cornea of patient should be done to detect corneal ectasia or corneal thickness. So topography is basically most important investigation for pre-LASIK evaluation. It is an investigation of cornea to detect exactly in detail curvature and thickness of cornea. So thorough slit lamp biomicroscopic examination of the patient should be done. Posterior segment evaluation is done to detect any treatable retinal lesions, and also optic nerve disorder should be evaluated. So this is the corneal topography investigation, four color quadrant map. The first map stands for corneal curvature, anterior segment, anterior curvature, posterior curvature, and corneal thickness. So we can detect keratoconus on this topography. So keratoconus is again a contraindication for LASIK surgery. So basically, keratoconus is the conical condition of cornea. It is an abnormal curvature of cornea. When we do the LASIK surgery, the curvature of cornea goes on increases and the power also increases. So this is the contraindication we can detect on corneal topography. So this is Shearer's topography machine Shearer's topography machine to know the curvature and thickness of cornea. It's a 4-quadrant curvature map showing all detailed values in the below diagram, and it shows maximum keratometry value, minimum keratometry value, thickness, central thickness and peripheral thickness. Central 3 mm of the thickness is the most important value. So we can see in short surgical steps of LASIK surgery. First we'll see the video. So the marking is done on the cornea on temporal side, which helps to identify the flap side if the flap gets dislodged. This is a microkeratom blade for preparation of the flap. You can see within 2 seconds the flap is created, and the vacuum is released. The flap is created and it is raised, which is attached at a particular site called as a hinge. Now the stroma bed is dried and laser is bombarded for approximately 2 to 10 seconds. It depends, the duration of laser depends on power of eye. Now the laser is done and flap is reposited. It is thoroughly washed. Underneath surface of the flap is thoroughly washed with balanced salt solution. Now the flap is opposed. It takes around 1 minute to oppose the flap. So these are the steps what we have seen in video. The preparation of LASIK machine, gas air exchange, then fluence test, basically to judge the lens delivery system, then patient data entry, which is very important about the birth death, topical anesthesia with eye drops, then flap making, same steps what I have explained. It usually takes 2 to 5 minutes for one night to complete. So after completion of the laser, we put antibiotic eye drops. So this is a diagrammatic presentation. We put anesthetic eye drops, then flap is created. Again flap is reposited. So what I have explained is a basic standard LASIK surgery where flap is created, and it is most commonly performed till date. But apart from that, there are different type of LASIK surgeries like standard LASIK surgery or customized LASIK surgery. So what is meant by standard LASIK surgery? It corrects only eye power. So beyond that, there is a term called as a corneal aberrations. So still that gives problem to the patient after LASIK surgery. It's called as a glare. So the glare is because of corneal aberrations or minute elevations and depressions, micro elevations and depression present over the surface of cornea, which can be detected with the help of topography, and so that can be corrected with the help of customized LASIK, which is again advanced technique after a standard LASIK surgery. So after this standard LASIK and customized LASIK with the help of flap creation, there is one more technique has come called as a femto-LASIK. So femto-LASIK, where flap is taken with the help of laser. What we have seen in the video is a microkeratom blade. With the help of microkeratom blade, the flap is created. But in femto-LASIK, the blade is not used. A special laser is used to create the flap. So hence it is called as a bladeless LASIK surgery. So after femto-LASIK surgery, there is an advancement in the surgery that is called as smile. So what is meant by smile is a small incision lenticle extraction. So here the incision is only 1.8 to 2 millimeter. Through that, with the help of laser, the lenticle is created, and that lenticle is extracted through that 2 millimeter incision. Hence the patient can resume the duty after 2 to 3 days. Here the lenticle is convex on one side and flat on the other side. But the main disadvantage of smile surgery is the high cost, which is almost double the cost of customized LASIK surgery for patient. Now the latest LASIK surgery now is silk. So what is meant by silk? Is smooth incision, smooth incision lenticule keratomiliasis. So it is again same like smile surgery, but the lenticule, the shape of the lenticule is biconvex on both sides, which is similar to the natural crystalline lens. So after LASIK surgery, we should take some post-operative precautions, because we in standard LASIK what we have seen is a flap is created and flap is reposited, and normally it takes 2 to 3 days to oppose the flap. So approximately 72 hours are very important after LASIK surgery. So we have to instruct to the patient not to rub the eyes for at least for 3 days. The topical antibiotic eye drops and low dose steroids are used. Medications are used for 2 weeks along with tear substitutes. The patient can resume the duty after 1 week here in standard LASIK surgery. And what we have seen in smile and silk surgery, the patient can resume the duty after 2 days. So that is the biggest advantage of the recent technology, but the disadvantage is high cost. Again, we usually instruct the patient avoid heavy weight lifting or gym exercise outdoor sports like football, swimming for 1 month. And we should follow up the patient for 1 week, 1 month, 3 months, 6 months, 1 year. Then once in a year to observe for the post-LASIK regression of power. So what is meant by post-LASIK regression and ectasia? Post-LASIK regression is the reversion of refractive power after LASIK surgery after 1 year to 10 years. So we explain to the patient that we are not worried about the reversion of LASIK, reversion of power, but we are worried about flap. So why it is because of re-LASIK surgery possible for such patients depending on the topographic value. And it has a similar success rate as compared to the first LASIK surgery. The last is the post-LASIK ectasia. So post-LASIK ectasia is basically changes in the shape or curvature of cornea with steepening and ectasia. So early detection and treatment with corneal collagen cross-linking is needed to stop further progression. So we can avoid post-LASIK ectasia complication by thoroughly investigating patient with the help of corneal topography in the pre-LASIK workup itself. And also post-operatively we have to follow the patient up to 1 year or 2 years to detect early post-LASIK ectasia, and we can treat the patient with corneal collagen cross-linking to stop further progression. So coming to the last slide. So who should not go for LASIK surgery? As I have explained, corneal topography investigation, in that the thickness of cornea less than 450 micrometer, patients having this less thickness should not undergo for LASIK surgery. And changes in the refractive error for more than 0.5 diopter in the last 6 months. And age less than 18 years and more than 40 years patients should not undergo for LASIK surgery. But nowadays we are doing LASIK surgery even after 35 years depending on the power of eye. If the patient is having very high power like 6 or 8 diopter, we can do LASIK surgery, and by explaining to the patient of condition of presbyopia, if the patient is concerned about profession. And also the moderate or severe dry eye patients should not undergo for LASIK surgery because of healing problem. And pregnancy and lactating mother should not undergo. Then oral hormonal treatment, patients on oral hormonal treatment. Then keratoconus patients also should not undergo LASIK surgery. Then very flat or steep cornea, like less than 38 diopter curvature or more than 47 diopter curvature should not undergo LASIK surgery. Ocular surface disorder or limbal stem cell deficiency patients should not undergo LASIK surgery. And posterior segment pathology or patients having optic nerve disorders or significant glaucoma or significant family history of glaucoma, then macular pathology should not undergo LASIK surgery because of poor visual prognosis. Or if the posterior segment pathology is progressive, then again it is contraindicated. Thank you. I would like to show the video of Padma Shri Dr. Manohar Dole Foundation. नहीं फोटो है ना हाँ एक मिनट हाँ नहीं हाँ वीडियो नहीं एक मिनट पहले ये देखो पहले एक मिनट The video is showing Padma Shri award ceremony. It has been awarded to Dr. Manohar Dole sir. So again, one more video I would like to show, documentary film. आवाज नहीं आ रहा है. हाँ.
जीवनाचा आधार असलेल्या या डोळ्यांना काही इजा झाली तर कळत न कळत डोळ्याला झालेल्या इजेपासून आहारातल्या त्रुटी समान तरीही प्रथम नाम दृष्टी प्रकाश देव अंध जीवनी आनंद विरह दुःख वेदना अशा अशा सगळ्याच भावना व्यक्त करण्याचं प्रभावी माध्यम म्हणजे डोळे. जीवनाचा आधार असलेल्या या डोळ्यांना काही इजा झाली तर कळत न कळत डोळ्याला झालेल्या इजेपासनं आहारातल्या त्रुटी आणि कुपोषणापर्यंत अनेक कारणांमुळे डोळे खराब होतात. अतिशय कडक उन्हात तासनतास थांबणं, तसंच कॉम्प्युटरचा सतत वापर यामुळेही डोळे थकतात आणि ताण अगदीच असह्य झाला की बंड करतात. शहरी भागापेक्षा ग्रामीण भागात तर डोळ्यांच्या समस्या फारच गंभीर असतात. एकतर अज्ञान असतं, उपचार करून घ्यायची इच्छा असली तरी त्यासाठी पैसे नसतात. त्यामुळे ग्रामीण भागातले रुग्ण पेशंटचं मोहन ठुसे नेत्र रुग्णालय आणि संशोधन संस्था सामाजिक जाणीवेतनं गेल्या 28 वर्षांपासून काम करते. आज या नेत्र रुग्णालयाचं जे भव्य दिव्य स्वरूप दिसतंय ते डॉक्टर मनोहर डोळे आणि त्यांच्या सहकार्यांच्या तपस्येचं मूर्तिमंत उदाहरण आहे. पुण्यातले प्रख्यात वकील बाबासाहेब भिडे यांच्या प्रेरणेनं ग्रामीण भागातल्या रुग्णांची सेवा करण्याचं व्रत घेऊन डॉक्टर डोळे 1959 साली नारायण गावात दाखल झाले. त्यावेळी त्यांच्याकडे होतं फक्त वैद्यकीय ज्ञान आणि समाजाबद्दलची तळमळ, आपुलकी. या अनोळखी गावातले त्यांचे जुने स्नेही मोहन ठुसे यांच्या घराचा त्यांना आधार मिळाला आणि मग डॉक्टर डोळे यांनी सायकलवरून फिरून आजूबाजूच्या गावांमध्ये प्रॅक्टिस सुरू केली.
माझे एक सहकारी जे डोळ्याचे डॉक्टर ज्यांनी मिलिटरीमध्ये काम केलं, त्यांच्याबरोबर काही दिवस मी काम केलं आणि माझ्या मनातली जी काही कल्पना होती त्याला प्रोत्साहन मिळालं. दुसरी गोष्ट, मी इथे आल्यानंतर निरनिराळ्या ठिकाणी हिंडत असताना मी जिथे जात असे तिथे एक दृश्य नेहमी मला दिसायचं की एक म्हातारी कोणीतरी कोपऱ्यात, ज्या ठिकाणी घाण आहे, गाय आहे, म्हैस आहे, पटकुरावर तो बसलेला आणि ओरडतो, अरे मला कोणीतरी पाणी द्या. त्याचं कारण असं की त्याची दृष्टी केलेली, त्यामुळे त्याच्या घरातला मान गेलेला आहे. प्रोडक्टिव्हिटी
He is explaining about the
परावलंबी झालेला आहे.
preventable blindness, that is cataract,
माणसांसाठी काहीतरी केलं
which was
पाहिजे.
present in the rural
या
area.
विचारातनंच त्यांनी नेत्र रुग्णालय सुरू करायचा विचार पक्का केला आणि 26 डिसेंबर 1982 या दिवशी त्याची सुरुवात केली. ठुसे कुटुंबियांच्या गावातच असलेल्या 200 वर्ष जुन्या वाड्यात या नेत्र रुग्णालयाचा नारळ वाढवण्यात आला. कोणतंही आर्थिक पाठबळ नसताना सुरू केलेल्या या रुग्णालयाच्या कामात पुण्यात दुसरीकडे मोहन ठुसेंसारखा पाठीराखा जग सोडून गेला होता. त्यांची आठवण जपण्यासाठी या रुग्णालयाचं नाव मोहन ठुसे नेत्र रुग्णालय असं ठेवण्यात आलं. समाजसेवेचं व्रत म्हणून डॉक्टर डोळे यांनी स्थापन केलेल्या या रुग्णालयात काम परिपूर्ण सेवा देण्यासाठी डॉक्टर आणि डोळ्यांच्या विविध आजारातले 8 विशेषज्ञ इथे सेवामग्न आहेत. त्यांच्या ज्ञानाच्या जोडीला आहेत अत्याधुनिक साधन सुविधा, यंत्र या रुग्णालयात आहेत. त्यासाठी दानाबाबत आणखी लोकजागृती करण्यासाठी आणि नेत्रदानाची सोय उपलब्ध करून देण्यासाठी रुग्णालयामार्फत माधव नेत्रपेढी चालवण्यात येते. नेत्रपेढी बरोबरच या रुग्णालयात रक्त साठवून ठेवायची देखील सोय करण्यात आली. नारायणगावच्या परिसरात कोणत्याही वेळी रक्ताची गरज भासली तर रुग्णालयातलं हे केंद्र त्यासाठी इंटरनॅशनल रोटरी क्लबचं सहकार्य मिळालंय. पुणे जिल्ह्यातले जुन्नर, आंबेगाव, खेड आणि शिरूर, अहमदनगर जिल्ह्यातले पारनेर, संगमनेर आणि अकोले, तसंच ठाण्यात नसेल तर आरोग्य सेवा त्याच्यापर्यंत पोहोचवण्याचा निर्धार रुग्णालयाने केला. गावागावात वाड्या वस्त्यांवर जाऊन डोळ्यांच्या आजारांबद्दल जागरूकता निर्माण करण्याबरोबरच तपासणी आणि उपचाराचं काम या फिरत्या दवाखान्याच्या माध्यमातून केलं जातं. एवढ्यावरच न थांबता रुग्णालयातर्फे वारंवार तपासणी शिबिरं भरवली जातात. मोतीबिंदू, काचबिंदू असे रोग झालेल्या मध्यमवयीन व्यक्तींची लक्षात आल्यानंतर त्यांच्या डोळ्यांचं ऑपरेशन करण्यासाठी त्यांना नारायणगावच्या रुग्णालयात दाखल करून घ्यावं लागतं. ऑपरेशन पूर्वी त्याच्या आवश्यक त्या सगळ्या तपासण्या केल्या जातात आणि आवश्यक तयारीनंतर ऑपरेशन केलं जातं. अत्याधुनिक साधन सुविधांनी सुसज्ज ऑपरेशन थिएटर्स आणि अनुभवी डॉक्टर्स यामुळे जेवणाची मोफत व्यवस्था करण्यात येते. ऑपरेशन नंतर आवश्यक असलेल्या विश्रांतीनंतर रुग्णाला पुन्हा घरी नेऊन सोडणं, डोळ्याला काळा चष्मा देणं आणि औषधं पुरवणं अशी सगळी सेवा रुग्णालयातर्फे मोफत केली जाते. गेल्या 28 वर्षांमध्ये रुग्णालयाने सुमारे 5,500 नेत्र शिबिरं आयोजित यशस्वी ऑपरेशन्स केली आणि ती सुद्धा मोफत. यशस्वी ऑपरेशन्स केली आणि ती सुद्धा मोफत. नारायण गावाबरोबरच पाबळ इथे कायमस्वरूपी उपचार केंद्र सुरू करण्यात आलं आहे, ज्याला नेत्र शिबिरापेक्षा स्वतंत्रपणे तपासणी आणि उपचार करून घ्यायची इच्छा असते. त्यांनाही खात्रीशीर आणि वाजवी दरात सेवा द्यायचं काम जागतिक दर्जाच्या अत्याधुनिक साधन सुविधांनी सुसज्ज अशा या अथर्व नेत्रालयात डोळ्यांच्या आजाराबाबतचे उपचार केले जातात. इथली काही वैद्यकीय उपकरणं तर इतकी नवीन आणि आधुनिक आहेत की ती फक्त मुंबईतल्या या उपकरणांमुळे माधव नेत्रपेढी अशा संस्थांच्या माध्यमातून भविष्यातील आव्हानं पेलण्याची तयारी केली आहे. पदव्युत्तर शिक्षणासाठीचं प्रशिक्षण केंद्र आणि होमिओपॅथिक नेत्र विभाग हा त्यापैकीच एक. ह्यात संशोधनासाठी स्वतंत्र संस्थेच्या स्थापनेचं काम आता अंतिम टप्प्यात आलं आहे. डॉक्टर मनोहर डोळे यांनी लावलेल्या एका लहानशा रोपट्याचं आता वटवृक्षात रूपांतर झालंय. त्यांचे दोन्ही चिरंजीव डॉक्टर संजीव
Nagre sir to felicitate Dr. Raghavendra. Now the next session is of Dr. Chirag Hora from Pulmonology. I request Dr. Sudhir Tambile and Dr. Rohan Hegde to chair the session. Dr. Chirag will talk on A to Z of the lungs from pulmonology, and to chair the session we have Dr. Rohan Hegde and Dr. Sudhir Tambile, who is our organizing secretary and secretary of our IMA Indapur. Over to Dr. Rohan.
Thank you sir. So it's a pleasure to introduce my dear friend Dr. Chirag Hora, who is a young top gun pulmonologist coming up in our area. So he's based in Akhileshwar, running his own dedicated pulmonology center, Chest Hospital. Apart from that, he is also a regular visiting Natepute ICU. Dr. Chirag has done his MBBS from DY Patil, Kolhapur, and then he completed his DNB pulmonology from Ruby Hall Clinic, and then he has gone on to done interventional pulmonology fellowship from Kavishwar Hospital, Pune. So without any further ado, I would like to hand over the session to Dr. Chirag.
गुड आफ्टरनून एव्हरीवन. काय दुपार आहे, जेवण भरपूर झालेलं आहे, गार हवा आहे, तर होप माझ्या लेक्चरला झोप येणार नाही जास्त करून, मी त्याची काळजी घेईल. तर माझं नाव डॉक्टर चिराग होरा, मी चेस्ट फिजिशियन आहे. डे टू डे लाईफमध्ये अस्थमा, COPD, TB क्लिनिक बरोबर माझा जास्त इंटरेस्ट राहतो इंटरव्हेन्शन पल्मोनॉलॉजीला. तर माझे मेंटॉर डॉक्टर खोजा सर होते ड्युरिंग माय PG, आणि त्यांच्याकडून इन्स्पायर झालो फॉर इंटरवेन्शन्स अँड ऑल दिस थिंग्स. देन आय डीड माय फेलोशिप कोर्स फ्रॉम दीनानाथ मंगेशकर हॉस्पिटल, आणि त्याच्यानंतर आत्ता आम्ही PPP बेसिसवर कमला नेहरूमध्ये चेस्ट डिपार्टमेंट आउटसोर्स केलेलं आहे, आणि तिथे ॲस्पायरंट जे अपकमिंग PGs आहेत त्यांच्यासाठी आम्ही फेलोशिप प्रोग्रॅम रन करतो आहे. तर आजचा माझा टॉपिक आहे की थोरॅसिक वॉर, द सिरीज ऑफ ब्लॅकआउट. तर आपली जी OPD किंवा इमर्जन्सी असते ती एक प्रकारचा एक वॉर फ्रंटच असतो असं मला नेहमी वाटतं, कारण का वेगवेगळ्या वेळेस वेगवेगळे अटॅक्स आणि वेगवेगळ्या पद्धतीचे पेशंट आपल्याकडे येत असतात. तर अशाच 2 केसेसबद्दल मी बोलू इच्छितो. तर 2 पेशंट आहेत, यंग 18 एक 16 year old मेल, एक 18 year old मेल. आणि आमच्याकडे येणारे पेशंट म्हणजे एकच की बाबा कफ, ब्रिथलेसनेस, चेस्ट पेन ह्याच कंप्लेंटनी येतात. तर पहिला पेशंट आला होता ॲक्यूट ऑनसेट ऑफ चेस्ट पेन, ब्रिथलेसनेस होतं, MMRC 2-3 वी कॅन से, प्रोडक्टिव्ह कफ अँड फीवर, हाय ग्रेड फीवर होता. वायटली जर बघायला गेलं तर टॅकिपनिया होता, सॅच्युरेशन नियर अराउंड 90%, दॅट टू ऑन वेंच्युरी मास्क, कारण का मी जास्तपर्यंत वेंच्युरी मास्क वगैरे घेतले होतं. काउंट्स त्याचे WBC नियर अराउंड 16,400 होते. LFT RFT नॉर्मल, स्पुटम आउटसाईड केला होता, स्पुटममध्ये GPCs विथ ZN निगेटिव्ह असं समवॉट पिक्चर त्याचं होतं. आणि दुसरा जो पेशंट होता तो सेम नियर अराउंड 18 year old मेल, आउटसाईड हॉस्पिटलला ॲडमिशन झालं होतं फॉर टेन्शन निमोथोरॅक्स. तिथं ICD केली होती, ICD नंतर त्याचं ॲडमिशन होतं, ॲडमिशननंतर तो डिस्चार्ज झाला ICD रिमूव्ह करून, आणि माझ्या कॅज्युअल्टीला अगेन विथ कंप्लेंट ऑफ ऑनसेट ऑफ ब्रिथलेसनेस, चेस्ट पेन विथ नो हिस्ट्री ऑफ कफ ऑर फीवर ॲट ऑल. त्याचाही वाईटली जर तुम्ही बघितलं तर 86% नियर अराउंड रूम एअरवर तो मेंटेन होता, WBC क्वाईट स्टेबल विथ LFT RFT नॉर्मल. मग आमच्याकडे येतात, आलेले असतात, पहिले GPंकडे लँडअप झालेले असतात, तिथून फिजिशियनकडून आमच्याकडे जेव्हा येतात तोपर्यंत त्यांचं ऑलमोस्ट सगळं वर्कअप झालेलं असतं, म्हणजे एक्सरे झालेले असतात, CBC बाकीच्या स्पुटमपर्यंत झालेले असतात. मग जेव्हा माझ्याकडं आलं मला थोडंसं गोष्टी वेगळ्या वाटल्या, ऑस्कल्टेशनला असू दे, TVF TVR असू दे, थोड्याशा गोष्टी वेगळ्या वाटल्या. CT ॲडवाईस झाला. CT मी रिक्वेस्ट करील की आपल्यात आत्ता रेडिओलॉजिस्ट असतील तर ते ग्रास्प करतील, पण माझी रिक्वेस्ट आहे की आत्ता हा CT बघून घ्या, ह्याच्यावर आपण परत भाष्य करणार आहोत. तर काय दिसतंय इनिशियल इम्प्रेशन जर तुम्ही बघितलं हे वालं किंवा हे वालं, तर इनिशियली हे कोणीही पाहिलं तर बोलणार की इट्स काइंड ऑफ निमोथोरॅक्स. सो आमचंही तसंच झालं, दो वी आर अ पल्मोनॉलॉजिस्ट, फर्स्ट इम्प्रेशन्स वॉज निमोथोरॅक्स. सो व्हॉट वी डीड की आम्ही ICD केला. ICD केलं फर्स्ट पेशंटला. ICD केल्यानंतर द मेन प्रॉब्लेम वॉज की BPF. ICD केले, 2 दिवस झाले, 3 दिवस झाले, पण इन्स्पिरेशन आणि एक्सपिरेशनच्या वेळेस जे कॉलम मुवमेंट होते त्या कॉलम मुवमेंटला बबल्स येत होते, म्हणजे कुठंतरी प्लुरल लीक होतं. मग त्यासाठी पहिल्यांदा काय करूया बाबा, तर ब्रॉन्कोस्कोप टाकला. ब्रॉन्कोस्कोप टाकून ज्या सेगमेंटमधून लीक होतं आहे ते सेगमेंट आयडेंटिफाय केलं, तिथं ग्ल्यू इन्स्टिलेशन केलं ब्रॉन्कोस्कोपिक. ग्ल्यू इन्स्टिलेशन केल्यानंतर वाटलं की बाबा ICDमध्ये जे लीक आहे ते बऱ्यापैकी कमी झालेलं आहे, तर आपण आता ICD रिमूव्ह करू शकतो. झालं काय, तर दिस वॉज द सिनारिओ. मे बी माझ्या ह्याच्यामुळे येत नाही आहे ते. आता दिसेल येस. सो दिस वॉज द सिनारिओ. आफ्टर ग्ल्यू इन्स्टिलेशन सगळं करून सुद्धा पुन्हा हे एक ग्लोरियस डिफीट बोलता येईल की ऑफकोर्स वी आर अ ह्युमन, अपयश येतच असतं आहे, त्यातूनच शिकत असतो. तर ग्ल्यू करून सगळं करून सुद्धा एअर फ्लुइड लेवल राहिली. अँड बॅटल टू त्याला ICD केली, ICD रिमूव्ह केली, तो स्टेबल होता, ओके. पण पहिलावाला तर तसाच ॲडमिट होता, दुसरावाला तिसऱ्यांदा माझ्या कॅज्युअल्टीला आला की सर परत मला त्रास व्हायला सुरुवात झाली, मी ब्रिथलेस आहे, चेस्ट पेन आहे, सगळ्या गोष्टी, परत त्याच गोष्टी, परत ICD. मग आता ठरवलं की बाबा काहीतरी वेगळं होतं आहे, अंडरविजन ह्या गोष्टी जाऊन बघायलाच पाहिजेत. तर मग आम्ही आता डिकॉर्टिकेशन, बुल्लेक्टॉमी या गोष्टी अकलूजमध्ये देखील करतो आहे. जेव्हा अंडरविजन लॅप्रोस्कोपिक आम्ही 2 पोर्ट एक पोर्टनी कॅमेरा, एक वर्किंग पोर्ट टाकला 10 mm आणि त्याच्यातून जेव्हा या गोष्टी बघायला गेलो, यू कॅन सी द थिंग्स की किती थिक सेप्टेशन्स आहेत. बाकी चेस्ट वॉल क्लिअर आहे, हिअर यू कॅन सी द थिंग्स की इतकं ते लॉंग स्टँडिंग अँड रिपीटिंग होतं की जो स्लफ तयार होतो आहे लिटरली ते आम्हाला लॅप्रोस्कोप इन्स्ट्रुमेंटनी पण निघत नव्हतं, आम्हाला स्पंज होल्डिंग फोर्सेप टाकून ते पुल आउट करून घ्यावं लागत होतं. ह्या लेवलला ते थिक अशा प्रकारचं डब्रिज तयार होतं आहे. तर व्हॉट वी कॅन कॉल इट ॲज अ आयसोलेशन, की बाबा आम्ही आयसोलेट केलं आहे त्या गोष्टी, जो स्लफ आहे ते आयसोलेट केलं आहे. इनिशियली आयसोलेशन जेव्हा करून होतं त्याच्यानंतर आपण काय करतो, सेपरेट करायला लागतो. लंग टिश्यू अँड चेस्ट वॉल यांच्यामध्ये जे प्लुरल ॲडेजन्स तयार झालेत ते आपण हळूहळू विदाउट ट्रॉमॅटायझिंग द लंग टिश्यू ऑर इंटरकॉस्टल वेन्स, इंटरकॉस्टल आर्टरीज आपण ते काय करतो की सेपरेट करायला लागतो. तर व्हॉट वी आर डुईंग नाव इज वी आर सेपरेटिंग. आणि त्याच्यानंतर गोष्ट येते की जे थोडंफार काही राहिलेलं आहे, जसं आपण पील करतो, संत्री मोसंबी पील करतो टिश्यू डॅमेज न करता, तसं जे काही थोडंफार लंग टिश्यूवर राहिलेलं आहे ते हळूहळू आपण पील करून ह्या गोष्टी करतो. आता हे जे इफ्युजन होतं ते कुठं होतं, विसरल प्ल्युरा आणि परायटल प्ल्युराच्या मध्ये, बरोबर आहे. चान्सेस आहेत का, तर डेफिनेटली आहेत की रिकरन्स होऊ शकतं. मग त्यासाठी आपण काय करतो, प्ल्युरोडिसिस. प्ल्युरोडिसिस इज नथिंग बट अ कॉझिंग अ इन्फ्लामेशन विच विल रिझल्ट इन अ फायब्रोसिस, बरोबर आहे. त्याच्याने त्या 2 प्ल्युरा चिपकून जातील आणि परत त्याला मध्ये फ्लूइड भरायला जागाच राहणार नाही. तर जेव्हा असं हे आमचं पिलिंग ऑफ होतं त्यानंतर आपण काय करतो की विथ द हेल्प ऑफ पीनट, स्टराईल पीनट, वी डू अ मेकॅनिकल प्ल्युरोडिसिस. मेकॅनिकल प्ल्युरोडिसिस म्हणजे काय की आपण चेस्ट वॉल आणि लंग जेंटली रब करतो जेणेकरून थोडासा ट्रॉमा होईल आणि तो ट्रॉमा जेव्हा हील होणार त्या फायब्रोसिसमध्ये ते प्लुरा चिटकून जातील. किंवा त्याच्यानंतर अजून एक आपण करतो की टाल्क प्ल्युरोडिसिस. टाल्क काय करतं, टाल्क इज अ आउटसाईड मटेरियल, ओके. तर कोणतंही आउटसाईड मटेरियल जेव्हा तुमच्या बॉडीमध्ये जातं इट क्रिएट अन ॲलर्जिक असल्यासारखं ते पार्ट बिहेव करतं आणि त्याच्यामुळे पुन्हा तेच इन्फ्लामेशन क्रिएट होऊन तुमचे प्ल्युरा चिटकून जातो. हे आपण पिलिंग ऑफ केलेलं आहे व्यवस्थित, मला दाखवायला आवडेल. हे मेकॅनिकल प्ल्युरोडिसिस जे आपण म्हणतो विथ द हेल्प ऑफ पीनट, जेंटली आपण जिथे जिथे वाटतंय ते जेंटल ट्रॉमा होईल ह्या पद्धतीने ते रब करतो की जेणेकरून इन्फ्लामेशन होईल. प्रोव्हाइडेड दॅट की म्हणजे मी पण खूप बोलणी खाल्ली होती, मला रेसिडेन्सीमधून बाहेर फेकून दिलं होतं आमच्या गुरुजींनी की बाबा तू डिकॉर्टिकेशन मी केलं आहे आणि त्याच्यानंतर पेशंटला पेन होतं आहे म्हणून स्टिरॉइड किंवा दुसऱ्या गोष्टी का देतो जे अँटी इन्फ्लामेटरी आहेत. जर तो अँटी इन्फ्लामेटरी दिला तर आपण ह्या ज्या गोष्टी करतो याचा फायदा होईल का. तर याच्यानंतर ॲडवाईस राहतो रेसिडेंट्सला पण आणि डे टू डे प्रॅक्टिसमध्ये आपण पण खबरदारी घ्यायची असते की वी आर युजिंग NSAIDs इन दिस केस. ICD प्लेस केला अँड देन वी जस्ट केम आउट. ऑल दिस प्रोसिजर वी टूक, म्हणजे किडनी ब्रिज पोझिशन देतो, 1 लंग व्हेंटिलेशन देतो, डबल ल्युमेन ट्यूब टाकून 1 लंग ऑफकोर्स डाऊन असतं आणि त्याच्यानंतर ही प्रोसिजर कॅरी केली गेली. दिस वॉज द लंग ऑफ सेकंड पेशंट की ज्याच्यात वारंवार रिकरंट निमोथोरॅक्स होत होता. तर बाबा का होतो आहे कारण आत गेलो, आत तर कंप्लीट कुठंच काही ॲडेजन्स नाहीत, काही नाही. मग ते लहानपणी सायकल चालवलेली असते, आपण पंक्चर काढलेलं बघितलेलं असते सायकलच्या दुकानात, तो काय करतो, हवा मारतो, पाण्यात बुडवतो, कुठं लीक आहे बघतो आणि तिथंच. तर त्याप्रमाणे आम्ही काय केलं की बाबा इरिगेशन दिलं, लंग कॅव्हिटी फिलअप केली. त्याच्यानंतर आम्ही काय केलं, जे पाणी आहे, जे इरिगेशन दिलेलं, त्यात लंग टिश्यू डीप करून पाहिले की बाबा कुठून लीक होतं आहे. आणि जे ऑलमोस्ट आफ्टर 15 to 20 मिनिट्स ऑफ हार्डवर्क एक अपायकल सेगमेंटला किती छोटासा आहे, हा लॅप्रोस्कोपवर इतका दिसतो आहे, म्हणजे असताना किती छोटा असेल. तर हा ब्लेब मिळाला. ब्लेब म्हणजे काय, फुग्यावर आलेला छोटासा फुगा ज्याला आपण म्हणू शकतो. मग आता ह्याला करायचं काय, तर आता आपण आयसोलेशन तर केलेलं आहे ब्लेबचं, तर आता हा रप्चर करावा लागणार. रप्चर करून तो रिमूव्ह करायचा आणि जिथे तो रिमूव्ह करतो आहे तिथून आपल्याला लंग टिश्यूही वाचवायचा, FE1 FEC रेशिओ पण लंगचे वाचवायचे आहेत. तर जिथे आपण रप्चर करतो आहे त्याच्या हार्डली 1 सेंटीमीटर खालीच आपण स्टॅपल करतो त्याला, जेणेकरून जास्त लंग टिश्यू आपला वाया जाऊ नये. तर हे रप्चर केला, रप्चर करून रिमूव्ह केला. हळूहळू रिमूव्ह केला, कारण का लंग टिश्यू आहे ना खूप फेबाईल, म्हणजे एखादा लहान मुलाला किंवा हातावरच्या फोडाला जपावं की नाही तेवढा लंग टिश्यू फेबायला असतो. तुम्ही जेवढं त्याला केअरफुली हँडल कराल तेवढा तुमचा सक्सेस रेट जास्त आहे. नाहीतर तुम्ही करायला जाणारे गोष्टी वेगळ्या होऊ शकतात. सो वेळ लागला तरी चालेल. आणि त्याच्यानंतर मी जसं बोललो की हार्डली 1 सेंटीमीटर खाली आपण स्टॅपल करतो, का तर ते लीक पुन्हा तिथून होऊ नये या अनुषंगाने. हे स्टॅपल केला. मला ह्या केसला 2 स्टॅपलर लागले होते. त्याच्यानंतर सेम प्रोसिजर जे आपण डिकॉर्टिकेशनला केली, परत आपण ते इरिगेशन दिलं, ते बुडवून पाहिलं लंग त्याच्यात की बाबा पुन्हा लीक होतं आहे नाही होत आहे. आणि जेव्हा ॲश्युरिटी आली की आता आपण जो लीक होता तो लीक क्लोज केला आहे स्टेपलनी, त्याच्यानंतर रिमेनिंग प्रोसेस की बाबा पुन्हा होऊ नये म्हणून सेम मेकॅनिकल प्ल्युरोडिसिस फॉलोड बाय टाल्क प्ल्युरोडिसिस, ICD प्लेसमेंट आणि त्याच्यानंतर लंग एक्सपान्शन. तर पहिल्या केसमध्ये आपण काय काय केलं, तर आपण आत गेलो, एंट्री घेतली, एंट्रीमध्ये व्ह्यू घेतला, आयसोलेशन केलं. डर्बीचं आयसोलेशन केल्यानंतर व्यवस्थितपणे सेपरेशन केले, प्ल्युरल सेपरेशन फ्रॉम थोरॅसिक वॉल ऑल्सो. त्याच्यानंतर जे लंगवर राहिले होते थोडेफार त्याचं पिलिंग ऑफ केलं. मेकॅनिकल प्ल्युरोडिसिस, टाल्क प्ल्युरोडिसिस आणि ICD इन्सर्शन. सेकंडमध्ये सेम एंट्री, इरिगेशन दिला, इरिगेशन नंतर आयसोलेशन केलं, कुठून लीक आहे, ब्लेब कुठं आहे तो पाहिला, रप्चर आणि रिमूव्हल केलं ब्लेबला. फर्स्ट स्टॅपलर, त्याच्यानंतर सेकंड स्टॅपलर, रिचेकिंग ऑफ लीक की पुन्हा काही लीक नाही आहे ना त्या साईटवरून. मेकॅनिकल प्ल्युरोडिसिस, टाल्क प्ल्युरोडिसिस, ICD प्लेस केलं आणि ऑन टेबल लंग एक्सपांड केला. दोन्ही प्रोसिजर नंतर पेशंट 3ऱ्या ते 4थ्या दिवशी घरी गेले विथ कंप्लीट रिमूव्हल ऑफ ICD. हे दोघांचेही एक्सरे आहेत. तर ह्या शॉर्ट स्टोरीमधून काय शिकलो आपण, तर जेव्हा तुमच्याकडे पेशंट येतो आणि त्याच्या एक्सरेला तुम्हाला ब्लेब, बुल्ला या सिस्ट या गोष्टी दिसतात, सॉरी ज्या दिसू शकत नाही पण निमोथोरॅक्ससारखा तुम्हाला तो एक्सरे दिसतो, तेव्हा डिरेक्टली ICDला जाण्याच्या आधी तुम्ही CT केलेला कधीही चांगला राहील, पहिली गोष्ट. दुसरी गोष्ट, ह्याच्यात जसं मी बोललो आहे की चेस्ट एक्सरे मे क्रिएट इल्युजन्स. निमोथोरॅक्स मिमिक्स होतं. तुमचा जेव्हा बुल्लस लंग डिसीज असेल तेव्हा इट मिमिक्स लाईक निमोथोरॅक्स आणि त्याच्यासाठी बेस्ट ऑप्शन राहतं वॅट्स डिकॉर्टिकेशन. मी जेव्हा तुम्हाला स्टार्टिंगला म्हटलो की हा सिटी आपण परत बघूयात. तर मी हे का बोललो होतो कारण का जर तुम्ही ह्याच्या मार्जिन्स बघितल्या, ह्या ज्या मार्जिन्स आहेत या मार्जिन्स जर बघितल्या, इथे जर रेडिओलॉजिस्ट असतील तर ते ॲग्री करतील माझ्या गोष्टीबरोबर, तर इथे डबल वॉल मार्जिन्स दिसतात. डबल वॉल मार्जिन्स अँड डबल वॉल मार्जिन्स इट सेल्फ इंडिकेट्स दॅट इट्स अ बुल्लस लंग डिसीज. त्यामुळं कोणतीही गोष्ट जेव्हा आपल्या ओ पी डीत येते किंवा आपल्या इमर्जन्सीत येते, बाहेर ऑलरेडी ट्रीट झालेली असते आणि तेव्हा आपल्याला आपल्या एक्सपर्ट ओपिनियनसाठी आलेली असते, तेव्हा मी नेहमी सांगतो की एक्सरेवर कोणतेही कन्क्लुजिंग थिंग तुम्ही कमेंट करायला किंवा ट्रीट करायला जाऊ नका. यू शूड अँड यू मस्ट गो फॉर CT अँड ऑल अदर इन्व्हेस्टिगेशन्स बिफोर मेकिंग अ फायनल डायग्नोसिस. थँक्यू. या आता आम्ही आपुलकी चेस्ट क्लिनिक अकलूजमध्ये वी आर वर्किंग ॲज अ डेडिकेटेड चेस्ट सेंटर, थोरॅसिक सेंटर, वेअर वी आर डुईंग ऑल द थिंग्स. ब्रॉन्कोस्कोपिक तर सगळंच करतो आहे आम्ही, स्टेंटिंग करतो आहे, बलून डायलिटेशन करतो आहे, ग्ल्यू इन्स्टिलेशन करतो आहे. इवन इन सोलापूर डिस्ट्रिक्ट वी कॅन प्राऊडली से थोरॅक्स अँड थोरॅसिक कॅव्हिटीमध्ये वॅट्स आणि या गोष्टी करणारे वी आर द ओनली वन who are doing all these things. Day to day ऑब्स्ट्रक्टिव्ह एअरवे डिसीज आणि TB, बाकीच्या गोष्टी, निमोनिया, MDR, XDR, डिफिकल्ट एक्स्ट्युबेशन यासारख्या गोष्टीवर तर काम करतोच आहे. पण आय विल ग्लाड अँड आय विल बी हॅपी इफ आय कॅन सर्व इंदापूर ॲज पर माय नॉलेज अँड माय स्किल्स. थँक्यू.
Thank you, Chirag, for giving us such a wonderful talk on the interventions, and we are very much delighted to have this detailed knowledge about the pneumothorax, the bulbous blebs in the lung, and how to tackle with this. So I can have the two take-home messages that in cases of pneumothorax, don't play. You go more in details. It is the lesson for physicians specifically. And second take-home message is literally send the patient to the pulmonologist. Actually, you were worried about the postprandial hyperglycemia and the sleepiness, but your talk in the vernacular with added Indapurian and Akhileshwar accent, so no one was able to sleep. So I again thank you for your wonderful job and wonderful talk. Thank you.
Thank you, sir.
Now I request our chairperson, Dr. Sudhir Tambile, and Rohan Hegde to felicitate Chirag with memento and the bouquet. You are chairperson for the next session also. Yes, sir. Now I request Dr. Rahul Nagne to come on the dais, and he will talk about stroke thrombolysis, the magic therapy.
It's another pleasure and delight to another wonderful doctor. So about Rahul sir, he is already visiting our hospital in Akhileshwar as a visiting neurologist. He's one of the most humble and down-to-earth persons I have ever met, and superb neurologist. He has done his DM from GB Pant in New Delhi, and it's a pleasure, sir, to have you amongst us today. So I hand over the session to Dr. Rahul Nagre, sir.
Good evening, everyone. Myself, Dr. Rahul Nagne. I'm a consultant neurologist practicing in Pandharpur and visiting the Rhythms Heart and Super Specialty Hospital, Akhileshwar, once a week. I would like to thank IMA Indapur and the organizing members of the INDACON for providing me opportunity to deliver a talk on the common topic of the neurology, that is thrombolysis in stroke. The title for today's topic is the magic of thrombolysis in the acute stroke. First of all, we'll have a little bit introduction. Tissue plasminogen activator is a naturally occurring enzyme in our body which helps in clot lysis. And recombinant technology has made it possible to produce altiplase, retiplase and tenecteplase. In last 25 years, altiplase is the most widely studied tissue plasminogen activator for the treatment of the stroke. So we'll see the evolution of the thrombolytic agents in the acute stroke. First, there were the first generation thrombolytic agents like streptokinase, then second generation altiplase, and recently tenecteplase is the third generation thrombolytic agent in use. What is the goal of the reperfusion therapy? What we want to achieve with the thrombolytic agent? We want to restore the blood flow to the brain tissue and improve the outcome by reducing the stroke-related disability, which is the most common disability associated with the stroke. So we have two options. The first is the reperfusion therapy with IV thrombolysis, which can be done within 4.5 hours, and second is the thrombolytic mechanical thrombectomy. Mechanical thrombectomy has been discussed by the respected Dr. Ashwin Sankar sir in the morning session. I will be discussing regarding the thrombolysis. We need to discuss AHA guidelines regarding the thrombolysis, so that we will have clarity in our mind which patient we can thrombolyze, which we cannot thrombolyze. I will not make it complicated. I will discuss it simply. First of all, we should be able to classify the stroke into severity, whether it is mild, moderate, and severe. It can be done using the NIHS scale. This is the 11-point scale. All these parameters are assessed, and we can decide whether it is mild stroke, that is NIHS score less than 5, and then moderate and severe. Now, any patient which come to our casualty or day-to-day OPD with the sudden onset of the weakness of the upper limb and lower limb, facial weakness, sudden onset confusion, or sudden onset loss of consciousness, imaging is mandatory and before starting any treatment. So in day-to-day practice, we always have a question which imaging we should do. So non-contrast CT is almost available in most of the town places and taluka places now. So now non-contrast CT is the only imaging we need before starting the treatment for the weakness or the suspected stroke. And it is the only imaging which has been used in the most of the trials which have made the guidelines for the thrombolysis. So the NCCT is the sufficient neuroimaging for the decision about the altiplase in most of the patient. MRI आणि बाकीच्या गोष्टीसाठी वेळ घालवण्यापेक्षा जे अवेलेबल आहे आपल्याकडे ते CT करून ICH इंट्राक्रॅनियल हेमरेज रूल आउट केल्यानंतर आपण पुढचे डिसिजन घेऊ शकतो. आणि एक स्पेशल सिच्युएशन आहे ज्याच्यामध्ये आपल्याला क्लिअर कट नाही की टाइम किती झाला आहे. When we are unclear about the time, so patient comes with the wake-up stroke, like patient woke up in the morning and he had weakness. So we don't know whether the weakness was developed in the night itself or a few hours back. So in that case only we need MRI to look for the diffusion-perfusion mismatch. What is diffusion flare mismatch? We see the hyperintensity in the diffusion images, and there is no corresponding hyperintensity in the flare images. So in that case only we need to do MRI. Otherwise CT the basic investigation is sufficient. What all other diagnostic tests we need is only blood glucose level. So blood glucose level is the only blood test that need to be measured, and we don't need to wait for the other test results like hematologic or coagulation testing in suspected case for the treatment of the stroke. We need to treat hypoglycemia before starting the treatment, and blood glucose should be maintained more than 60. And during and after the thrombolysis, the blood glucose should be maintained between 140 to 180. Other baseline investigations like ECG, TROP-T, chest X-ray and all routine investigations can be done, but they should not delay the treatment of the stroke patient. Another important aspect, the temperature. If the patient has temperature more than 38 degrees centigrade, we need to control with the antipyretic medications. We should be prepared to deal with the complications of the thrombolysis, which I will discuss in the next slides. Now, the concept of time window, there are two concepts, that is for patient presenting within 3 hours. Level of recommendation and class of recommendation both are 1 and A for the thrombolysis of in such patients. In patient presenting within 3 to 4.5 hours, the class of recommendation is 1, means you should definitely thrombolyze the patient, but the level of recommendation changes. So I can say time is very important in making the quick decisions. For altiplase or the thrombolysis in the wake of stroke, the decision should be made based on, as I discussed in the previous slide, based on the MRI images with flare diffusion mismatch and diffusion image showing lesions smaller than 1/3 of the MCA territory. For the mild stroke, many times the patient comes, he has just mild weakness, and patient is in the window period, and we don't know whether we go for the thrombolysis or not. That decision depends upon whether the stroke is disabling or non-disabling. What is the disabling stroke? The disabling stroke is the stroke like deficit involving the dominant hand. I am right-handed. I am working with my dominant hand, and I have the weakness in the right hand. Then that is disabling stroke. Another example is the involvement of the speech. In such cases, even if it is a mild stroke, class of recommendation is you can thrombolyze for the patient, and patient will definitely improve and will have benefits. For mild stroke with non-disabling symptoms, means non-dominant hand involvement, no speech involvement, or minimal weakness, there is no benefit of thrombolysis, and we should avoid thrombolysis in such patients. In this slide, some patients have previous MRI showing microbleeds. Then we think whether we should thrombolyze or not, whether we will complicate the case. Then also we can thrombolyze the patient, and we should not defer the patient from thrombolysis. After these indications, I would like to point out toward the contraindications of the thrombolysis. Contraindications are simple. The patient having severe head trauma within past 3 months, past history of stroke in last 3 months, intracranial hemorrhage, subarachnoid hemorrhage, history of infective endocarditis. All these are the contraindications. The main is the blood pressure more than 185 or the diastolic blood pressure more than 110. The patient blood pressure should be lowered before starting the thrombolytic treatment. Other contraindications are many patients are on the warfarin, patient who have received heparin in the last 48 hours with abnormal APDT, and patient on the oral anticoagulant. For the other indications, we cannot thrombolyze such patients. I would like to discuss some special situations. As first situation I discussed, mild disabling stroke, we need to thrombolyze. Non-disabling stroke, we don't need to thrombolyze, there is no recommendation. Cardiovascular conditions, patient sometimes present with the MI and stroke. So in such cases, we should thrombolyze the patient followed by the coronary interventions. Some patients have a recent history of MI in the past 3 months. We should see whether it is NSTEMI or STEMI involving the right or the inferior wall MI, then it is recommended to thrombolyze the patient. For the patient with past history of STEMI involving left myocardium, then also it is reasonable to thrombolyze the patient. However, patient with acute pericarditis or left ventricular thrombus, decision should be made after consultation with the cardiologist whether we can thrombolyze or not. Other indications like cardiac myxoma, papillary fibroelastoma with severe disability, we can thrombolyze the patient. Vascular lesions involving the extracranial cervical artery like dissection, we can thrombolyze. However, it is uncertain whether the vascular lesions involving the intracranial arterial dissection we can thrombolyze or not. Aneurysms less than 10 millimeter size, some patients are the known case of aneurysm and present with the stroke, then it is reasonable to thrombolize the patient. However, in patients with AV malformation, we should avoid thrombolysis. As I told previously, patient with cerebral microbleeds, we can thrombolize the patients because benefits outweigh the risk. In case of malignancy, systemic malignancy, any patient with systemic malignancy with life expectancy more than 6 months may benefit from the thrombolysis. However, GI malignancy is an absolute contraindication for the thrombolysis. Other scenario is coagulopathy. If the patient is on warfarin, but the INR report is available with less than 7 or PT is less than 15, then we can thrombolize the patient. Another scenario is sometimes the pregnant woman come with the sudden onset weakness. Thrombolysis can be considered if the severity of the weakness is more and benefits definitely outweigh the anticipated risk of uterine bleeding. Other situations like sickle cell disease, CT saving hypertensive MCA, patient illicit drug user, and this one is a stroke mimic. Sometimes we are not sure whether it's a stroke or not. Sometimes seizure with post-ictal state and other hypoglycemia and other situations may mimic stroke. But we don't have time to evaluate such situations because time window, golden hour is the dictum in the stroke. In such situation, we should take the decision to thrombolize the patient, and we should not waste time in evaluating the patient for the cause, for his or her weakness. Another thing is the periprocedural stroke, which is common with cardiac or cerebral angiographic procedure. In such cases also, we can thrombolize the patient. Another thing, sometimes the presentation of the stroke is a seizure. Patient presents with a seizure, and on imaging we see the patient is having ischemic stroke. In such situation also we can thrombolize the patient. And for nephrologist, patient with end-stage renal disease already on hemodialysis is not a contraindication for the thrombolysis. We can thrombolize such patients also. Menstruating woman, we can thrombolize the patient after consultation with the gynec persons. The same thing European stroke guidelines tell, what I have discussed previously. Now another question is whether to use the alteplase or tenecteplase. Whichever is available can be used. Recently there is a trend towards the use of the tenecteplase because tenecteplase has greater affinity, faster onset of action. We don't need to give the infusion, and can be given as a bolus and has a longer half-life. So these are the studies which are supporting the use of tenecteplase over the alteplase. This is the meta-analysis which has shown that tenecteplase is safe and effective and might provide the more benefits compared to the alteplase. This is another study which has shown the higher incidence of early neurological improvement with the use of tenecteplase. Now we have thrombolized the patient. Important is the post-alteplase treatment, post-alteplase management of the patient, post-thrombolysis management of the patient. Target BP should be less than 180/105 in the first 24 hours after the alteplase treatment. And this should be monitored meticulously to avoid the complications. Another question is when to start the antiplatelets after the stroke. Aspirin can be started after 24 to 48 hours after the stroke, after obtaining the CT which don't show any hemorrhage or hemorrhagic transformation. Treatment of hypertension in stroke patients. If the BP is less than is more than 220/120, then only we need to reduce the BP. If patient is not candidate for the thrombolysis, the target BP should be lowered by 15% in first 24 hours. We don't need to reduce the BP very rapidly. And those with presenting with the BP less than 220/120 and who are not receiving thrombolysis, we should not be in hurry to reduce the BP because it will not benefit the patient. Now, what are the options for the arterial hypertension in patients of the stroke who are the candidates for the reperfusion therapy or thrombolytic therapy? BP should be reduced to less than 185/110. We can use levetolol, nicardipine. Other options are hydralazine, enalprate or clevidipine. If BP is not maintained less than 185/110, do not use the thrombolytic treatment. Now, how we can monitor post-thrombolysis? Monitoring should be done every 15 minutes for first 2 hours, then every 30 minutes for first 6 hours, and every hour till next 16 hours. For those who are not eligible for the thrombolysis, These are the guidelines. If the systolic BP is less than 140 and diastolic is less than 90, we should stop the antihypertensives and observe the patient. If the BP is less than 220 by 120, we need to observe and we need to treat the BP. If it is only systolic is more than 220 and diastolic is more than 120, or only isolated diastolic hypertension is BP more than 140. Otherwise, we don't need to treat the patient. Now, sometimes post thrombolysis intracranial hemorrhage may occur. What we can do? Immediately stop the thrombolytic treatment. Cryoprecipitate can be used, which can be given 10 units infused over 30 minutes. Tranexamic acid loading dose followed by the maintenance can be given, and neurosurgery consultation should be often. Immediate complication post thrombolysis or during thrombolysis is the angioedema, which can be managed with the treatment like methylprednisolone, diphenhydramine, and ranitidine, and the antidote is icatibant. During this time, we should have interaction with the endovascular thrombectomy team, if possible, because 10 to 30% of the patients with large vessel occlusion, as it was told by Ashwin sir also, may not improve after the thrombolysis treatment. But this doesn't mean you should skip the thrombolysis and refer the patient to the thrombectomy. You should give every chance to the patient for the thrombectomy. Lastly, I would like to give the message that time is brain. When I say time is brain, shorter the time to the thrombolysis treatment onset, then there will be reduced disability in 90 days. So better results are obtained with when the treatment is started within the first hour of the treatment, first hour of the weakness onset. When I say time is brain, I mean this. Per stroke, there is accelerated aging by 36 years. Per hour, it is accelerated by 3.6 years. Per minute, it's accelerated by 3.1 week. And per second, it's accelerated by 8.7 hours. So now you will have clear impression that what I mean by the time is brain. And with every stroke, you will lose 1.9 million neurons, 14 billion synapses, 7.5 miles of the myelinated fibers. So take the decision. And when I said time is important, I mean at 60% we can save 90% of the brain, at 2 hours 80% of the brain, at 3 hours 60%, and up to 4.5 hours we can save the 40% of the brain. After that maybe 30% and less than 20%. Lastly, I would like to show how magical is the thrombolytic therapy. Most of you have already done the thrombolysis and know this. This gentleman presented with sudden onset weakness of the right upper limb and lower limb. Power on presentation was 0. He was aphasic, and there was a mild facial weakness also. Patient presented within window period, and we thrombolized the patient within 45 minutes. Within seconds, patient had the improvement of the power, and the power was more than 3. His facial weakness improved, and he was able to speak. So now you can understand what does this mean, the time is brain, and what the magic the thrombolysis can do. Thank you very much. Thank you for the patient listening.
Thank you, sir. Thank you very much for the wonderful presentation. And I hope you continue to visit us and offer your services to our medical fraternity, especially our town of Indapur. At least if you are able to spare one day, a few hours in a month, it would be very, very good, sir.
Sure. I would like to work with you all.
Thank you, sir. Thank you. Absolutely. It's a pleasure having you here.
Thank
you. Now I request our chairpersons, Dr. Rohan and Dr. Sudhir Tambile, to felicitate our speaker, Dr. Rahul Nagne. Thank you, Rahul, for giving such a wonderful talk, and when to use altiplase, when to use tenecteplase, and how time is money or time is a brain. Thank you. Now I request our next speaker, Dr. Nitin Londe. One minute. Felicitation of our two chairpersons. I request Dr. Sudarshan Doshi sir, our senior practitioner from Nimgaon Ketki, to felicitate our chairpersons, Dr. Sudhir Tambile and Rohan Hegde. Now I request our next chairpersons, Dr. Mahesh Rupnavar and Dr. Raghunandan Pomne, to chair the session. This is the last batting session and you have to be on the crease till the end of the match. So no one is going to replace you now. So till the end of the match you are there. And I request Dr. Nitin Londe sir to have his talk. Thank you.
Good evening everyone. Respected chairpersons, seniors, teachers, colleagues and my dear friends. Before I start my topic as a medical legal issues in day-to-day our practice, yesterday we had a very nice discussion by the panelists and they have covered almost all the topics. Okay, so we will see from the practical point of view की आपल्याला काय काय अडचणी येतात आणि त्या अगोदर आपण बेसिकली आपल्या डॉक्टरांच्या अगेन्स्ट जे काही सध्या जनमानसांमध्ये मत तयार झालेलं आहे तर ते बेसिकली एकदा जाणून घेऊया की सपोज दिस इज अ वन पोस्ट की KEMमध्ये एका रुग्णालयात डॉक्टरांना सळईने मारहाण केली तर त्यावेळेस लोकांच्या काय प्रतिक्रिया होत्या त्याच्यामध्ये. तर KEMमध्ये पेशंट ॲडमिट करून घेतल्यावर कित्येक तास तरी त्याला कोणी बघायला येत नाही. मेला असेल तर अभिनंदन, चोर हे डॉक्टर सब, डॉक्टर सोडा, त्या नर्सेस कशा उद्धट उत्तरे देतात बघा. पेशंट जोपर्यंत जमिनीवर पडत नाही तोपर्यंत डॉक्टर्स बघत नाही. मी असतो तर मी पण हेच केले असते. एकाची शिक्षा दुसऱ्याला का, बरे झाले मारले, मी माझ्या बाबांना घेऊन नाही गेलो तिकडे. आणि माणसांच्या जीवापेक्षा यांना पैसे महत्त्वाचे वाटतात. सो यातली फक्त एकच पोस्ट म्हणजे या 8-9 रिप्लायपैकी एक रिप्लाय इज इन फेवर ऑफ डॉक्टर्स अँड ऑल अदर बेसिकली अगेन्स्ट द डॉक्टर्स. सो वी नो की हार्डली काही जन्म ते जे फक्त आपल्या बाजूने बोलणार आहे, बाकी ऑलमोस्ट एव्हरी इज आपल्या अगेन्स्ट आहे. आणि मग अशा सिच्युएशनमध्ये आपल्याला प्रॅक्टिस खूप सांभाळून करायला लागेल. सो व्हॉट इज द करंट मेडिको लिगल सिनेरिओ. कंझ्युमर अवेअरनेस दिवसेंदिवस वाढतच चाललेला आहे आणि प्रत्येक कॉम्प्लिकेशन्सला रिलेटिव्स दे ऑलवेज टेक इट ॲज अ निग्लिजन्स ऑन द पार्ट ऑफ ट्रीटिंग डॉक्टर्स. मग त्यांचे ॲलिगेशन सुरू होतात ते. अँड देर आर एन नंबर ऑफ केसेस पेंडिंग बिफोर व्हेरियस फोरम थ्रू आउट आवर कंट्री. सो द बेस्ट सोल्युशन इज टू डू अ एव्हिडन्स बेस्ड प्रॅक्टिस. सो म्हणजे आपण जेव्हा कुठलीही आपल्या अगेन्स्ट एखादी केस होते तर आपल्याला कोर्टामध्ये एवढंच प्रूव्ह करायचं आहे की मी जी ट्रीटमेंट दिलेली आहे ती कशी योग्य आहे. आणि त्यासाठी आपल्याला एव्हिडन्स बेस्ड म्हणजे आपले जे कुठलेही स्टँडर्ड टेक्स्टबुक, जर्नल्स जे काय आपण रेफर करतो तर त्या अनुषंगाने आपल्याला आपली बाजू तिथे सिद्ध करावी लागते. नाऊ दिस वॉज द स्टॅटिस्टिक्स इन 2019 ज्याच्यामध्ये किती केसेस पेंडिंग होतात बिफोर हे. ॲट प्रेझेंट जानेवारी 2025चे जे स्टॅटिस्टिक्स आहे त्याच्यामध्ये एकट्या सुप्रीम कोर्ट्समध्येच द नंबर ऑफ केसेस आर पेंडिंग विच आर मोर दॅन 82,000. सो ऑलमोस्ट डबल दॅन द 2019. ठीक आहे. सो एवढ्या जेव्हा केसेस पेंडिंग असतात सो अँड देर आर सम फ्यू केसेस विच आर पेंडिंग सिन्स मोर दॅन 20 years. काही आहेत त्या अगदी 30-30 वर्षापासूनही चालू आहेत त्या. ओके. सो न्याय मिळेल नाही मिळेल कधी मिळेल ही तर खूप लांबची गोष्ट राहिली आपल्यासाठी. ठीक आहे. सो ॲज अ मेडिकल प्रोफेशनल आपल्याला 2 गोष्टी फॉलो करायला लागतात. वन इज इथिक्स विच इज लेट डाऊन बाय आवर ओन मेडिकल काउन्सिल आणि दुसरं जे आहे लिगॅलिटीज. सो व्हॉट आर द लिगॅलिटीज. वी आर ऑल अबाईड बाय द लॉ ऑफ द लँड. म्हणजे ज्याच्यामध्ये कंझ्युमर प्रोटेक्शन ॲक्ट आला, सिव्हिल लॉज आलेत, क्रिमिनल लॉज आलेत, ह्युमन राईट्स आलं, स्टॅच्युटरी लॉज आले. मग त्यामध्ये प्रत्येक स्टेट वाईज बरेचसे वेगळे लॉज आहेत अँड वी आर सपोज टू फॉलो. कालच जेव्हा पॅनल डिस्कशन झालं त्यावेळेस अरंकर सरांनी सांगितलं की आम्हाला 52 पाकिटं तिथे रेडी ठेवावे लागतात ते. ठीक आहे. मग हे एवढे रूल्स रेग्युलेशन सगळे फॉलो करायचे आहेच. वरनं प्रॅक्टिसही चांगली करा, वरनं कॉम्प्लिकेशनही नाही झालं पाहिजे आणि जर झालं तर त्याला कसं हँडल करायचं तेही बघायचं. म्हणजे इट्स ओके. तेजल मॅडमनी सकाळी सांगितलं की डॉक्टरांनी हॅप्पी राहिलं पाहिजे, पण आता हे सगळं करून हॅप्पी राहणं म्हणजे जरा थोडंसं अवघड आहे. म्हणजे इम्पॉसिबल नाही आहे बट वी हॅव टू फाइंड आवर ओन वे आउट. ओके. मग जेव्हा कुठलंही एखादं कॉम्प्लिकेशन होतं, लेट इट बी अ नॅचरल कॉम्प्लिकेशन ऑफ द डिसीज इट सेल्फ. एखादा पेशंट आला, MIचा आला, तो एक्सपायर झाला हॉस्पिटलमध्ये येऊन, किंवा एखादं कॉम्प्लिकेशन झालं, मी ऑर्थोपेडिक सर्जन आहे, सर्जरी केली, एखाद्या पेशंटला नॉन युनियन झालं, इम्प्लांट ब्रेकेज झालं किंवा इन्फेक्शन झालं. द पेशंटला एवढंच माहिती आहे की आपल्याबद्दल बरोबर काहीतरी डॅमेज झाला आहे, तर इथे डॉक्टरांची हॉस्पिटलची स्टाफची चूक आहे. ठीक आहे, दे नेवर ॲक्सेप्ट इट ॲज अ नॅचरल कॉन्सिक्वेन्स ऑर नॅचरल दिस ऑफ द डिसीज. मग त्यामध्ये ते कुठे कुठे कंप्लेंट करू शकतात. दे हॅव द राईट टू कंप्लेंट अगेन्स्ट अस टू ऑल दीज ऑथॉरिटीज सायमल्टेनियसली. म्हणजे ते पोलीस स्टेशनमध्ये करतील, त्याच वेळेस ते MMCमध्ये पण करतील. ठीक आहे, त्यांना कुठेही तक्रार करायचा अधिकार आहे. लेट इट बी, अँड वी आर सपोज टू रिप्लाय टू ऑल दीज कंप्लेंट्स ॲट द सेम टाईम. मग जेव्हा असं एखादा प्रॉब्लेम येतो आणि बऱ्याच वेळेला जेव्हा एखादी अनएक्सपेक्टेड डेथ होते, एखाद्या यंग पेशंटची डेथ होते, सो वी आर ऑलवेज फिअरफुल अबाउट फ्यू थिंग्स लाईक व्हायोलेन्स इन द हॉस्पिटल. मग त्याच्यामध्ये जो काल यांनी डोळ्याचा किस्सा डिस्कस केला, ज्याच्यामध्ये डॉक्टरांच्या डोळ्याला मारहाण झाली, मग असं व्हँडलायझेशन ऑफ द हॉस्पिटल वगैरे होतं, मीडिया ट्रायल्स होतात, डॉक्टरांच्या अगेन्स्ट खूप साऱ्या न्यूज पब्लिश होतात, आणि दॅट टू विदाऊट, इट्स जस्ट वन साइडेड स्टोरी जी युजली प्रेझेंट केली जाते. ठीक आहे, बऱ्याच वेळेला तर असं होतं की डॉक्टरांना विचारणंसुद्धा केली जाते की तुमचं म्हणणं काय या केसमध्ये हे तरी सांगा. सी, द प्रॉपर जर्नलिझम शुड बी, दे शुड बेसिकली प्रेझेंट बोथ साईड स्टोरीज, पण तसं होत नाही युजली. अँड इन दॅट केस येस, वी हॅव द राईट टू सेंड अ लिगल नोटीस और फाइल अ डिफेमेशन सूट अगेन्स्ट दॅट पर्टिक्युलर चॅनल और द न्यूजपेपर, की तुम्ही आम्हाला ही स्टोरी छापायच्या आधी काहीच विचारलं नाही आहे. ठीक आहे, यू डिडंट कॉन्टॅक्ट अस फॉर एनी इन्फॉर्मेशन फ्रॉम आवर साईड. सो ऑफेन्सिव्ह लँग्वेजेस काहीतरी मग होतात, थ्रेट ऑफ असॉल्ट्स असतं, डिस्ट्रक्शन ऑफ प्रॉपर्टी असते. सो जेव्हा आपण म्हणतो की निग्लिजन्स निग्लिजन्स निग्लिजन्स, तर मग एक्झॅक्टली निग्लिजन्स म्हणजे काय? सो निग्लिजन्स हॅज बेसिकली 3 कंपोनंट्स बाय डेफिनेशन. फर्स्ट इज ड्युटी. ड्युटी म्हणजे डॉक्टर पेशंट्स रिलेशनशिप इज एस्टॅब्लिश, ब्रीच ऑफ दॅट ड्युटी, आणि हे ब्रीच ऑफ ड्युटी झाल्यामुळे जो काही रिझल्टंट डॅमेज आहे, जर कुठलाही पेशंट आपल्या अगेन्स्ट या 3 कंपोनंट कुठल्याही कोर्टामध्ये प्रूव्ह करतो, तर देन इट इज सेड दॅट द डॉक्टर इज निग्लिजंट इन ट्रीटिंग हिज पेशंट. वी ब्रॉडली क्लासिफाय निग्लिजंट इंटू 2 थिंग्स, सिव्हिल निग्लिजन्स आणि क्रिमिनल निग्लिजन्स. मग सिव्हिल निग्लिजन्समध्ये विदाऊट इंटेन्शन पेशंटला काहीतरी आपल्याकडनं डॅमेज झालेलं असतं, बट क्रिमिनलमध्ये देर इज अ रेकलेस रिगार्ड फॉर पेशंट सेफ्टी लिडिंग टू सिरियस हार्म ऑर डेथ. सिव्हिल निग्लिजन्स किंवा कंझ्युमरमध्ये जेव्हा पेशंट जातो, तेव्हा त्याचं एम असतं टू गेट अ मॉनिटरी कॉम्पेन्सेशन फ्रॉम द डॉक्टर. जेव्हा तो क्रिमिनल केस फाईल करतो, हिज एम इज टू पुट द डॉक्टर बिहाइंड द बार. ओके, मग आता या कुठलीही केस होऊ द्या, कुठेही पेशंटनी कंप्लेंट करू द्या, सगळ्यात महत्त्वाचं आपल्यासाठी काय आहे की या ऑथॉरिटीज आपल्याकडे मागतात ते डॉक्युमेंट्स आपले. आणि काल पॅनल डिस्कशनमध्ये जेव्हा डिस्कस झालं, आपण डॉक्युमेंटेशनमध्ये भयंकर चुका करतो आणि तिथे आपण खूप लॅकिंग असतो. जेव्हा ॲज अ मेडिको लिगल कन्सल्टंट आम्ही डॉक्युमेंट चेक करतो, सो वी कम टू नो की आपण कुठे कुठे चुका करतोय त्या, अँड वी ऑलवेज ट्राय टू बेसिकली रेक्टिफाय ऑल दोज एरर्स. ठीक आहे, सो बिफोर हँडिंग ओव्हर द डॉक्युमेंट टू एनीवन, कुणालाही पेशंट मागत असेल, पोलीस मागत असेल, किंवा तुम्हाला कुणालाही सबमिट करायचं असेल, तर ऑलवेज टेक अ ऑफिशियल ॲप्लिकेशन फ्रॉम देम. ठीक आहे, जस्ट व्हर्बल ॲप्लिकेशनवर कुणाला काही द्यायचं नाही, प्रॉपर ऑफिशियल ॲप्लिकेशन घ्यायचं. चेक फॉर कम्प्लिटनेस, चेक इफ समथिंग इज सो रॉंग दॅट कॅन गो अगेन्स्ट यू. बऱ्याच वेळेला आपल्या इथे डेट टाईम लिहिलेलंच नसतं. व्हेरियस कन्सल्टंटनी बघितलं असेल तर त्यांच्यामध्ये मिसमॅच असतो त्यांच्या रायटिंगमध्ये वगैरे. चेक डेट टाईम, कम्पेअर फाइंडिंग ऑफ व्हेरियस कन्सल्टंट अँड स्टाफ ॲज पर टाईम मेन्शन. आणि सगळ्या पेपर्सला पेज नंबरिंग करायचं, 1 2 3 4 5. जिथे कुठे ब्लँक सोडलं असेल तिथे क्रॉस करा. ठीक आहे, आणि जेव्हा तुम्ही हे त्यांना देतात डॉक्युमेंट्स, तर त्यांची रिसिप्ट घ्या की ठीक आहे 1 to 60 पेजेस त्यांना मिळालेत म्हणून. मग ते लेट इट बी अ पोलीस, पेशंट, कोणी असू द्या. ठीक आहे, अँड बिफोर द हँडिंग ओव्हर डॉक्युमेंट टू एनीवन, गेट द डॉक्युमेंट चेक बाय युअर सेल्फ. कारण तुम्हाला माहीत असतं की त्या केसमध्ये एक्झॅक्टली नक्की काय झालेलं आहे, व्हॉट कॉम्प्लिकेशन्स किंवा काय प्रॉब्लेम्स आले असतील ते. सो यू आर द बेस्ट पर्सन टू जज युअर ओन डॉक्युमेंट इन फॅक्ट. ओके, बिफोर यू सेंड द डॉक्युमेंट टू एनी ऑफ द मेडिको लिगल कन्सल्टंट. And why you have to get the document check from medical legal consultant? Because over a period of years we know की जेव्हा हे केस कुठल्याही एखाद्या कोर्टामध्ये जाते, तर जो समोरच्या पार्टीचा जो ॲडव्होकेट आहे, तो यातनं कुठले लूप होल शोधून काढतो आणि तो आपल्याला कुठल्या पद्धतीने क्वेश्चनिंग करू शकतो. सो वी ट्राय टू रेक्टिफाय ऑर मॉडिफाय द डॉक्युमेंट प्रिव्हियसली ॲज पर द रिक्वायरमेंट. ओके, आणि मग आपण ते युजली सबमिट करतो. सो इफ यू सी द मेडिकल रेकॉर्ड्स, मेडिकल रेकॉर्ड इज अ लिगल डॉक्युमेंट. ओके, आणि this is basically produced in any court of law, which is basically considered as a crucial evidence in all the medico-legal or negligence cases. Now coming to some of the allegations, which are the common allegations. जेव्हा कधी medical negligence होतं, तर जे common allegations by पेशंटचे नातेवाईक असतात, तर त्यांच्याकडनं काय काय केले जातात ते बघूया, आणि त्याच्याशी रिलेटेड आपण जस्ट काही केसेस पण बघूया. ठीक आहे, द मोस्ट इम्पॉर्टंट इज की आपल्याला हे केस लॉज माहीत पाहिजे सो दॅट वी कॅन डिफेंड ऑर प्रेझेंट आवर केस बिफोर द जजेस. जजेसला बऱ्याच वेळेला त्या गोष्टी माहीत नसतात आणि अल्टिमेटली कुठलीही केस जिंकणं किंवा हरणं हे डिपेंडिंग ऑन येस फॅक्ट्सवर तर असतं, डॉक्युमेंटेशनवरही असतं, पण आपण ती कशा पद्धतीने प्रेझेंट करतो आणि त्या जजला कसं कन्व्हिन्स करतो की व्हॉट एव्हर आय हॅव डन इज ॲक्च्युली द राईट थिंग. ठीक आहे. सो दॅट इज मच मोर इम्पॉर्टंट. सो मिसडायग्नोसिस किंवा डिलेड डायग्नोसिसमध्ये पेशंटचे युज्युअल ॲलिगेशन्स असतात. इनकरेक्ट डायग्नोसिस लिडिंग टू रॉंग ट्रीटमेंट, डिले इन आयडेंटिफाईंग अ सिरियस कंडिशन अँड फेल्युअर टू ऑर्डर द नेसेसरी टेस्ट. ठीक आहे. आता जेव्हा कधी पण मी एखादे सांगतो की लेट सी एव्हरी कंपाऊंड इंजुरी, लेट इट बी अ पंक्चर कंपाऊंड ऑफ द वुंड, कुठेही असू द्या ते, ऑलवेज ॲडवाईज एक्सरे ऑन पेपर. ठीक आहे. बऱ्याच वेळेला आपण काय करतो, छोटीशी वुंड आहे, वॉश देतो, हां ठीक आहे, तिथे काही दिसत नाही आहे, काही प्रॉब्लेम काही वाटत नाही आहे, 2-3 सुचर घेऊन टाकतो. बट वी कॅन मिस आयदर अ फॉरेन बॉडी ऑर अ अनडिस्प्लेस हेअरलाईन क्रॅक फ्रॅक्चर. मग तो कुठेतरी दुसरीकडे जातो, तिथे ते डायग्नोज होतं अँड देन निग्लिजन्स कुणावर येतो, आपल्यावर, बिकॉज वी हॅवंट ऑर्डर द इन्व्हेस्टिगेशन. ठीक आहे. सो देर वॉज वन इंटरेस्टिंग केस बेसिकली. येस. सो दिस केस वॉज फाईल्ड इन अ डिस्ट्रिक्ट फोरम. पहिल्यांदा डिस्ट्रिक्ट फोरममध्ये केस फाईल झाली. डॉक्टरांनी डेंग्यू म्हणून एका पेशंटला डायग्नोज केलेलं. ठीक आहे. पण तो पेशंट तिथे रिस्पॉन्ड देत नव्हता, म्हणून नातेवाईकांनी पेशंट इतर हॉस्पिटलमध्ये घेऊन गेले. तिथे त्या पेशंटला मलेरिया म्हणून डायग्नोज केलं, सेरिब्रल मलेरियाची त्याला ट्रीटमेंट दिली, बट अनफॉर्च्युनेटली द पेशंट एक्सपायर्ड. आता पेशंट एक्सपायर झाल्यानंतर डिस्ट्रिक्ट फोरममध्ये जेव्हा ही केस गेली तर तेव्हा त्यांनी निर्णय दिला की इथे डॉक्टरांची चूक आहे, कारण त्यांनी प्रॉपरली डायग्नोसिस केलं नाही, म्हणून दे अवॉर्डेड ₹5 लाख ॲज अ कॉम्पेन्सेशन. त्यानंतर डॉक्टरांनी अपील केलं. इट वेंट टू द स्टेट कमिशन. स्टेट कमिशन म्हटले की येस द डॉक्टर्स आर निग्लिजंट, पण जे डिस्ट्रिक्ट फोरमने जे कॉम्पेन्सेशन अवॉर्ड केलं आहे 5 लाखाचं ते खूप जास्त आहे. सो दे रेड्यूस द कॉम्पेन्सेशन टू ₹1 लाख. त्यानंतर मग डॉक्टरांनी परत नॅशनल कमिशनमध्ये अपील केलं. तर नॅशनल कमिशननी पूर्ण केस स्टडी करून सांगितलं की मेडिसिन इज नॉट अ एक्झॅक्ट सायन्स अँड रॉंग डायग्नोसिस इज नॉट नेसेसरीली अ निग्लिजन्स ऑन द पार्ट ऑफ ट्रीटिंग डॉक्टर अँड दे डिसमिस द केस. ओके. आता काल असा मुद्दा झाला होता उपस्थित की जसं डॉक्टरांकडनं निग्लिजन्स होतं तसं डॉक्टर जसे कंझ्युमरमध्ये येतात तसे ॲडव्होकेट्स येत नाही, बरोबर ना. ठीक आहे. आता इथं या केसमध्ये खालच्या दोन्ही कोर्टांनी आपल्या अगेन्स्ट हे दिलं आहे ना, मग त्यांच्या अगेन्स्ट आपण केस करू शकतो का? तुमच्या याच्यामुळे माझ्यावर एवढा काही प्रॉब्लेम आले वगैरे नाही करू शकत, बिकॉज दे आर नॉट कवर्ड इन अंडर इट. ठीक आहे. तसंच काल अजून एक मुद्दा आला होता की जेव्हा एखादा पोलीस ऑफिसर अननेसेसरीली आपल्या अगेन्स्ट FIR फाईल करतो तर वेदर त्या पोलीस ऑफिसरच्या अगेन्स्ट आपल्याला केस फाईल करता येते का? तर आपल्याला ॲक्च्युली केस फाईल करायची गरजच नाही आहे, कारण सुप्रीम कोर्टनी जे मार्टिन एफ डिसूजामध्ये जे जजमेंट दिलेलं आहे त्यामध्ये त्यांनी अगदी क्लिअर कट स्पेशली मेन्शन केलेलं आहे की इफ द पोलीस ऑफिसर इज नॉट फॉलोईंग व्हॉट वी हॅव बेसिकली प्रोटोकॉल जो आखून दिलेला आहे तर ते ही हिमसेल्फ इज लायबल फॉर पनिशमेंट, असं त्यांनी स्पष्ट दिलेलं आहे त्याच्यामध्ये. त्यामुळे आपण फक्त त्यांना हे सांगून द्यायचं आहे की दिस इज द जजमेंट, ही त्याची कॉपी आहे आणि दे आर देमसेल्फ्स आर लायबल फॉर पनिशमेंट. ओके. सो येस, मग आता हे केस लॉस ज्यावेळेस आपल्या एखाद्या पेशंट आपल्या अगेन्स्ट ॲलिगेशन करतो अशा पद्धतीचं, तर आपण युजली त्यांना डिफीट करण्यासाठी आपल्याला हे केस लॉस माहीत असणं गरजेचं आहे. आता सेकंड जे युजली पेशंटचं ॲलिगेशन असतं दॅट इज द रॉंग ट्रीटमेंट ऑर अ मेडिकेशन एरर. मग ते कोणीतरी रॉंग मेडिकेशन प्रिस्क्राईब ऑर रॉंग डोस देण्यात आला, इनकरेक्ट ट्रीटमेंट झाली आहे, फेल्युअर टू चेक द ड्रग ॲलर्जीज ऑर मिक्सअप इन मेडिकेशन्स. ठीक आहे, होऊ शकतं. ह्युमन एरर्स यालाच म्हणतात. आणि इफ यू नो द स्टॅटिस्टिक्स, ऑलमोस्ट 5.2 मिलियन पीपल डाय ड्यू टू ह्युमन एरर्स इन इंडिया एव्हरी इयर. सो इट्स अ क्वाईट अ ह्यूज figure actually, and we are supposed to minimize those risks. So this case where in Spring Meadows Hospital it was a miscommunication between a consultant and a staff nurse. तर त्याच्यामध्ये ॲक्च्युली पेशंट ॲडमिटेड असतो, कन्सल्टंट फोनवर सांगतात की 3rd जनरेशन सिफेलोस्पोरिन इंट्राव्हिनसली द्यायचं आहे त्या बाळाला, आणि सिस्टर त्याला इंजेक्शन क्लोरोक्विन इंट्राव्हिनसली देते. सो द बेबी ही सफर्ड अ कार्डियाक अरेस्ट आणि एक्सपायर होत होतो त्याच्यामध्ये. सो इट वॉज अ मिसकम्युनिकेशन, अ रॉंग मेडिसिन वॉज गिवन टू द पेशंट अँड दॅट्स वाय ₹12.5 lakh compensation was awarded. So this was again a medical negligence. Now surgical negligence किंवा बॉस्ड अप सर्जरी, म्हणजे याच्यामध्ये सर्जरी रॉंग साईड ऑफ द बॉडी पार्ट झालं किंवा काही सर्जिकल इन्स्ट्रुमेंट सर्जरी करताना राहून गेले, डॅमेज टू नर्व ऑर्गन टिश्यूज अँड इम्प्रॉपर स्टरलायझेशन ऑफ इक्विपमेंट लिडिंग टू द इन्फेक्शन्स. मग याच्यामध्ये आता ही जी स्टेट ऑफ महाराष्ट्र व्हर्सेस डॉक्टर प्रभाकरांची जी केस होती त्याच्यामध्ये सर्जन ऑपरेटेड ऑन द रॉंग लेग ऑफ अ पेशंट रिझल्टिंग इन ॲम्प्युटेशन आणि नंतर काही कॉम्प्लिकेशन होऊन पेशंट डाईड. सो ही वॉज कन्व्हिक्टेड अंडर सेक्शन 304A IPC, द क्रिमिनल सेक्शन, अँड देन ही वॉज सेंटेन्स टू 2 years ऑफ इम्प्रिझनमेंट. ओके, आता मध्यंतरी 1.5-2 वर्षापूर्वी दिल्लीमध्ये देखील ऑर्थोपेडिक सर्जनने रॉंग अँकलवर सर्जरी केलेली. सो ही वॉज डिबार्ड फ्रॉम डुईंग द सर्जरी बाय द दिल्ली मेडिकल काउन्सिल फॉर 6 months. 6 महिन्यासाठी त्यांचं सस्पेन्शन केलेलं, त्यांचं नाव मेडिकल रजिस्टरमधनं काढून टाकलेलं. ओके, so these are the things which can go against us and we are supposed to be very careful about this. Then in Dr. R.K. Anand versus Delhi administration case, तर त्याच्यामध्ये गायनेकॉलॉजिस्टने सर्जिकल इन्स्ट्रुमेंट पेशंटचं जेव्हा सिझेरियन सेक्शन करत होते त्यावेळेस ते राहून गेलेलं. पेशंट देन सिव्हिअर कॉम्प्लिकेशन्स होऊन लेटर ऑन डाईड अँड देन द लिगल आउटकम वॉज अगेन द डॉक्टर वॉज कन्व्हिक्टेड अंडर सेक्शन 304A IPC. ओके, नो ॲनेस्थेशिया एरर्स, त्याच्यामध्ये मग युजली त्यांचं असतात की सपोज एखादा इनसाईड OT जर डेथ झाली समजा एखादी, तर त्याच्यामध्ये असतं की यांना बुलीचा ओव्हरडोसच जास्त दिला किंवा चुकीचं औषध देण्यात आलं किंवा त्यांचं मॉनिटरिंगच झालं नाही, हे सगळे प्रॉब्लेम्स किंवा हे त्याच्यामध्ये येऊ शकतात. सो इन स्टेट कंझ्युमरची जी ही केस होते इन डॉक्टर मनीष मोटवानी, तर त्यामध्ये पेशंटला एक ॲक्झिलरी ब्लॉक दिलेला असतो आणि त्यांना usually cardiac arrest at the end of surgery. So the patient was referred to other hospital but the patient expired. So this was very interesting case because या केसमध्ये as whatever the Supreme Court guidelines have given in Martineau D'Souza's case की तुम्ही कुठल्याही डॉक्टरांच्या अगेन्स्ट काही करायच्या अगोदर एक एक्सपर्ट ओपिनियन घ्यायला पाहिजे असतं. ठीक आहे, मग हे एक्सपर्ट ओपिनियनसाठी त्यांनी पाठवलं. त्याच्यामध्ये PMचा रिपोर्ट आलेला आहे, सिव्हिल सर्जनचं ओपिनियन आलं, पण दॅट वॉज नॉन कन्क्लुझिव्ह. जे हॉस्पिटलची कमिटीची एक रिपोर्ट आहे त्याच्यामध्ये त्यांनी स्पेसिफिकली मेन्शन केलं की डॉक्टर्स आर नॉट डायरेक्टली रिस्पॉन्सिबल फॉर डेथ ऑफ दिस पेशंट. ठीक आहे, सो वी आर हॅपी. ओके, बट ऑलवेज एक्सपेक्ट द अनएक्सपेक्टेड. जरी जे कमिटीचा रिपोर्ट असा असला तरी देखील अल्टिमेटली डायरेक्टर ऑफ हेल्थ सर्व्हिसेस त्यांनी एक जी त्यांची कमिटी नेमली होती या केसमध्ये, त्यांनी मात्र जो रिपोर्ट दिला त्याच्यानुसार त्यांनी ॲनेस्थेटिस्टचे जे काही त्याच्यामध्ये पिटफॉल्स काढले, लॅक्युने काढल्या, एरर्स काढले, दॅट वॉज नो प्री ॲनेस्थेटिक चेकअप वॉज डन बिफोर द डे ऑफ सर्जरी. ओके, सो वी ऑल्सो ॲज आपल्याकडे देखील तेच होतं ना, ॲनेस्थेटिस्ट डायरेक्ट पेशंटला कुठे भेटतो, इन द OTs भेटतो, परंतु वेन यू आर गोइंग टू सबमिट द डॉक्युमेंट टू समवन एल्स, तर त्यावेळेस काही गोष्टींचं आपल्याला मॉडिफिकेशन हे करून घ्यायला लागतं. ठीक आहे, ही सॉ द पेशंट ओनली इन द OT. सेन्सिटिव्हिटी टेस्ट वॉज नॉट डन फॉर द ॲनेस्थेटिक एजंट. Toxic effect of anesthetic agent are manifested in the form of convulsion or at least twitching of muscles, hypotension, cardiac arrest, but they have not been noted by the anesthetist. And patient expired on operation table itself. त्यामुळे नंतर ते तुम्ही त्याला व्हेंटिलेट केलं, इतर हॉस्पिटलला शिफ्ट केलं. दिस इज ऑल बेसिकली इट अमाउंट्स टू चिटिंग असं त्या कमिटीचं म्हणणं आलं. ओके, सो देर आर 2 committees which one has given a clean sheet to the doctors and the other committee which has basically given all these lacunae or these errors on the part of the doctor. ठीक आहे, and they have ordered 15 lakh compensation. ठीक आहे, म्हणजे आता प्रत्येक वेळेला आपला डामाडोल जो आहे तो चालूच राहतो अल्टिमेटली. दे हॅव ऑर्डर्ड द ठाणे म्युनिसिपल कॉर्पोरेशन टू टेक ॲक्शन अगेन्स्ट दॅट हॉस्पिटल अँड टू इन्फॉर्म द महाराष्ट्र मेडिकल काउन्सिल सो दॅट ॲप्रोप्रिएट ॲक्शन कॅन बी टेकन अगेन्स्ट द डॉक्टर्स. ओके, सो देन लॅक ऑफ इन्फॉर्म कन्सेंट. दिस इज the most important and crucial document in every surgical procedure, but unfortunately आपल्याकडे consent properly कधीच घेतली जात नाही. What we took, it is a printed consent, right? Maximum. The consent should be procedure specific. म्हणजे abdominal hysterectomy consent तीच laparoscopic hysterectomy चालणार नाही, कारण दोन्हीचे कॉम्प्लिकेशन्स वेगळे वेगळे आहेत. ठीक आहे, सो द कंटेंट ऑफ द सर्जरी, त्याच्याशी रिलेटेड कॉम्प्लिकेशन हे स्पेसिफिकली त्या कन्सेंटमध्ये मेन्शन करणं गरजेचं असतं अँड दॅट इज व्हेरी इम्पॉर्टंट. आणि त्याच्यामधल्या काही केस रेफरन्सेस आहे बेसिकली. सो दिस वॉज अ केस वेअर रेक्टोव्हॅजिनल फिस्च्युला वॉज डेव्हलप आफ्टर लॅप्रोस्कोपिक हिस्टेक्टमी. मग त्यामध्ये त्या जजने स्पेसिफिकली डिमार्केट केलं की या कन्सेंट फॉर्मवर हे कॉम्प्लिकेशन तुम्ही पेशंटला समजावून सांगितलेलं दिसत नाही आहे, विच इज डेफिशियन्सी ऑन युअर पार्ट बिकॉज यू हॅव नॉट एक्सप्लेन दिस कॉम्प्लिकेशन टू द पेशंट पार्टी. सो यू आर डेफिशियंट अँड दॅट्स वाय यू विल बी पेईंग ₹3 lakh ॲज अ कॉम्पेन्सेशन. ठीक आहे, देन स्टरलायझेशन फेल्युअर इज नॉट डॉक्टर्स फॉल्ट. आता या केसमध्ये तर ट्युबल लायगेशन झाल्यानंतर ती पेशंट परत प्रेग्नंट राहते. प्रेग्नंट राहिल्यानंतर ती कंप्लेंट करते की माझं जे बाळ जन्मणार आहे त्याचा आयुष्यभराचा सगळा खर्च त्या डॉक्टरांनीच करावा म्हणून. ठीक आहे, बिकॉज इट इज हिज फॉल्ट की जे काय आहे ते. बट द कन्सेंट विच हॅज बीन टेकन बाय द डॉक्टर, इट हॅज स्पेसिफिकली मेन्शन दॅट इट इज नॉट अ 100% फुल प्रूफ सर्जरी, आणि तुम्ही कधीही भविष्यात प्रेग्नंट राहू शकतात. मग जर तुमची मासिक पाळी नाही आली तर इट इज युअर ड्युटी टू इन्फॉर्म इट टू द डॉक्टर्स अँड गेट इट चेक. सो इट सेव्ड हिज स्किन फ्रॉम द ॲलिगेशन्स, आणि मग त्यांनी ती केस डिसमिस करून टाकली. ओके. सो निग्लिजन्स ड्युरिंग चाइल्ड बर्थ और डिलिव्हरी एरर्स बऱ्याचशा होतात त्याच्यामध्ये, आणि इम्प्रॉपर हँडलिंग ऑफ डिलिव्हरी किंवा मग डॉक्टरच ॲबसेंट असणं, फेल्युअर टू डिटेक्ट फिटल डिस्ट्रेस वगैरे हे सगळे प्रॉब्लेम्स येतात त्याच्यामध्ये. दिस वॉज अ केस फ्रॉम मुंबई वेअर द डॉक्टर वॉज बेसिकली, आपल्या बऱ्याच वेळेला घर बाजूला हॉस्पिटल बाजूला, तर डॉक्टर जेवायला घरी जातात आणि तेवढ्या वेळात ती पेशंट डिलिव्हर होऊन जाते. अनफॉर्च्युनेटली स्टील बर्थ होतं, बेबी डाईड. सो द कोर्ट हॅज मेन्शन दॅट जेव्हा तुम्ही कुठलाही पेशंट ॲडमिट करता तर 24 आवर त्याला सर्व्हिस देणं, इट इज द रिस्पॉन्सिबिलिटी ऑफ द डॉक्टर्स, अँड ॲज यू आर ॲबसेंट ड्युरिंग द डिलिव्हरी ऑफ द बेबी इट अमाऊंट्स टू द निग्लिजन्स, अँड दॅट्स वाय त्यांनी 19 लाख रुपयाचं कॉम्पेन्सेशन त्याच्यामध्ये त्यांना देण्यास वर्डिक्ट दिलेलं आहे. सो हॉस्पिटल ॲक्वायर्ड इन्फेक्शन, पुअर हायजीन, मग हॉस्पिटल रिलेटेड काही केसेस झाल्या तर त्याच्यामध्ये देखील ॲज अ हॉस्पिटल मग त्यासाठी आपल्याला इंडेम्निटी इन्शुरन्स काढायची गरज पडते. सो दिस वॉज मिस्टर एम रमेश रेड्डीज केस, ज्याच्यामध्ये पेशंट फॉर गायनॅक कंप्लेंट्स ॲडमिट असते, पण ती बाथरूममध्ये पडते आणि नंतर इट वॉज डिस्कवर्ड दॅट देअर वॉज अ बेसिकली फंगस ग्रोन, आणि त्याच्यामुळे तिला हेड इंजुरी होऊन ते एक्सपायर होते. सो द हॉस्पिटल वॉज हेल्ड लायबल फॉर हर डेथ. ओके. निग्लिजन्स इन इमर्जन्सी केसेस, ओके. इन ग्रेवाल हॉस्पिटल, याच्यामध्ये डॉक्टरांनी काय सांगितलं ना की पेशंटला ट्रीटमेंट देताना हॉस्पिटलची काहीही चुकी नाही आहे, त्यांचं काहीही निग्लिजन्स नाही आहे, बट द हॉस्पिटल ॲडमिनिस्ट्रेशन दे फेल्ड टू प्रूव्ह टू द कोर्ट दॅट दे हॅव टेकन द एफर्ट्स टू अरेंज द ॲम्ब्युलन्स इन अ टाइमली मॅनर. त्यांनी कोणाला फोन नाही केला, त्यांची ॲम्ब्युलन्स इतर पेशंटला घेऊन कुठेतरी गेली होती, म्हणून हा दुसरीकडनं कुठनं ॲम्ब्युलन्स त्यांनी बोलवण्याचं इथं कुठेही आम्हाला दिसत नाही आहे, अँड दॅट्स वाय द हॉस्पिटल वॉज हेल्ड निग्लिजंट. ठीक आहे. सो आपण ज्या ज्या गोष्टी करतोय ना पेशंटच्या हितासाठी, इट इज आवर ड्युटी टू रेकॉर्ड इट इन द पेपर सो दॅट वी कॅन प्रूव्ह इट टू एनी कोर्ट ऑफ लॉ. ओके. सो वी विल, किती मिनिट राहिले माझे, झालेत? ओके, फाईन. सो एक बेसिकली आय जस्ट वॉन्ट टू हायलाईट ऑन द न्यू, एक 2-3 स्लाईड त्याच्यावर सांगतो. हाऊ लॉंग टू कीप रेकॉर्ड्स, बेसिकली देर आर व्हेरियस रूल्स रेग्युलेशन्स. हे रेकॉर्ड्स किती दिवसांपर्यंत धरायचे, तर व्हॉट वी फॉलो इज द मेडिकल काउन्सिल गाईडलाईन्स विच बेसिकली शोज सिव्हिल लिमिटेशन्स कुठल्याही असतील. नॉन मेडिको लिगल केसेस वी आर सपोज टू कीप देम फॉर 3 years, आणि बाकीचे क्रिमिनल केसेस असतील तर जोपर्यंत आपण वर जात नाही तोपर्यंत त्या सांभाळायच्या. ठीक आहे. मग बाकीचे अदर रूल्स रेग्युलेशन्स आहेत, दॅट इज ओके. आणि कुठल्याही पेशंट ज्यावेळेस आपल्याकडे डॉक्युमेंटसाठी रिटर्न ॲप्लिकेशन करतो तर बाय लॉ वी आर सपोज टू प्रोव्हाइड हिम द डॉक्युमेंट्स विदिन अ पिरियड ऑफ 72 hours. नाउ कमिंग टू द सर्टिफिकेट, दिस इज व्हेरी इम्पॉर्टंट. जेव्हा आपण कुठलंही मेडिकल सर्टिफिकेट देतो पेशंटला तर त्याच्यामध्ये काही ज्या गोष्टी आहेत which should not be omitted to record on the certificate itself. So first is basically signature and or thumb mark of the patient, address of the patient, and at least one identification mark. तर या गोष्टी आहेत या आपल्याला कंपल्सरी. आपण बऱ्याच वेळेला काय करतो, एक फॉर्मॅट आहे, हां तो पेशंट माझ्याकडे आला आहे आणि त्याला देऊन टाकतो. नो, बट यू हॅव टू ॲटलिस्ट टेक अ थंब इम्प्रेशन अँड ॲड्रेस अँड वन आयडेंटिफिकेशन मार्क. ओके. दिस वॉज अ GR बाय महाराष्ट्र गव्हर्नमेंट. त्याच्यामध्ये त्यांनी इंडोर केस पेपर जे आहेत ते 5 वर्षापर्यंत सांगितलेत. मेडिको लिगलचे केसेस 30 years अँड OPD पेपर्स फॉर 3 years. ओके. नाउ दिस वॉज वन महाराष्ट्र मध्य प्रदेश मेडिकल काउन्सिल. सो द काउन्सिल हॅज ऑल्सो द ऑथॉरिटीज, बिकॉज ही जी डॉक्टर सीमा आहे दे डिडंट हँड ओव्हर द डॉक्युमेंट्स टू द पेशंट विदिन अ स्पेक्युलेटेड टाईम. सो दे बेसिकली रिमूव्ड हर नेम और सस्पेंडेड हर फॉर 1 year फ्रॉम डुईंग द ड्युटी. ओके. तर त्यांनी रजिस्टरमधनं त्यांचं नाव काढून टाकलेलं. ठीक आहे. सो बेसिकली दिस इज अगेन्स्ट द रूल्स अँड रेग्युलेशन्स ऑफ द लेट डाऊन बाय आवर ओन काउन्सिल. त्याच्यामुळे त्यांच्या विरोधात जर काही केलं तर येस, द काउन्सिल हॅज द ऑथॉरिटी टू टेक ॲक्शन अगेन्स्ट अस. आता काल जी आपण एक चर्चा करत होतो की आता मागचा जो आपला IPC सेक्शन होता, इट हॅज बीन चेंज टू दी BNS, भारतीय न्याय संहिता. याच्यामध्ये विच इज मोर हार्मफुल टू अस इज धिस सेक्शन, दॅट इज सेक्शन 304A. ठीक आहे. जो आधी होता, आधीच्या याच्यामध्ये काय होतं ना प्रोव्हिजन, की जर सपोज डॉक्टरला निग्लिजंट ठरवण्यात आलं तर व्हॉट वॉज द पनिशमेंट, आयदर अ जेल टर्म अप टू 2 years ऑर फाईन होतं त्याच्यामध्ये. ठीक आहे. सो धिस ऑर आता गेलाय तो, आता हा कंपल्सरी, म्हणजे द ऑप्शन होता तिकडे आधी, आता तो कंपल्शन झाला या BNS सेक्शन 1061 मध्ये. तर त्याच्यामध्ये इफ द डॉक्टर इज हेल्ड निग्लिजंट देन ही हॅज टू बी गिवन वर्डिक्ट ऑफ इम्प्रिझनमेंट ऑफ आयदर डिस्ट्रिब्युशन फॉर अ टर्म विच मे एक्सटेंड टू 2 years अँड फाईन. ओके, म्हणजे इम्प्रिझनमेंट हे पक्क झालं आहे. ओके, 1 दिवस का होईना किंवा ते जजच्या मनावर आहे जे काय असेल ते, पण इम्प्रिझनमेंट हे जे पक्क झालेलं आहे याच्यामध्ये. ठीक आहे, सो दिस इज नॉट इन आवर फेवर. आणि हे जे 2 महत्त्वाचे, आता जो आपला CPA जो 1986 मध्ये लागू झाला आणि जो 2019 मध्ये त्याच्यामध्ये ज्या अमेंडमेंट आल्यात, तर त्याच्यामध्ये काही मेजर चेंजेस झालेत. मग एक फायलिंग ज्युरिडिक्शनमध्ये काय आहे की आजच्या डेटला जर सपोज एखादा कुठलाही बिहारचा किंवा इतर कुठलाही ठिकाणी राहणारा जर तो आपल्याकडे ट्रीटमेंट घेतलं, तर ही हॅज द राईट टू फाईल अ कंप्लेंट ॲट हिज ओन रेसिडेन्स. म्हणजे तो तिथे जाऊन आपल्या अगेन्स्ट कंप्लेंट फाईल करू शकतो. आणि मग आता आपली ड्युटी बनते की आपण तिथे जाऊन केस लढायची. ठीक आहे. सो ॲज अ अपेक्स इन्शुरन्स कन्सल्टंट मेंबर दे प्रोव्हाइड सर्व्हिसेस पॅन इंडिया, तो इश्यू नाही. बट दिस इज व्हेरी इम्पॉर्टंट. सेकंड थिंग, पेक्युनरी ज्युरिडिक्शन जे होतं ना, इट्स अ 3-tier सिस्टीम. डिस्ट्रिक्ट फोरम, स्टेट कमिशन, नॅशनल कमिशन. आधीचं जे होतं तर ते ज्युरिडिक्शन होतं 20 lakhs to 1 CR आणि मोर दॅन 1 CR ॲट नॅशनल कमिशन. आता अप टू 1 CR ॲट डिस्ट्रिक्ट फोरम, 1 to 10 CR ॲट स्टेट कमिशन अँड मोर दॅन 10 CR ॲट द नॅशनल कमिशन. म्हणून आता मॅक्झिमम ज्या केसेस आहेत ना, त्या डिस्ट्रिक्ट फोरमलाच काय होणार, सबमिट होणार. कारण अप टू 1 CR आहे ना. पेशंट जे काही पार्टी कुठलीही हे करेल तर डायरेक्टली वरच्या लेवलला मोस्टली कोणी जाणार नाही आहे मॅक्झिमम केसेस. आणि विथ दिस नंबर ऑफ ऑलरेडी पेंडिंग केसेस ज्या आधीच आहेत, त्याच्यामध्ये अजून किती भर होईल डिस्ट्रिक्ट फोरमच्या याच्यामध्ये, अँड मग ते कसं निर्णय देतील हे त्यांनाच माहिती. आता ते अजून तिसरा जो पॉईंट याच्यामध्ये जो आपल्या अगेन्स्टमध्ये गेला आहे ना, दॅट इज अ अपील डिपॉझिट. आधीच्या वेळेसचा जो काही कायदा होता त्याच्याप्रमाणे काय होतं की जेव्हा आपण डिस्ट्रिक्ट फोरममधनं स्टेट किंवा स्टेटमधनं जेव्हा नॅशनलमध्ये आपण अपील करतो, तर आपल्याला सपोज डिस्ट्रिक्ट फोरमने 5 लाख रुपये कॉम्पन्सेशन ऑर्डर केली आहे. ठीक आहे, तर त्याचे 50% किती होतात, 2.5 लाख रुपये किंवा 25,000. यातली जी कमीत कमी अमाऊंट असेल तेवढी भरून तुम्ही अपील करू शकत होता. आता हा जो आहे हा क्लॉज त्यांनी काढला आहे. त्यांनी स्टेट हवे सांगितलं आहे की जी 50% ऑफ अमाऊंट ऑफ कॉम्पन्सेशन आधी तुम्ही डिपॉझिट करा. मग जर डिस्ट्रिक्ट फोरमने आपल्या अगेन्स्ट कॉम्पन्सेशन ऑर्डर केलं आहे 20 लाख रुपये, तर आधी आपल्याला 10 लाख रुपये कंपल्सरी भरायला लागणार, तरच आपल्याला स्टेट कमिशनमध्ये अपील करता येईल. ओके, सो दिस इज अगेन अगेन्स्ट द डॉक्टर. म्हणजे आधी 25,000 भरून कमीत कमी वी कुड हॅव इझिली अप्लाइड फॉर द अपील. आणि मेडिएशनचा जो अवेलेबल नव्हता, सो नाऊ दे हॅव मेक इट बेसिकली अवेलेबल इन दिस अमेंडमेंट. की मेडिएशन म्हणजे बेसिकली कुठल्याही थर्ड पार्टीकडनं यू कॅन हॅव अ मेडिएटर अँड यू कॅन डिसाईड की ठीक आहे आम्ही दोघं जणं एका समझोत्यासाठी तयार आहोत. आय विल बेसिकली एवढे पैसे देऊन किंवा हे जे करून द कोर्ट विल पास अ डिग्री अँड देन येस वी विल हॅव अ प्रॉपर मेडिएशन थ्रू दॅट. आणि एकदा मेडिएशन थ्रू जेव्हा ही केस डिस्पोज ऑफ होते कोर्टाकडनंच, तर दॅट पेशंट पार्टी विल नेवर बी एबल टू फाईल एनी केस रिगार्डिंग दिस मॅटर अगेन्स्ट द डॉक्टर टू एनी ऑफ द कोर्ट्स इन फ्युचर. ठीक आहे, सो दिस इज अ गुड in favor of us. So I have tried to given a very broad this thing about the medical negligence case. So do the things as a matter of habit and not out of fear or law. कायदा हा आपल्यासाठी आहे, त्याला घाबरण्याची काही गरज नाही आहे absolutely. But yes, we have to be very careful when we are dealing with all the medical legal cases. कारण आत्तापर्यंतचं जे हायेस्ट कॉम्पन्सेशन देण्यात आलं, एक ओव्हरडोस ऑफ स्टिरॉइड देण्यात आला होता आणि त्याच्यामुळे जी कलकत्ता अंबरी हॉस्पिटलची केस झाली त्याच्यामध्ये आत्तापर्यंतचं हायेस्ट कॉम्पन्सेशन दॅट इज 5.6 करोड अलॉंग विथ द इंटरेस्ट इट कम्स टू अराउंड मोर दॅन 11 करोड हे त्या केसमध्ये देण्यात आलं होतं. सो वी डोंट वॉन्ट टू गो इन टू एनी ऑफ दिस अननेसेसरीली. हे सगळं खूप प्रॉब्लेमॅटिक आहे. आणि येस वी आर ट्राईंग टू बेसिकली ॲज सेफ ॲज आपली प्रॅक्टिस करण्याचा आपण प्रयत्न करत आहोत. बट स्टील द नंबर ऑफ केसेस किंवा ॲलिगेशन्स हे वाढतच जातील. अँड येस, सो thank you very much for giving me an opportunity and thank you for giving extended time for my talk. I have many more slides also, but that is not possible to cover in this short this thing. So I thank you IMA for giving me an opportunity to share my thoughts with you all. And if there are any questions or any something which we would like to highlight on any specific topic, तो वो भी कर सकते हैं. Yes sir. येस, जर सपोज तुमच्याकडे काही पेशंट ॲडमिटेड नाही आहे तर तुम्ही बंद करून जाऊ शकता, दॅट इज ओके. बट प्रायरली तुम्हाला फक्त नोटीस तिथे लावायची आहे की 7 दिवस तुम्ही अवेलेबल नाही आहे. असं काही त्याच्याकडे कुठं स्पेसिफिक मेन्शन नाही की किती दिवस आधी तुम्ही 1 दिवस 2 दिवस जरी लावले, बिकॉज देर आर नो पेशंट ॲडमिटेड, पण तुमच्या OPD पेशंटला काही प्रॉब्लेम होऊ नये म्हणून तुम्ही एक 8-10 दिवस करू शकतात ना. येस, द ओनली थिंग इज दॅट त्यांचं काय म्हणणं असतं की जेव्हा तुम्ही कुठलाही पेशंट डायव्हर्ट करतात किंवा तुमच्याच हॉस्पिटलमध्ये पेशंट ॲडमिट आहे आणि तो तुम्ही कुठेतरी जाणार आहात सुट्टीवर, तो यू हॅव टू हां पाठवू शकता ना तुम्ही. येस येस नाही, आता कसं आहे ना, बाहेर ऑलरेडी डिलिव्हर झाला आहे पेशंट. हां नाही, बट दॅट इज ओके, कारण कसं आहे ना, डिलिव्हरीच्या याच्यामध्ये म्हणजे त्या पिरियडमध्ये येणं किंवा हे यू विल नेवर बी हेल्ड लायबल जस्ट बिकॉज ही इज युअर रजिस्टर पेशंट. सो ॲट दॅट टाईम वॉट वी बेसिकली ॲडवाईज इज, जेव्हा तुम्ही एखादा पेशंट तुमच्याकडे रजिस्टर होतो ॲज अ ANC पेशंट, यू टेक अ कन्सेंट ॲट द सेम, पहिल्याच व्हिजिटला कन्सेंट घेऊन टाका की ठीक आहे तुम्ही आमचे ANC पेशंट आहात, बट कुठल्या कारणास्तव सपोज जर तुम्हाला आमच्या सर्व्हिसेस अवेलेबल नाही झालू शकल्या तर हे 2-4 नंबर आहेत तुमच्या मित्रांचे, देऊन ठेवा. यू कॅन कॉन्टॅक्ट देम ॲट एनी टाईम. ओके.
आता ANC बाकीचे फिवरचे वगैरे पेशंट येतात आमच्याकडे, तर आम्ही त्याला ट्रीटमेंट देऊ शकतो का क्रॉस पॅथीमध्ये जाऊ शकतो?
नाही, क्रॉस पॅथीमध्ये जाण्याचं काय नाही, बिकॉज यू हॅव होल चॅप्टर रिगार्डिंग हायपरटेन्शन इन ॲनेस्थेशिया, सॉरी इन प्रेग्नन्सी किंवा फिवर इन प्रेग्नन्सी. तुमच्या टेक्स्टबुकमध्ये ऑलरेडी हे सगळं कवर्ड आहे अल्टिमेटली. सो यू कॅन give the treatment. The only thing is that you should not miss some crucial points while dealing with the patient, which might lead to a delayed diagnosis, which might affect the health of the mother or the baby. ठीक आहे. सो त्या केसमध्ये मग ते हे प्रूव्ह करू शकतात की बेसिकली तुम्ही प्रॉपरली डायग्नोसिस केलं नाही आणि त्याच्यामुळे आमच्या पेशंटला किंवा बाळाला त्रास झाला म्हणून. सो यू कॅन ट्रीट, दॅट्स ओके.
चेस्ट पेनचा पेशंट आला तर आम्ही त्याला चेक करून रिफर करणं अपेक्षित का प्रायमरी मॅनेजमेंट द्यायला?
सी, आता अजून आपल्याकडे क्लिनिकल एस्टॅब्लिशमेंट ॲक्ट आलेला नाही आहे, ठीक आहे, लागू झालेला नाही आहे. तो जेव्हा लागू होईल इट हॅज अ व्हेरी क्लिअर कट मेन्शन. सर यू वॉन्ट टू टेल? येस, अरंकर सर आहेत ते ही इज. येस सर, थँक्यू सर. येस सर, शुअर, नो प्रॉब्लेम. येस, थँक्यू. सो बेसिकली अजून क्लिनिकल एस्टॅब्लिशमेंट ॲक्ट लागू झालेला नाही आहे, पण त्या क्लिनिकल एस्टॅब्लिशमेंट ॲक्टमध्ये व्हेरी क्लिअर कटली दे हॅव मेन्शन की यू शूड नॉट रिफ्यूज अ इमर्जन्सी पेशंट. सो आय एम टेलिंग यू, जेव्हा इमर्जन्सी, तुम्ही गायनेकॉलॉजिस्ट आहे किंवा मी ऑर्थोपेडिशियन आहे, माझ्याकडे चेस्ट पेनचं येईल किंवा तुमच्याकडे चेस्ट पेनचं येईल. सो व्हॉट दे से की ॲटलिस्ट यू एक्झामिन द पेशंट, you check his basically vitals, you see to it whether the patient is stable or not from hemodynamical point of view. ठीक आहे. किंवा आता माझ्याकडे सपोज एखादी प्रेग्नंट जरी आली, समजा एक 8 महिन्याची प्रेग्नन्सी आहे, ती आली आहे वॉट एव्हर फॉर चक्कर येते किंवा काय, सो आय एम सपोज टू ॲटलीस्ट चेक हर पल्स, BP. सपोज BP कमी लागत असेल तर मी कमीत कमी एक तिला IV लाईन सिक्युअर करणं, अँड देन डिपेंडिंग ऑन द इन्फ्रास्ट्रक्चर, मॅन पॉवर अवेलेबल और सर्व्हिसेस अवेलेबल ॲट युअर प्लेस, आयदर यू कॅन ॲडमिट और यू कॅन शिफ्ट द पेशंट. चेक करून जर त्याचे व्हायटल्स वगैरे स्टेबल असतील तर दॅट इज ऑल राईट. काय हां ठीक आहे, तुम्ही रेफर करू शकतात. फक्त तो मिड व्हाईल म्हणजे तुमच्या इथनं जवळचा कोण जो आहे त्याच्याकडे जाईपर्यंत जर एक्सपायर झाला तर मग प्रॉब्लेम येतात आपले, की तुम्ही त्याला एकटंच सोडून दिलं किंवा तुम्ही त्याला बरोबर ट्रान्सफर नाही केलं. सो व्हेन एव्हर वी शिफ्ट एनी पेशंट फ्रॉम आवर इन्स्टिट्यूट टू एनी अदर इन्स्टिट्यूट, what is taken into consideration is कि you have shifted the patient and ते shift करताना तुम्ही एक RMO registered medical practitioner should accompany the patient and you should have at least an emergency tray available with you. ठीक आहे, probably in an ambulance, because जर त्याला काही द्यायचं झालं तर at least that registered RMO किंवा जो कोणी medical officer असेल तर he should give it. नाही करू शकत तो, because whatever you do in a good faith to save the life of the patient, he will not be able to do, because we will be त्याच्यामध्ये डिफेन्सेस खूप आहेत आपल्या साईडला. सो इवन यू कॅन ऑपरेट द पेशंट विदाउट अ कन्सेंट इन अन इमर्जन्सी, सो दॅट इज ऑल्सो ओके. ओके, तर लॉने आपल्याला तो अधिकार दिलेला आहे. वी हॅव स्पेसिफिक सेक्शन्स अकॉर्डिंग टू डॅक, सेक्शन 87 to 92, ज्याच्या अंडर तुम्ही पेशंट अगदीच डायर इमर्जन्सी आहे, कोणी कन्सेंटला नाही आहे, you can go ahead and do the surgery. We will just prove in a court of law that whatever you have done is basically in a good faith to save the life of the patient.
Thank you, Dr. Yes. Thank you, Dr. Nitin.
Thank you very much.
As a member of IMA Indapur and as a faculty, Now may I request Dr. Shelke sir to felicitate Dr. Nitin Londe sir. Next, our next speaker, Dr. Sumit Saxena sir, cosmetic and plastic surgeon from Pune. Please welcome. Sir has done MBBS and MS General Surgery from GMC Nagpur, MCH Plastic Surgery, Ahmedabad Gold Medalist, owner of Glam X Aesthetic Center Pune, associated with Ruby, Sahyadri, Inamdar, Jahangir, etc. Works in Leprosy Hospital Pune on honorary basis, loves drawing, painting, traveling, world and foodie. Active lawn tennis player and runner. Fields of interest, cosmetic surgery, microvascular surgery. Sir, please proceed. Thank you.
Good evening, everyone. I think this is one of the last lectures, so I'll not bore you for long and try to finish off as early as possible. So, today we are going to talk something about plastic surgery. आता 20 मिनिटांमध्ये plastic surgery कसं cover करायचं ते मला गोंधळ होता. But let us try and try to at least rule out some misconceptions, some myths, and get some facts clear. So first of all thing is that सगळ्यांना वाटतं plastic surgery म्हणजे खूपच expensive झाला. Actually not. It is now becoming more affordable. Day by day plastic surgery is becoming more affordable within the reach of the people, and most of the people are wanting to do some or the other kind of a plastic surgery thing. Now there are some misconceptions, there are some problems with the plastic surgery. So the first thing is the expensive thing. Then people always assume plastic surgery kiya matlab there is no scar. That is not like that. There is always a scar. Plastic surgery ultimately is going to give you a scar, but a better scar. Now there's also that every plastic surgery means involving from skin, and the basic question is there a plastic involved? No, there is no plastic involved. The plastic surgery has its origination from the word plasticose, which means mold. Plasticला आपण fold करू शकतो, तसंच plastic surgery म्हणजे कोणत्याही भागाला fold करणं, त्याला एक shape देणं, त्याला एक आकार देणं. So that is plastic surgery. It is not covered under insurance. No. Plastic surgery असं नाही आहे की सगळे procedures plastic insurance मध्ये cover नाही होत. Only purely cosmetic surgery is not covered under insurance. Rest all the procedures are covered under insurance. Patients comes with a trust. So plastic surgery la फक्त cosmetic surgery see associate करू नये. There are multiple of procedures which can be done. So patients come with a trust. We need to give them back. There are social things, there are social responsibilities, and there are plenty of things where the plastic surgery is involved beyond the cosmetic surgery. So you can see still a 80-year-old female which is still having a cleft palate. Ignorance, especially in these smaller towns, is still there. We see these kind of patients still. We are talking of 2025 where everything is developed, we are digitally modified, but still I see these kind of patients on a regular basis. At this age, I can see this kind of patient. Just this patient was seen few years back, just 1 or 2 years back. Can you imagine still these patients are left untreated? So a lot of social responsibility is left over. So basically, I am trying to give you an overview of what a plastic surgeon can do and what all the cases are to be referred primarily to plastic surgery. So not only these congenital deformities like cleft lip, cleft palate, the ear reconstructions, the syndactyles where the fingers are joined together. Plastic surgeon has been involved in plenty of procedures. We have been associated with leprosy reconstructions, we have been associated with smile train, we have been associated with Muskan projects. I have personally been involved in all of these projects in one or the other way around, and I have been trying to actively take this into the social forums. So when we speak of plastic surgery, especially in the smaller towns, we should get into notice that plastic surgeons are there to help the patient out there. You refer the patients, we can even manage them at a less expensive setup, at a free of cost places, at places where these things can be managed and still can be given life to the patients. Now a very I will probably target few of my challenging cases what I had faced. Now this child was 10 days old when a mongoose has eaten his mouth. You can imagine what is the thing. Now imagine what a plastic surgeon, abhi we are talking of trauma, but trauma and aesthetic are linked together. Imagine, आता ट्रॉमा आहे, पेशंटला मंगूसने खाल्ला आहे, पण आता आपल्याला काय बघायचं आहे, ही इज गोइंग टू ग्रो ओल्ड. My reconstruction, my thought process starts what to do in this 10 days old child, so that when he is 18 years of old, then how he should look. So my preparation starts when he is 10 days old. Ata asil te trauma, asil te cosmetic surgery, but what I am looking at? I am looking at aesthetic procedure after when the child is 18 years old. I must have done 25 surgeries to this patient, all free of cost to this patient, sometimes at my place, sometimes when he is too small, I cannot manage, I can do it at institutes. This was the latest surgery done just 3 days back. He was a donor, he gave us 75,000 rupees only. I said, I will manage. I will fund his medications, the hospital, because this time I could not manage to do it at my clinic because it was a big case. He required a complicated intubation and other places. So I did it at an institute. I managed in the same budget. No surgeon charges, no anesthesia charges. Jitna ho sakta utna best possibly karke do. So you see, plastic surgery is not just a simple thing where I do trauma, where I do cosmetic surgery. The process is intermingled. आपण जर विचार केला तर ट्रॉमा मध्ये एस्थेटिक आहे आणि एस्थेटिक मध्ये ट्रॉमा झाला तर बाबा हे तर वेगळीच गोष्ट आहे. मग मेडिको लिगलच लागणार आपल्याला. एनी केस, सो यू सी, आता हे बर्न्सची पेशंट आहे. तो आपण कसं बघणार, व्हॉट विल शी चाइल्ड डू. शी यूज टू ऑलवेज रोम अराउंड विथ हर फेस कवर्ड टू दिस एक्सटेंट वेअर शी गॉट मॅरिड. सो आता आपण बघणार ते पोस्ट बर्न कॉन्ट्रॅक्चर आहे. बट व्हॉट आर यू लुकिंग ॲट राईट नाव, अ गर्ल टू अ मॅरेज. तर हे बर्न्स आहे की एस्थेटिक आहे. अब there is nothing like burns or aesthetic, they are all together. You understand, plastic surgery, you have to raise your imagination, you have to think good for your patient. तुम्ही जर बघितलं की प्लास्टिक सर्जन काय करू शकतं, तर प्लास्टिक सर्जन सर्जरी करू शकतो. त्याला इन्शुरन्स, त्याला कॉस्मेटिक, त्याला ट्रॉमामध्ये टाकू नये. You think in a broad term, what I can do for the patient. The number of surgeries, the number of things are not important. 3 or 4 years from this position to her marriage, she is still married, she will still touch in with me. त्याला इंग्लिश येत नाही, ते हिंदीमध्येच करते, पण लग्न झालं आहे, she is happy, she is having a child and she is very happy. आता झाला होता सुरू पोस्ट बर्न कॉन्ट्रॅक्चरने, हेअर ट्रान्सप्लांट पण केला आयब्रोसाठी, केमिकल पील केले, लेझर्स केले, सगळं काही केलं. Okay, so plastic surgery has got a wide variety, it has got a wide perspective, and we should look into plastic surgery as a whole unit. It should not be just looked into, divided into trauma, aesthetic, micro, nothing like that. It's a whole soul thing where each and every procedure is involved to make you a complete plastic surgeon. तर बर्न्स बघितलं तर कॅन्सरमध्ये पण प्लास्टिक सर्जनचा रोल आहे. इकडे नाकच नाही आहे, वी हॅव गिवन अ एस्थेटिक अपियरन्स टू द पेशंट. सो नाव डेज कॅन्सर रिकन्स्ट्रक्शन डज नॉट लिमिट ओनली टू द रिकन्स्ट्रक्शन की बाबा नाक कापली तर त्याला काहीतरी एक फ्लॅपने चिटकून द्या. यू हॅव टू लुक इन टू द एस्थेटिक पोर्शन की पेशंट बाहेर जाणार आहे ते कसं दिसणार आहे. दिस इज द पेशंट्स फोटोग्राफ आफ्टर जस्ट 10-15 days, आफ्टर मे बी अ मंथ or 2 months time. So but see the patient again after 3 years, 6 years, she would be amazingly great. आता हे माणूस बघा, स्क्रॉटम कुठे होता, अँकलपर्यंत स्क्रॉटम पोचत होता. आता प्रॉब्लेम हे नाही आहे की आपल्याला फक्त स्क्रॉटम कापायचा आहे. प्रॉब्लेम कसा आहे, त्याला इरेक्शन पण पाहिजे, त्याच्या टेस्टिस पण मेंटेन करायचं आहे. आता मी तुम्हाला फोटोग्राफ दाखवला असतं तर टेस्टिस लटकून बसली होती अँकलपर्यंत. But we were able to give him a normal life, we were able to give him a normal reconstruction, we were able to save his testes, we were able to save him things. This lady for so many years was looking with only one eye. Ptosis correction, local anesthesia मध्ये अर्धा तास मध्ये सर्जरी प्रोसिजर केली. See how different she is. So plastic surgery encompasses a lot thing. Bed sore, आता तुम्ही बेड सोर असेल, प्रिव्हेंशन पासून क्युरेटिव्ह पासून आपण काय करतो, ड्रेसिंग लावा, चालू ठेवा 3 महिना 4 महिना ड्रेसिंग चालू आहे. Forget that. Refer to a proper consultant. 20 days patient is wound free. 1 month patient is wound free. कशासाठी महिना वॅक लावायचा, कशासाठी महिनाभर ड्रेसिंग करायची. Get a proper consultation done. He will make a difference to the patients. So what it is, Marcus Aurelius has said, everything we hear is an opinion but not a fact. So everything we see is a perspective but not the truth. This has got a very wide meaning. Okay, someday if you look into this sentence again and again, you will realize there are so many different things how we look into the world and how do we actually should be treating care of it. I will now mention few more cases which are more important for these kind of places where the facilities are not there, but you should understand that these things can be done. All of these cases which I am showing to you are personally my own. They have not been taken from internet. They are wholesale my own, and I have done all of these procedures myself. I don't have a team. I do have junior consultant who work with me. Junior consultant, not plastic surgeons, but some residents who have been working with me, but it's my team, and I do most of my cases alone. Thumb reimplantation, even at distal level, it is possible. Hand, bilateral hand, right hand, left hand, both has been cut, both have been reconstructed, and he is working. You can see he is lifting his mobile, he is using his mobile. It is just 1 year right now. He still requires some tendon transfers, he still requires the nerves to recover. Sometimes nerve may recover well, sometimes the nerve may not recover well, but he is able to do things. He is able to lift bottle, he is able to do his daily work, which is a good hand. दोनों हाथ काट के लाया है बंदा, left and right hand both. This is left hand, this is right hand. दोनों काट के लाया, we have been able to reimplant. So these things are also possible. Finger, इतना गंदा क्रश भी रहेगा तो भी किया है. ये नगर का पेशेंट है. We have been able to do this. So all these things are possible these days. Even amputation at this level, although अभी मुझे इस लेवल पे करने में बहुत मज़ा नहीं आता क्योंकि brachial plexus इंजरी होती है तो रिकवरी करने के बाद में भी काम नहीं करता. But see, it is still possible. Someday we will be able to find a solution in between these. So all these patients we can do. Even distal level, कुठे आहे एक डिस्टल फॅलिंग्स लेवलवर आहे, बट यू शुड हॅव दॅट डेडिकेशन टू डू दिस जॉब अँड इट कॅन ऑल बी मॅनेज. अँड प्लीज ट्रस्ट मी, डोंट ट्राय टू फोर्स दिस थिंग्स टू बी डन ॲट एनी हॉस्पिटल. तुम्ही म्हणणार रस्त्यामध्ये कुठेतरी हॉस्पिटल आहे, नो, यू रिक्वायर, सी, अंडरस्टँड वन थिंग, द सर्जन रिक्वायर्स हिज कम्फर्ट, द सर्जन रिक्वायर्स हिज टीम, द सर्जन रिक्वायर द बेस्ट ऑफ द इक्विपमेंट, अँड द सर्जन रिक्वायर्स टू बी ॲट पीस. देन ओनली ॲट दिस लेवल ऑफ थिंग ही कॅन गिव्ह यू रिझल्ट्स. कुठेतरी गेले, सूचर नाही आहे, 8010 नाही आहे, मग सिस्टरला काही माहिती नाही, दॅट डज नॉट वर्क आउट. That does not work out. Especially with reimplantations and microvascular surgery, it does not work out. So even penile reimplantation, the bobitization, all of this is possible. Patient पाठवताना एकच लक्ष घ्या, आपण काय करतो, आईसमध्ये टाकून देतो, तसं नाही करायचं. त्याला एक ओला गॉजमध्ये, गॉज नाही भेटला तर रुमालमध्ये, ओला रुमालमध्ये फेकाय. जर तुम्ही पाणीमध्ये टाकणार ते मॅसेट होऊन जाणार, तुम्ही डायरेक्टली आईसमध्ये टाकणार ते बोटाला फ्रॉस्टबाईट होऊन जाणार. तर काय करायचं, ओला रुमाल करायचा, त्याला एक प्लास्टिकची पिशवीमध्ये टाकायचा आणि तो प्लास्टिकची पिशवीला आईसमध्ये ठेवायचा. म्हणजे फिंगर डायरेक्ट कॉन्टॅक्ट ऑफ आईसमध्ये पण नाही आहे, वेट आहे पण मॅसेटेड नाही आहे. तसं करून पेशंटला पाठवायचं. ॲम्प्युटेड पार्टला तुम्ही क्लॉट लावू शकता, तुम्ही लायगेट करू शकतात, नाहीतर तुम्ही टुनिके लावून पाठवू शकतो. टुनिके पेन पण पेशंट बिना एनेस्थीशियाने 45 मिनिट्स टू 1 hour आरामाने सहन करू शकतो. तर काही हरकत नाही आहे. यू कॅन ऑलवेज सेंड दीज पेशंट्स. Always remember, see, the moment you go to a specialized consultation, not only just with the reimplantation, primary skin grafting, किती ओला असतो, आपण काय करतो, ड्रेसिंग करतो. First day skin grafting करो, first day flap करो. The less the number of times the patient goes in OT, the faster the recovery, the faster the results are. Same day DFL, same day injury, same day skin grafting, patient gone home after 15-20 days. No morbidity, no blood loss, nothing. एवढा खराब जखम आहे, काहीच नाही होत, त्याला काढायचा, लगेच ग्राफ्ट टाकायचं, काहीच नाही होत. 80 to 90% वूंड सेटल होऊन जातात. उलट मी तो म्हणतो मोठा वूंडमध्ये लवकर करा, ब्लड लॉस नाही होत, प्रोटीन लॉस नाही होत, पेशंट जल्दी रिकवरी होतो, इन्फेक्शन नाही होत, सेप्सिस नाही होत. सो ऑल दिस थिंग्स हैव चेंज, concepts have changed, we have to move fast. Even flap coverage in the bones, जिसमें expose orthopedic friends आए, some might not agree, but I usually do primary day, first day flap coverage. काही नाही होत, इन्फेक्शन कमी होऊन जातो, रिस्क कमी होऊन जातो, पेशंट चांगला होऊन जातो. देर आर साइड इफेक्ट ऑल्सो. आई गेट पेशंट फ्रॉम ओवरसीज ऑल्सो. समटाइम्स यू डू मैंने इसका पूरा लेग रिकन्स्ट्रक्ट किया था. वी डिड इट विद अ फ्री फ्लैप, विद अ फ्री फिबुला. ही डिड नॉट हैव अ टीबिया ओनली, बट नाउ व्हाट ही इज डूइंग, he is on a warpath, he is using the valence. So but that is not our prerogative to look into how the patient is doing and what the patient is doing in life. Our job is to treat the patients and do it well. So tendon transfer for nerve injury, this was all about trauma. But you see, where is the plastic? Abhi the spectrum is so wide that I cannot finish off in just 10, 15, 20 minutes time. Simple abrasion, आपण काय करणार, एक क्रीम लावणार, काहीतरी करून सोडून देणार, हे abrasion. But she wanted to become a model. She went for Miss India, although she did not succeed in becoming Miss India, but she went. Within 3 days her result was like this. So a simple abrasion also can be treated by a plastic surgeon in a very different manner. I did derma abrasion to her on the first day. कुठे जखम होता आणि थर्ड डे मध्ये बघा तिला. She was absolutely fine after 10 to 15 days time. So a specialized thing will always make a difference. Now the world is awakening. We have seen trauma, we have seen things, but you have to understand, now people are not restricting themselves to just things. It is now the world wants more. You feel ki periphery मध्ये कोई होत नाही, city मध्ये काय होत नाही. Skin whitening treatment has become so common, dimple creation. Now we are going more towards cosmetic from the trauma ward. I used to do trauma, but abhi equally cosmetic and aesthetic chalta hai. What we were speaking of all those things right now, even if you see even the trauma, so never is the thing that the cosmetic or trauma is not mixed together. You see, now this patient had a penile amputation done due to certain disease process. We made a skin lengthening. Now we did a penile lengthening. Penile lengthening can be done as a cosmetic procedure. It can be done in these trauma or in cancer patients. Look what the result is. Now he is having a normal erection. He is leading a normal life. Absolutely fine. Now almost 1 to 1.5 years. Sometimes they don't give you post-op long-term pictures, so there is a restriction. But see, the things are moving. Now what we are talking of trauma and cosmetic, now all of them are intermingled. There is no single phase where one can be defined as other things. Vaginoplasty, hymenoplasty, their female genital rejuvenation, these have all come into fore. Buttock lift, penile fat grafting, they have all become common. Liposuction, sagadana mahiti hai. I am probably one of the few surgeons in India who must have done more than 24 kgs liposuction as a series. If you look at me, I must have more than almost 50 to 100 patients which are we call more than 10 kgs of liposuctions as mega liposuctions. So mega liposuctions are usually not safe. So I take a lot of precautions in doing them, and I counsel the patients to do it in multiple settings, but still so overseas patients aate hain which require a lot of things to be done. But I had no morbidity and mortality. So we have done, but the things have changed, the world has changed. You see, mommy makeover is possible. What we were talking of is post-pregnancy, 2 babies. Now look at her. Within, this is just talking of 3 to 4 months things. Previously, patients were not willing to share the photographs. Now look at the age, what has happened. I had to hide the patient's face. They are willing to share their photographs. So world is moving on. The cosmetic procedures are moving out. Even 6-pack abs. Doctors, he is one of the famous personalities, I will not name him, did a 6-pack abs. 4 years down the line, he is maintaining himself. He is still happy. He has the same figure what I had given him 10 in those days. The same thing is maintained till now. I still have 5 minutes. I'll just focus on few photographs and then try to think. So plastic surgery as a whole has a lot of impetus to be given, not only in cities but also in periphery. So we should always remember the difference between liposuctions, gynecomastias, abdominoplasties. All of these things can be performed by a plastic surgeon. I will not waste a lot of time at the end of the day, so I'll just fix breast implants, breast reductions. Not only the implants have to be done, even with the fat grafting we can do these things. And all of these patients are my own patients. All of them I have done it, and now they are not more complicated. They are done as a daycare procedures. I do all these procedures at daycare. You come in the morning at 8 o'clock. By 5 o'clock or 6 o'clock, patient wants to go home. I send them by night. You wait for some time. Let the things get settled. You want to have, I want you to see walking. I want you to be happy, and then I want to shift you by 8:30. But they have become a daycare procedures. Patients want to go home by 4:30. All these procedures I do as a daycare. Although these kind of breast reductions I do it at a later stage. Rhinoplasties I do it as a daycare. Lip reduction I do it as a daycare. So blepharoplasties I do it as a daycare procedures. Hair transplant, most of them would be knowing also these people. He is one of the famous, he was one of the orthopedic surgeons in Pune. He doesn't mind even if I tell his name. Got his hair transplant done from me during the COVID times. खाली बैठा था, कहा चलो sir COVID है, चलो मेरा hair transplant कर दो. मैंने कर दिया. Now he does all the marathons. He has done Ironman. He has done plenty of procedures. He still has those. He even made his ponytail. People would be knowing him also very well. Now his whole family has done Ironman. He is roaming around with the hairs. He didn't have a single hair on his forehead. He is doing it. So burns, everything has got a mixture. So my contention in this whole thing is that, see, plastic surgery can offer you a lot of things. You should realize that plastic surgery is not restricted by trauma, or trauma and aesthetic are not mixed up. Someday even the insurance company might have to take up that, because we were talking of insurance right now. So I was tell you, see, aesthetic and trauma are both mixed together. There can be aesthetic involved in each and everything, right from cancer and trauma, everything. But you need to have a realistic expectations. Patients should be guided regarding the realistic things. You have to check up their emotional balance. You have to check up whether whatever they are asking, they are emotionally stable or not. If you feel that they are stable, they understand what you are doing, there are more to give to this world than what we can offer. And should not attempt a lot of plastic surgery procedures at one go. Try to not to mix up too many procedures in one go. If you are doing a chin liposuction, you are doing a, don't try to do breast augmentation, liposuction, abdominoplasty, everything at the same time. You will end up having a lot of complications. Tell the patients, do mega liposuctions ki meri series hai, but I still try to convince the patients not to do a lot of them at the together. Try to stage them if you have time so that you can avoid the complications. You have to understand, make them understand the risk, take a proper consent, tell them that there are pros and cons to each of the procedure, tell them in detail about the whole procedure, but also tell them that this can have a positive, sometimes these cosmetic surgeries are beneficial because they have a positive impact on the emotional and the psychological well-being. Ek model ke liye doing these kind of cosmetic surgeries have got a different impact, but trust me, even a person who is on the reception desk of your hospital, if she feels good about it, thoda sa skin whitening karte hain, thoda sa chemical peel karte hain, they will do a small amount of laser procedures, they will do a small amount of hair removal, and then they feel psychological so beneficial. So trust me, this cosmetic surgery has benefited so many people, not only just in how they look but also psychologically also, because then they begin to have more confidence in themselves and they begin to behave in a different manner. So I feel plastic surgery is the way to look forward, and we should not restrict plastic surgery to a mere plastic surgeon to categorize as a trauma or a aesthetic surgeon. And amalgamation of all the therapies together is the best thing what we can do for you. Ultimately it's the patient's choice what they want, and we should use all these things to our best of the knowledge so that we can give it the right to the patient. So if you have any questions, I will be glad to entertain later on. I think one of our lectures are more pending. We had multiple newspaper publications. These are few of our publications which have been there. Thank you everyone. I try to wrap up fast. Plastic surgery cannot be covered in 20 minutes, and there was no particular topic for me to be speaking on. Say if I have to speak on liposuction, I can give you a lecture for 1 hour on even on liposuction. If I have to speak on microvascular, but my idea was to just show you the clinical picture so that you understand that what a plastic surgeon can do, and instead of referring those cases to orthopedic surgeon, क्या होता है हाथ कट गया हम orthopedic को भेजते हैं. Don't do that. I'm not against orthopedic surgeon, but you have to understand whom it to refer to. So you save a lot of time on the time where the patient wastes his time going to multiple hospitals where they don't have the facilities, and also money, because see, if you get a finger reimplantation, I don't require an orthopedic surgeon. Why do I require? एक KWAR डालते हैं, plastic surgery medical legally authorized. So we put a KWAR, do the reimplantation. Nothing is required. You save on the money for the patient because instead of 2 surgeons, only 1 surgeon is doing. But also try to understand कि aesthetics साथ में linked है. So when we are doing a flap, not only look into कि flap कर दिया, then he has to wear shoes, he has to wear dress. So then the next portion comes over. So all of this thing has to be amalgamated together to bring you the best kind of a results. Thank you very much.
Thank you, sir, for your excellent presentation within a short period of time. Actually, this lecture is finalized when sir has seen my status, and there is a need of time to present a topic like this. Thank you, sir. Now may I request Chandan Shiva sir to felicitate today's guest speaker, Dr. Saxena sir. शेवटी एक लेक्चर आहे ना अजून. अपेक्स अरे तो हे कुठे गेलाय? थांब एक लेक्चर आहे. नितिन नितिन थांबा. नितिन हे कुठं आहे? मिश्रा गेला का? माता नाही ना. विघ्नार कुठलं? विघ्नार 2 विघ्नार आणि 3रा विघ्नार. हो काय झालं? कोण येतं?
Thank you.
हाय गुड इवनिंग, मेरा नाम खालिद मनसबदार है, मैं गो ड्रीम हॉलीडेज से आया हूँ. थैंक यू अनिल सर लास्ट मोमेंट पे एक अपॉर्चुनिटी देने के लिए कि मैं एक्सप्लेन करूँ कुछ. ज़्यादा टाइम नहीं लूँगा आपका क्योंकि ऑलरेडी यहाँ पे बहुत टाइम स्पेंड हो गया है और आई होप आपको मैच वगैरह भी देखना होगा जाके. तो मैं आपको 2 मिनट में एक्सप्लेन कर देता हूँ कि गो ड्रीम हॉलीडेज़ वर्क कैसा करता है. गो ड्रीम हॉलीडेज़ की मेंबरशिप है 5 ईयर से 25 ईयर्स तक, जिसमें एवरी ईयर आप 6 नाइट 7 डेज़ के लिए वेकेशन जा सकते हैं किसी भी 4 मेंबर्स के साथ. ये डोमेस्टिक इंटरनेशनल कहीं पर भी यूज़ कर सकते हैं आप. बेस्ट पार्ट क्या है कि यहाँ पे आपको प्रॉपर्टीज़ के ऑप्शन ज़्यादा मिलते हैं. 6000 से ज़्यादा आपके पास ऑप्शंस रहते हैं जो आप कहीं पर भी यूटिलाइज कर सकते हैं, कश्मीर टू कन्याकुमारी 3, 4, 5 स्टार कैटेगरीज की प्रॉपर्टी में. सेकंड बेस्ट पॉइंट है कि इसमें कोई मेंटेनेंस कॉस्टिंग नहीं है आपको. आप साल भर यूज़ करिए या 10 साल तक मेंबरशिप को वैसे ही सेव करके रखिए. इसमें आपको कोई भी एक्स्ट्रा कॉस्टिंग या मेंटेनेंस कॉस्टिंग नहीं करना. और मेन यूएसबी इसका ये है कि इसमें कोई भी आपको सीजन बैरियर नहीं है. फॉर एग्जाम्पल मार्केट में अलग अलग कंपनीज़ है, वहाँ पे पर्टिकुलर अलग अलग सीजन्स होते हैं. तो यहाँ पे आपको कोई सीजन बैरियर नहीं है. साल में 365 डेज कभी भी जा सकते हैं आप बिफोर 48 आवर्स पहले बुकिंग करा के. और इसमें ना ही आपको ऐसा कोई रिस्ट्रिक्शन है कि सिर्फ आप ही यूज़ कर सकते हैं. आप यूज़ कर सकते हैं, फैमिली मेम्बर यूज़ कर सकते हैं, आपके फ्रेंड्स यूज़ कर सकते हैं, कोई भी यूज़ कर सकते हैं. कैरी फॉरवर्ड का ऑप्शन है, स्प्रेड का ऑप्शन है. आप 2 नाइट्स करके 1 नाइट्स करके भी यूटिलाइज कर सकते हैं या फिर आप ट्रांसफ़र करके भी यूज़ कर सकते हैं. लाइक आप 3 नाइट्स यूज़ कर रहे हैं, आपके फ्रेंड 3 नाइट यूज़ कर. यहाँ पे अगर नियर बाय देखेंगे तो बहुत सारे मेंबर्स हैं. अनिल सर है, राकेश सर है, पंकज गोरे सर है और बहुत सारे मेंबर्स हैं जो यूज़ करें. तो होप सो आपसे रिक्वेस्ट है कि आप भी इसमें इन्वेस्ट करें, मेंबरशिप यूटिलाइज करें फैमिली और फ्रेंड्स के साथ. थैंक यू सो मच.
So thank you all delegates. This is the end of our conference, which has been concluded with great success because of only because of you and you. Now at the end of the session, our 2 chairpersons, Dr. Mahesh Rupnavar and Dr. Raghunandan Pomne, I request another Vigna-Arthite, Dr. Anil Pundesar, to felicitate our 2 chairpersons, Dr. Mahesh and Dr. Raghunandan. एक 2 मिनिट. आपण खरं तर कॉन्फरन्समध्ये आपल्या सगळ्याच कार्यकर्त्यांचा सत्कार करतो. ह्यातले सगळेजण हे स्टेजच्या पुढचे लोक असतात. कोण ऑर्गनायझिंग कमिटीमध्ये असेल, फूड कमिटीमध्ये असेल, ऑर्केस्ट्रामध्ये असेल, स्टॉलमध्ये असेल. परंतु हे जे ऑडिओ व्हिज्युअलचं काम चालू असतं आणि इतक्या चांगल्या पद्धतीनं आपल्याकडं ऑडिओ व्हिज्युअल जे आपल्याला पाहता आलं, ऑनलाईन लिंकद्वारे आपल्या महाराष्ट्रामध्ये सगळीकडे लिंक गेली आणि हे सगळं करणारी जी टीम होती त्या टीमचं खरं तर आपण अतिशय आभारी आहोत. आणि त्याचं उत्तरही म्हणून मी श्री गोपने सर आणि त्यांच्या पत्नी मिसेस गोपने यांना मुद्दाम स्टेजवर बोलवतो आणि आमचे अध्यक्ष डॉक्टर अनिल पुंडे सर यांना विनंती करतो की त्यांनी त्या उभयतांचा सत्कार करावा. श्री गोपने सर आणि मिसेस गोपने. बुके दे. यानंतर मी आपल्याकडचे सर्व मंडप असेल, डेकोरेशन असेल, माईक सिस्टीम असेल की जी 2 दिवस कुठेही आपल्याला अडचण आली नाही, ते अख्तर मोमीन यांना मी पुढं बोलवते आणि त्यांचा सत्कार सेक्रेटरी, ऑर्गनायझिंग सेक्रेटरी सुधीर तांबेले सर यांना विनंती करतो की त्यांनी अख्तरचा सत्कार करायचा आहे. तुझं नाव काय? श्री ना? आडनाव? खंदारे. त्याचबरोबर ऑडिओ व्हिज्युअलचं, कम्प्युटरचं डिजिटलायझेशन असेल, यूट्यूब ऑनलाईन स्ट्रीमिंग असेल, ह्या सगळ्याच गोष्टी ज्यांनी आपल्यासाठी उपलब्ध करून दिल्या आहे ते श्री गौरव गुंजाळ आणि श्री खंदारे या दोघांनी अतिशय टेक्निकली साऊंड अशी सिस्टीम आपल्याकडे उभी केली आणि फार चांगल्या पद्धतीने आपल्याला नॅशनल लेवलची कॉन्फरन्सचा आभास करता आला. त्या दोघांचाही सत्कार आपले अध्यक्ष अनिल पुंडे सर यांनी करावा अशी मी त्यांना विनंती करतो. गोसावी यांनी पण पुढे यायचं, त्यांचाही आपण सत्कार करतोय, कारण हे खरे सतरंजी उचलणारे खरे तर कार्यकर्ते असतात आणि त्या सतरंजी उचलल्यामुळेच आपला कार्यक्रम चांगला होतो आणि त्यांचंही कुठंतरी आपण कौतुक केलं पाहिजे आणि म्हणून गोसावी यांचा पण सत्कार होतोय. आणि सगळ्यात महत्त्वाचं आपण कुठे अरे तुझा फोटो कोणी काढायचा आता आणि आपल्या ह्या सगळ्या स्मृती खूप काळापर्यंत टिकून राहणारे आहेत. त्या संवर्धन जतन करण्याचं काम ज्यानं केलं ते आमचे मित्र. नाही कॅमेरा दे, तू कॅमेरा घ्या, मी मोबाईलमध्ये काढतो. हां कॅमेरा दे की गोसावी कॅमेरा दे त्याला. तर अवधूत पाटील यांनी फोटोग्राफीचं काम अतिशय रिझनेबलमध्ये आपल्याला ते करून दिलेलं आहे आणि तितक्याच तत्परतेने ते आपले उत्कृष्ट फोटो डेव्हलप करून देतील. अशा प्रकारे अतिशय सक्सेसफुल यशस्वीरित्या आपली कॉन्फरन्स ही संपन्न झालेली आहे आणि या सगळ्या कॉन्फरन्सचं श्रेय आपले पॅटर्न डॉक्टर राम आरणकर आणि ऑर्गनायझिंग टीम आणि सर्व IMA मेंबर्स, निमा, होमिओपॅथी या सर्वांच्या सहकार्यामुळे आपल्याला करता आली आणि म्हणून मी सर्वांचं IMAच्या वतीनं, माझ्या वतीनं मी अभिनंदन करतो. हिप हिप हुर्रे, हिप हिप हुर्रे. आता आपले ऑर्गनायझिंग सेक्रेटरी जे चिरतरुण आहेत, अतिशय उत्साही, इन्थुजियाझम असलेले, ते सुधीर तांबिले यांचा वाढदिवस इथं साजरा करतोय. हा वाढदिवस म्हणजेच खरं तर संध्याकाळच्या फेलोशिपचं आवातनं आहे असं समजूया. हो बघितलं की आम्ही.
हॅलो, गेले जवळजवळ 2-3 महिने रूपनवर गेले जवळजवळ 2-3 महिने कॉन्फरन्स आपली गाजत होती. जास्तीत जास्त चांगली कशी करता येईल हा एक मुद्दा होता आणि मेनली फंडिंग हा सुद्धा मुद्दा होता. आपण बऱ्याचशा कॉन्फरन्स बघतो शहरामध्ये किंवा इतरत्र की ज्याच्यामध्ये फंड्स गोळा करण्याच्या दृष्टीने कृपया 2 मिनटं ऐका. कृपया 2 मिनटं ऐका. आपण फंड्स गोळा करण्याच्या दृष्टीने बऱ्याच ठिकाणी पाहतो की वाटेल ती लेक्चर्स त्याच्यामध्ये घुसडली जातात. मला खरोखर आपल्या ब्रँडचा अभिमान वाटतो की सुरुवात केल्यापासून शेवटच्या लेक्चरपर्यंत एकही लेक्चर असं नव्हतं की ज्याच्यामध्ये इंटरेस्ट आला नाही लोकांना किंवा माहिती मिळाली नाही. इट वॉज अ एक्सलंट लेक्चर. ईच अँड एव्हरी लेक्चर वॉज एक्सलंट लेक्चर. याबद्दल मी आपल्या संपूर्ण टीमचं मनपूर्वक अभिनंदन करतो.